alkaline phosphatase and bone health was taught to you in your biochemistry classes, that we very well know. But many other functions of vitamin D have been discovered because almost every single cell in the body has vitamin D receptors. So vitamin D receptors definitely indicate that there's some functioning, as was highlighted. It has got some intranuclear receptors and it works through genes. So it's a numerous function. It has been linked with autoimmune diseases, with many cancers, with infection, with mood disorders, and vitamin D is extremely relevant. And well, I would have slightly different opinion whether we should do regular testing or not. Many times I just prescribe vitamin D. Maybe I'm wrong. Since I know that's extremely prevalent, and since I know that giving up to a certain dose is safe, and sometimes I order the test after somebody has taken that dosage, which is, I consider 600 milligram, 600 international unit, which is equivalent to about 15 milligram. And if that is given over 3 months, I think that may be the time when you test and confirm. Now, the dietary source, and I made a presentation on vitamin D once, and I made some calculations. And if you want to acquire vitamin D, the average requirement to correct the deficiency is 600 milligram. Now you can, I think Professor Javed Akram also mentioned about it, just to make it a little interesting, you need to consume 1,000 liters of cow's milk, 200 kgs of cheese, 15,000 hen eggs, 6.6 liters of cod liver oils. Some people might just like to do this one, but I think very convenient is to take 600,000 international units of vitamin D over 3 months. And another point I would like to make is that what we measure in the laboratory is 25 hydroxycholecalciferol. And what is actually metabolically active in the body, that is 125 dihydroxycholecalciferol. So there is actually also difficult to correlate patient symptom with the vitamin D level which we measure. So I think it's safe to prescribe a certain dose, and then of course you have to advise the patient on maintenance doses. Thank you.
Thank you. Very nice presentation, and of course these guidelines would help the general practitioner and physician at large to supplement. When vitamin D is discussed, I always remember Professor Faisal Masood. Right, I think he started this work on vitamin D some 15 years ago, and he was, I would say, probably the pioneer on vitamin D, and we, two of us and then two in the audience, Somia and Sajid, have a long association with Professor Sab, and I remember that he just mentioned, he conducted a study, I was a bit part of it, that bone tenderness related to be analog to the vitamin D deficiency level, and he at that time he was very fond of that कि पैसे नहीं खर्च करने, सस्ते से सस्ता कोई तरीका ढूंढो उन्होंने कहा, and he developed say a sort of a analog, and from that you can probably estimate that the patient is vitamin D deficient or not. So science has moved forward, and we are now talking of the levels and all that. One comment about fortification. I was just discussing with डॉक्टर अजीज़ दैट हमारे घी के जो डब्बे होते थे उसके ऊपर अभी भी लिखा होता है फैट सॉल्युबल विटामिन है, और घी के डब्बे पर विटामिन ए और डी से भरपूर और फोर्टिफाइड. सो दिस फोर्टिफिकेशन, ये 60s में अयूब खान ने ये रूल शुरू किया था कि विटामिन डी सप्लीमेंटेशन फोर्टिफिकेशन करनी है. सो वी हैव बीन डूइंग दैट, एंड इट कैन बी डन एंड इट कैन बी प्रैक्टिस्ड एज वेल. Then there are 2 or 3 more areas. There is a plenty of data on that vitamin D supplementation improves blood pressure control and antihypertensive medication. So it's supplementation, there's a data over there. Then Dr. Solat is in the audience, there is a plenty of data on improvement in heart failure management. So you add vitamin D and you probably can reduce the heart failure medication, and there is a lot of survival benefits on that as well. In one area I may differ with Professor Aftab. You mentioned about TB, granulomatous disease and all that. But there is a lot of literature saying, and you mentioned in your talk as well, that anti-tuberculous treatment, probably being an enzyme inducer, would lower the level of vitamin D. And there is data that vitamin D supplementation improves the anti-tuberculous treatment response and time to taken to AFB clearance. So this is, and on one side we are saying that we have to be cautious about that in granulomatous we have to give it or we are not to give it. But on the other hand, there is data that those who are on anti-tuberculous treatment, they would require a vitamin D supplementation that would improve their response. So I think vitamin D, as rightly said by Professor Aziz Saab and Javed Saab, that it's in every cell, and you take it at, say, autoimmune disorders to metabolic disorders to bone health and all that. So I'm glad that we have a supplement, the guidelines, and they would definitely help in selecting the right dosage for the right patients. Thank you.
Thanks, Professor Aftab Mohsen, for highlighting this important topic. We all know that the vitamin D is required for a good health, and we need that in order to combat certain diseases in a good manner. We need a vitamin D as well. So I stress that vitamin D supplementation should be from very beginning in the childhood. And we do that, and there were certain brands were very common in Pakistan at that time, like 7C's syrup and soft gel capsule, and we were giving to our children in order to supplement. And other thing that our diet should contain the eggs and the curd to provide the vitamin D. So highlighting the vitamin D, and we all know, being a diabetologist, we see that when we are seeing the type 1 diabetic patient, and when they are not responding to the insulin, or they having a pain, we do supplement with the vitamin D and the calcium. It's very important when you supplement with the vitamin D, you should also supplement with the calcium. The good thing, as the Professor Javed Akram has pointed out, that we hardly see any person with vitamin D intoxication. So it's safe, it can be given, and we should supplement it. Thank you very much.
To let the audience and the chairperson know that how living the document is, then the recommendations would be not to test to begin with, treat everyone, test after 3 months for vitamin D and serum calcium, and I never said not to give in tuberculosis or other diseases, but I said be cautious. So that comes with caution. So, and I am a full supporter that you give it without testing now and test after 3 months. Thank you so much.
I just want to make an announcement that from now onward there will be going to be a parallel activity in another hall also, please, for the audience.
Thank you, sir. This concludes our session on vitamin D. Thank you everyone for joining us.
in Hall B, there is going to be a session on depression and diabetes and advances in emergency medicine. This is Hall B, which is on the downside of the aisle. And in this hall, we will have updates on treatment of HIV and use and abuse of antibiotics. Thank you.
इसमें आउटपुट क्या है? नहीं, आउटपुट दिखा देना।
हो तो जाना चाहिए,
नहीं हो जाएगा।
मेरे लिए ये आसान हो जाएगा अगर मैं
आप ज़रा पकड़ के रखिए जी। ये हॉल ए है ये।
ओके, ये उठाना पड़ेगा आपको।
बस ठीक है।
Arshad. I am Secretary of Karachi Chapter, Pakistan Society of Internal Medicine. Currently, I am working as Assistant Professor in Department of Medicine, Aga Khan University, Karachi. And I am also advisor for PSIS exam of Royal College of Physicians in Edinburgh. So, the topic of today's session is infectious diseases. And I will be, through the whole of this session, I will be moderating this session. And first of all, I would like to invite our chairpersons on stage, Professor Bushra Jamil. Yes. So, Professor Bushra Jamil, she is Professor of Medicine and Infectious Disease. She is President of Medical Microbiology and Infectious Disease Society of Pakistan. She is working as a consultant at Aga Khan University. She served as a member of NCOC and PHEOC, National Institute of Health. She is a custodian and convener for COVID Guidelines Committee in Pakistan. And she is also National Coordinator for TB, HIV and Malaria grants funded by a Global Fund. We all welcome you, Professor Bushra. Thank you for taking time for this conference. Our next speaker is, our next chairperson is Professor Dr. Somia Iqtidar. May I request Dr. Somia to please come on the stage and take your respective seat. So she is, we all know about Dr. Somia. So she is Associate Professor of Medicine at King Edward University, Mayo Hospital, Lahore. She is Adjunct Faculty in Department of Public Health, University of Health Sciences, Lahore, and Visiting Adjunct Faculty Member, Institute of Public Health, Lahore. Dengue Master Trainer, Government of Punjab and WHO. She is Chairperson Dengue Expert Advisory Group. She is General Secretary of Pakistan Society of Internal Medicine. And we all learn a lot from her, being her junior colleagues. And she is also member of Corona Expert Advisory Group and Technical Working Group of Corona Punjab, member Dengue Advisor Board and ISNTD. She had received Governor Award for Extraordinary Contribution in Health Sector in year 2021 and also awarded Women of the Year in Health 2020 by Women Chamber of Commerce and Industry. She was nominated among top 100 women in Global Health Pakistan chapter. Regarding her academic contribution, she has 43 research papers have been published in national and international journals of impact factor. She is primary author of Dengue GCP guidelines and COVID SOPs guideline in 2019. 3 chapters of Congo, Ebola, and Dengue in Kumar and Clark textbook of medicine. Handbook of Dengue for general public. Handbook of Hum or Dengue has represented Pakistan in numerous international forums as invited speaker. She is editor and international advisory board member of McMaster textbook of medicine South Asia edition. And now her papers are increasing, and I was searching on net and she had over 50 papers now. So thank you, Dr. Somia, for accepting this session. Now I would request our third chairperson, Professor Hakim Ali Abro. Please have a seat, sir. So Professor Hakim Ali Abro is he's a professor at Larkana, and I'm sorry, I just forget that. So please give me some time. There are so many things that have been missed. I'm so sorry. Sir, I'm so sorry. I missed some data in my mobile. So, can you please give mic to there?
Shahid Mohtamam Bhutto University Larkana, and I worked as a chairman Department of Medicine and Dean Faculty of Medicine also. I remained Director of Research for 6 years in my university, and presently I am working as the head of unit at my university. Thank you.
Thank you, sir, for your kind gesture, and because last night I take screenshots of all the intro of our respective faculty. And unfortunately, I take a screenshot of his Eid wish that he sent to all of us, that Eid Mubarak, and I just saw, it was my mistake. And सुबह मैंने Professor Bushra से भी सुबह मैंने पूछा, so it was my mistake. Anyways, so we have excellent talks today, and first talk will be on updates on treatment of HIV, and another will be on use and abuse of antibiotics in medical practice. And infectious disease is something that is really close to my heart as well. So I am very glad to moderate this session. So first talk we are fortunate to have Professor Safdar Kamal Pasha. So regarding brief intro of Dr. Safdar Kamal Pasha, he holds master's degree in public health and business administration and fellowship in research and ethics from Global Institute of Public Health at Vanderbilt University, Nashville, Tennessee, US. Dr. Pasha has more than 30 years of experience in public health, including over 20 years of experience in HIV sector. He has worked with various UN and developmental agencies, including Global Fund, UNPFA, UNDP, and currently working with WHO Country Office's National Professional Office for HIV, Viral, Hepatitis and STIs. As a technical advisor for WHO in Pakistan, he supported development and upgradation of national and provincial strategic plan for HIV and hepatitis, in addition to upgradation of national HIV testing and treatment guidelines, national hepatitis B and C treatment guidelines in line with WHO global and regional guidelines in area of HIV, hepatitis and HIV. I humbly request Professor Safdar Kamal Pasha to please come on the stage and teach us. Thank you, sir.
Bismillah ar-Rahman ar-Rahim. With your permission, Chair. I'll be talking about an updates on HIV treatment. So basically, the format for my presentation would be as follows. I'll be talking about the HIV situation in the country, then few slides on WHO global guidance on HIV testing services in terms of new strategies and the approaches, HIV treatment services in terms of the new regimens and its application, then how these guidelines, the global guidance, has been translated into our national guidelines for testing and treatment. I'll be giving you an update of this transition from global to the national level, and then few gaps in the overall service delivery for testing and treatment in the country. Just a few words on the current epidemiological situation of HIV. We have an estimated around 240,000 people living with HIV in the country. There are around 27,000 new infections occurring each year. So this number is increasing every year. In the year 2021, 9,200 new cases were in fact disclosed or recovered. We have till now around 49,584 people who are aware of their status, which means they have been diagnosed and they have been registered, which makes it around 21% of the estimated PLHIV in the country. Out of these 49,000 or 50,000, around 29,626, which around 12%, they are receiving life-saving ART in the country. The ultimate aim for HIV treatment is to get the viral suppression, and just 8% of the total lot of around 29,000 who are on treatment at the moment, they are widely spread. for suppression, we need to have their viral load tested. Around 11,346 got their viral load tested, which is almost 50% of those, less than 50% of those who are in fact on ART. Around 8,600 new cases were started on ART last year. But I mean, you can see from this graph that Pakistan is among 3 countries in Asia Pacific region where the number of new infections are on rise. In fact, we have around 75% increase in number of new infection from 2010 to 2020, and is going beyond that. It's now 79%. Apart from this, we have one of the lowest testing and treatment coverage in the Asia Pacific region. As I just mentioned, the number of new infections, around 27,000 per year, they are on an increase. Next year, it will be more than that if we don't take appropriate action. So this shows you our regional position, how we are as regard the testing and treatment is concerned, the testing and the treatment coverage. Pakistan, unfortunately, at the moment, we are just ahead of Afghanistan, and you can see even the testing coverage of Afghanistan, they have more than what we have in Pakistan, 22 to 26%. But as regarding the treatment coverage, we are at number 2 in the Asia Pacific. So not only the number of new infections are on the rise in the country, but also we are facing the low testing and treatment coverage in the country. Not only this is the situation, but also whosoever is on treatment, those who are on life-saving ART, they face a lot of issues when they get to the treatment centers. There is a lot of attrition or loss to follow-up happening at the level of the ART services delivery. You can see from this graph, there is a huge gap, almost 20,000 gap among those who are registered at the various treatment centers. We have almost around 52 treatment centers all over the country, and those who are actually getting life-saving ARVs or life-saving ART at the treatment centers. So this is something alarming, that having policies of test and treat, and still we are having a lot of people living with HIV who are supposed to be on treatment, but still they are not on treatment, or they are not widely expressed. This is the testing and the treatment cascade. You can see around 240,000, and out of these 240,000, 49,000 are we have been able to reach around 49,594, almost 50,000. They know their status. They have been reached through various programs, service delivery as part of the HIV response. And out of these 29,000, they are on treatment. But the thing is, only just 8% or 6,990, almost 7,000, they are widely expressed, which is the ultimate aim of HIV service delivery in the country, to get those who are infected, to get them on ART and get them widely expressed. And if you look the same cascade in terms of the global commitment of global elimination target of 1990, which is 90%, we need to get to 90% of those living with HIV, so that they know their status, and out of which 90% they should be put on ART and 90% should be widely expressed. So I mean, on the left side of the graph bars, you can see that we are just not only behind, but way behind the global commitment for HIV elimination. The global guidance for HIV, just a few slides on HIV testing services and the global guidance. Basically, the global guidance for HIV testing services is based on 3 principles. One is diversity, simplicity, and demand generation. Diversity means adopting a differentiated service delivery, or rather differentiated testing approaches in terms of moving from facility level to community level, and even adaptation of HIV self-testing. Simplicity means that we should adopt the testing services which are more user-friendly and moving from expensive Western blot, time-consuming testing services to the rapid testing in terms of third test. As I mentioned, 3 different. So each client has to go through 3 rapid tests. Coming to the global guidance on treatment services, and this is just to give you a sense of how the guideline developmental process it takes place within WHO. So whatever the guidelines are developed, it goes through an extensive process of review and evidence generation in terms of data gathered through various modeling and studies, network meta-analysis, surveys, and the data that is routinely generated and collected from the countries and in fact analyzed at the level of at the global level. Then feasibility and the cost study, whether the guidelines they are cost effective and particularly the lower and middle income countries, they can afford it or not. Then values and preferences based on community and healthcare surveys and consultations. So it's a tedious, extensive process through which the guidelines are developed. So over the years, 2 in fact very important development has occurred in the as regarding the HIV policies are concerned. One is treat all policy, which means that those who are confirmed positive, they should be put on treatment immediately, irrespective of their CD4. I'll explain to you in my next slide. Then transition to new regimens, DTG, dolutegravir, which has in fact revolutionized the HIV treatment globally. So we have the last guidelines issued by WHO in late 2019, and as I just mentioned, dolutegravir, DTG, popularly known as DTG, is being recommended for first and second line of treatment for all the populations, including pregnant women and those who are in the childbearing age. To To start with, there have been some studies which indicated some neural tube defects during early pregnancy in use of DTG, but now the empirical data is available, is relatively safe. It can be used by women in childbearing age. This DTG is a drug which is easier to take and has fewer side effect, only one pill a day. It can be combined with the other ARVs. So it's available in fixed dose combination. The studies has indicated that there are lesser chances for drug resistance as compared to the other ARVs. The clinical trials that has been conducted in various countries, they do indicate better safety and efficacy of DTG as compared to efavirenz, which was in fact used on a large basis. Almost 82 low and middle income countries, they have adopted this transition to DTG, and we are also in Pakistan, we are also in a process of transitioning to this DTG based regimens. So these are WHO 2019 guidelines, an update from them. As I mentioned, dolutegravir in combination with nucleoside reverse transcriptase inhibitor NRTI is recommended as preferred first regimen for people living with HIV, both for adults, adolescents, and infants. Efavirenz in low doses in combination with NRTI is recommended as alternate first line regimen. RAL-based regimens may be recommended as an alternative for infants and children if DTG is not available, so it can be used, but this RAL-based regimens, these are preferred first line for the neonates. So these are various combinations you can see. I'm not going to give you details of this, but only I can share that the preferred first line regimen is tenofovir, lamivudine, and dolutegravir. As an alternative, we can have tenofovir, lamivudine, and efavirenz. For the second line of ART, DTG in combination with optimized NRTI backbone may be recommended as a preferred second line if the client, they are not responding to the first line. Then as an alternative, boosted protease inhibitors in combination with optimized NRTI is recommended as a preferred second line regimen if the first one doesn't work or is not available. So these are various combinations, those are available for the second line of ART. Coming to the pediatrics ART optimization and the pediatric drugs. So basically the whole management is based on 4 principles, that is moving from non-NRTI based regimens. Second is introduction of DTG. So DTG is not only recommended for the adult but also for the pediatrics and for in ped regimens as well. Then use of most non-NRTI options and switching over to solid formulation as soon as possible. The recommended first line regimen is for the children is avidine, lamivudine, and raltegravir, and is for the neonates, and for the children is abacavir, lamivudine, and dolutegravir. So for the second and the third line of treatment, both for adult, adolescent, and children, is two NRTIs and lopinavir and rotenavir. So a combination of these regimens in form of a fixed dose combination, and if these doesn't work, then 2 NRTIs and efavirenz, this is recommended. Just some points on or caution for use of these drugs for women. As I mentioned, that during the initial phase when this DTG was introduced, there was some data reported by some countries on neurological or neural tube defects. So subsequent studies have shown it to be quite safe, but still we recommend that during the first trimester of the pregnancy, DTG, if can be avoided, that would be more feasible for the client. Or the client can be advised to have an effective contraception during the period. And just to sum up, DTG has been preferred first line for every living with HIV with approved dosing. Efavirenz 400 milligrams or in lower doses is recommended as alternative. Boosted protease inhibitors alternative RAL can be considered an alternative to lopinavir and ritonavir, the alternative drugs, those are available. But for the neonates, the RAL is recommended. Apps are available where all these guidelines are available. So just a few slides on what actually we are implementing in the country. As I mentioned in my previous slide, that we are following HIV test and treat strategy. That is, ART should be initiated in all the individual regardless of their Cd4 count. So this is what we also call treat all. So immediately who are diagnosed or discovered with, of course, after going through 3 tests, so they should be immediately put on the treatment, preferably on the first visit. But some of the client, when they come to the treatment center for the first time, they need to have adequate social support. So the combinations that are being applied in the country at the moment, it consists of 2 nucleoside reverse transcript inhibitors and RTIs, plus an integrase strand transfer inhibitor INSTI, and the regimen that is being followed, the combination that is being followed is consists of tenofovir, lamivudine, and dolutegravir, DTG. Then various alternatives are also available in the country, and in fact there are 6 drugs: lamivudine, efavirenz, tenofovir, abacavir, and DTG. These various combinations are also available in the country. For the pediatric, either to start with or to transition, as the formulation is based on weight bands. For more than 30 kg is the same as the adult one, which is tenofovir, lamivudine, and DTG. For weight band of 20 to 30, the tenofovir is replaced with abacavir. For 5 to 20 kg, the same combination, we add the LPV is added. But for weight band up to 5 kg, the combination is slightly different, and nevirapine is added to the combination. For monitoring of the client, the treatment monitoring, in fact, there are 2 type of monitoring. One is the immunological monitoring, the other is virological monitoring. So we recommend the virological recommended, that is the viral load testing of all the client on ART at least twice a year. As regard the Cd4 count, the immunological monitoring, in adults, the Cd4 count is not required, or it need not to be repeated if the Cd4 count is more than 350. But if a opportunistic infection is suspected, the Cd4 count, they give an idea about it, so it can be repeated. But for the children, the cutoff is more than 750. So if the Cd4 count is more than 750, so no need to repeat, except when it is required to determine the safety of viral live vaccine suspected of OIs. But in each case, reinforcement of adherence is very much required. Then treatment failure. Second line treatment for adults and children, it consists of 2 NRTIs and ritonavir based protease inhibitor. So again, dolutegravir, DTG has been recommended as the second line. Apart from them, in the second line regimen, tenofovir should be switched to zidovudine, and vice versa, and lamivudine should be continued. A few words on advanced HIV disease. We define advanced HIV disease as 5 years. Is defined as Cd4 count of less than 200, or WHO clinical staging 3 and 4 at the time of the presentation. So there is a package of services available to manage the advanced HIV disease, which includes the management of OIs, rapid ART initiation, if not already started, intensified adherence, interventions in sport, and counseling on continuation of the treatment. And what we recommend is there should be a referral pathway or mechanism should be available, so that those with the advanced disease, they should be immediately referred to a specialized center for management. This is a very important slide, and just to show you the air regimen data, that is data from ARV regimens that is being in practice in the country at the moment. So for the adults, you can see that the almost 70% at the moment they are getting dolutegravir, lamivudine, and tenofovir as first line. So DTG has been transitioned in almost over 70% in adults in Pakistan. But when it comes to pediatric ARVs, DTG is a low priority, and the most commonly prescribed regimen is nevirapine, lamivudine, and zidovudine. So just summarizing, for treat-all, as I mentioned, the treat-all strategy, which in fact WHO came up in 2015. So we have a huge gap as regards the treat-all strategies concerned. Okay, thank you. So we have a huge gap for it. Around 98% of our PLHIV who are in fact on treatment, they are getting first line, and majority, in fact, DTG is in fact in adults in almost 70%. My last slide. But the major gap that we are facing at the moment is a loss to follow-up, a great loss to follow-up among ART clients who are registered and getting ART services at the treatment services. Relatively, the viral load monitoring is quite a bit of concern. We don't have a system available in the country to monitor the HIV drug resistance, and we hope that this system, the surveillance system for HIV DR, will be established in the country very soon. We don't have a system for pharmacovigilance for ARVs. In fact, the other phenomena, which is in fact, though we have more than 50 treatment centers in the country, but still the treatment coverage is low because we don't have a decentralized or differentiated service delivery services available for the treatment in the country. I mean, this is this is a concern in a sense that we have the treatment centers available in the country in the major cities, but down the service delivery, we don't have the services for HIV or even for hepatitis available. Hepatitis to some extent is available, but for HIV is confined to the major cities and to urban cities only. But the lower down in the primary healthcare, we don't have the facility for HIV available. We don't have PPT-CT services available with all the treatment centers, and if you compare the PPT-CT sites with the ART sites, so these are very small numbers. Though WHO has recommended pre-prophylaxis for HIV prevention PrEP, but still it hasn't been implemented in the country as yet. Formally it has been not yet implemented. So I'll stop here, and if there will be any question, I'll be happy to respond. Thank you so much.
Assalamu alaikum everyone. I'm just going to quickly replace Dr. Enan. We also have parallel sessions going on, so he just was needed at the other session. Thank you very much, sir, for your elaborate talk. I'm going to invite our next speaker. She is Dr. Farheen, and she's currently head of microbiology department, ESA Laboratories, Karachi. She has previously been head of microbiology and infection control at Al Khidmat Foundation, and she's also been the head of infection and lab control at the Lady Dufferin Hospital. And ma'am, please join us on stage. Thank you.
Antimicrobials are the pillars of the modern medicines and have contributed to the progress of the healthcare during the last half century. Antimicrobial resistance is a global public health concern and is extensively implicated and is extensively associated with the health and economic implications. Dear faculty and colleagues, I'm Dr. Farheen Mubashir from Dr. Isa Laboratory and Diagnostics, and I will be talking about the use and abuse of antibiotics in medical practice. I have no conflict of interest to disclose. Both the use of the antibiotics and the resulting resistance to them are increasing. In the last 15 years, our global antibiotic consumptions grew 40%. The number of deaths from antibiotic-resistant infections in the United States alone doubled in the last 6 years. And globally, 73% of antibiotics are used to fatten the cattle, pigs, and poultry for the human consumptions. So what is the antibiotic resistance and how it develops? The genes can be inherited from the relatives or can be acquired through the mobile genetic elements such as the plasmids. And this is the horizontal gene transfer can allow the antibiotic resistance to be transferred among the different species of the bacteria. The resistance can also occur spontaneously through mutations. Genetic mutations causes the drug resistance. The non-resistant bacteria, if exist, and if there is mutations in the DNA, then a few of these bacteria will mutate. In the presence of the drug, only the drug-resistant bacteria survive, and this is the antibiotic selective pressure. And the drug-resistant bacteria then multiply and thrive. The gene transfer can also facilitate the spread of the drug resistance. The bacteria that have the drug-resistant DNA, it may transfer a copy of these genes to other bacteria. Then the non-resistant bacteria become resistant in the presence of the drugs, and only the resistant bacteria survive, multiply, and thrive. Antibiotic resistance is also accelerated by the antibiotic selection pressure, and mainly the population of the resistant bacteria will survive. Implications. According to the CDC, the Center for the Disease Control and the Prevention, United States alone, antibiotic resistance could add about $1,400 to the hospital bill for treating the patient with any bacterial infection. And this additional cost could go up significantly to more than $2 billion every year. High costs associated with expensive and intensive treatment and escalation in the resources utilization are the direct monetary effects of AMR on the healthcare. AMR could cost from $300 billion to more than $1 trillion annually by 2050 worldwide. Treating the patient with resistant infection infections may need the longer hospitalization stay as well as a more ICU and isolation beds in order to prevent the spread of the infection. Nosocomial outbreak with resistant pathogens, it may result in the closure of the wing of the hospital and the cancellation of the surgeries costing the hospital money. This table is taken from the article. It shows a mortality rate by 2050 due to AMR will be significantly high among all the continents. Economic perspective, the CDC estimated that the cost of the antimicrobial resistance is $55 billion every year in the United States, $20 billion for healthcare and $35 billion for the loss of productivity. MDR TB alone could cost the world $16.7 trillion by 2050, loss of the labor and premature deaths. When infections are no longer be treated by the first-line antibiotics, then what happens? The more expensive antibiotics medicines must be used. Longer duration of the illness and the treatment, often at the hospital, increase the healthcare costs as well as economic burden on the families and the societies. Antibiotic resistance is putting the achievements of the modern medicines at risk. Transplantations, chemotherapy, and the surgeries such as cesarean sections becomes much more dangerous without the effective antibiotics for the prevention treatment of the infections. Current challenges of the resistant organisms like MRSA, VRE, CRE, XDR, Salmonella typhi, and MDR Acinetobacter, and other nosocomial infections. Outbreak also occur in the hospital like Burkholderia cepacia and others. MRSA, the control of MRSA remains a major healthcare challenge because this strain of the Staph aureus is resistant to all beta-lactam antibiotics, and very few and the limited options are available to treat this infection. The last decade of 20th century saw the emergence of the infections due to novel clones of the MRSA in community setting unrelated to the healthcare. MRSA predominantly causes SSTI, varying severity, sometimes causes fatal CA pneumonia, community acquired, and severe bone and joint infections. Infection control practices are most effective to control the MRSA by screening, contact precautions, decolonization of the patient with MRSA, and in order to reduce a cross-infection by eradicating or reduce the bacterial load on MRSA carrier. MRSA is basically the nasal carrier, and it can be decolonized by the mupirocin drops. Hygiene is the most important, considered to be the most effective infection control intervention. These are the references. VRE, the vancomycin-resistant Enterococcus. The article is the ongoing challenge of the vancomycin-resistant Enterococcus faecium and Enterococcus faecalis. This analysis of the bloodstream infection, and this article was published in Emerging Microbes and Infections in 2020, and they concluded that the local and the regional authorities should intensify the efforts directed at diagnostic and antimicrobial stewardship. For vancomycin, at all the last exhaust of the drugs for the management of the VRE, particularly for the hospitalized elderly patients. CRE is the carbapenem-resistant Enterobacteriaceae, and it includes the drug the imipenem and the meropenem, ertapenem. And CRE constitute a major threat to healthcare system because these infections are difficult to treat and are commonly associated with a high mortality. Infections caused by the CRE, such as pneumonia and the BSI, are difficult to treat and are often associated with a high mortality. CRE become endemic in several healthcare institutions across the world. Importance of the new antibiotic against CRE is required. Antibiotic stewardship is essential for the appropriate and the rational use of the existing antibiotics. It is also plausible that interruption in the health services and supplies disruption caused by the COVID-19 pandemic could result in the undetected propagation of the CRE. According to the most recent report of the CDC on antibiotic resistance in the US, there were 13,100 estimated CRE infection in hospitalized patients in 2017, with an estimated 1,100 deaths, CDC drug-resistant report of 2019. Treatment of CRE depends on the site of infection, patient's clinical condition, isolated pathogens, and the resistance profile. Treatment has been based on the combination regime polymyxins, tigecycline, fosfomycin, or the double carbapenem, although resistance to these agents has been reported. CRE is the rapid emergence of asymptomatic infections in form of bacterial colonization also. So what are the causes? Inadequate diagnostic, very important. And these situations contribute to selective pressure and accelerate antimicrobial resistance. Inappropriate use. The patient may self-medicate or inadequate use of the antibiotics. The use of the antimicrobials, even when used appropriate, they creates a selective pressure for the resistant organism. Poor absorption of the antibiotics and drug-to-drug interaction. Hospital-acquired infections, ICU-induced infections, and the extensive use of the antimicrobials and close contact among the sick patients creates a fertile environment for the spread of antimicrobial resistance germs. Scientists also believe that the practice of adding the antibiotics to agriculture feed promote the drug resistance. More than half of the antibiotics produced in the United States are used for the agriculture purpose. This is the review article, Antibiotic Use in the Agriculture and its Consequential Resistance and Environmental. This review article was published in a journal Molecule, and they conclude that the continuous surveillance of the antibiotic resistant profiles of bacterial pathogens which are obtained from the humans, animals, food and other of public and environmental significance be implemented because of the high burden of infectious diseases. So how to prevent the antimicrobial resistance and the responsibilities of the doctors, healthcare workers, healthcare industry, patients, and agriculture industry and the policymaker. The responsibilities of a doctor is to maintain the hand hygiene is very important. Hand hygiene is important to combat for any of the infection. Hygiene, instrumentation, hygiene, and environmental. Prescribe the antibiotic when indicated. Type, dose, frequency, and the duration. Report the antibiotic resistance to the surveillance team, educating the patient how to take the antibiotic correctly, and preventing the infections, vaccination, hand washing, safe sex, and covering the nose and mouth when sneezing. The role of the healthcare industry: invest in the research and development of new antibiotics, vaccines, diagnostics, and other tools. Role of the patient: only use the antibiotic when prescribed by the certified health professionals. Never demand antibiotic if your health worker says you don't need them. Always follow your health worker advice when using the antibiotics. Never share or use the leftover antibiotics. These are very important points. Prevent the infection by regularly washing the hands, preparing the food hygienically. WHO 5 keys to safer food. Keep the food at the safe temperature, use the safe water, raw materials, and choose a food that have been produced without the use of the antibiotics. Antibiotics in agriculture: not use the antibiotics for the growth promotion or to prevent the disease in the healthy animals. Vaccinate the animals to reduce the need for antibiotic and use alternatives to antibiotics when available. Promote and apply the good practice at all the steps of the production and processing of the food, and improve the biosecurity on farms. The role of the policymaker: no antibiotic without prescription. Doctors should follow the guidelines of infection control, educate the population, ensure a robust national action plan to tackle the antibiotic resistance, improve the surveillance of the antibiotic resistant infections, and the new drugs should be introduced replaced by ineffective ones. Pharmaceutical collaboration with the fund providers, universities, and the government help in the new research. The GLAS is a global antimicrobial resistance surveillance system. The WHO supports the approach to the collection, analysis, and sharing of the data related to the antimicrobial resistance at a global level to inform the decision making, drive the local, national, and regional action. This is a very important slide, the core elements of the antibiotic stewardship, starting from the enhancing infection prevention and the control, controlling the source of infection, prescribe the antibiotics when they are truly needed, prescribe the appropriate antibiotic with adequate dosages, using the shortest duration of antibiotic based on evidence, reassess the treatment when culture results are available, supporting the surveillance of AMR and HAI and monitoring of the antibiotic consumptions, educating of the staff, supporting an interdisciplinary approach. WHO Global Action Plan, tackling the antibiotic resistance is a high priority for the WHO. The Global Action Plan on Antimicrobial Resistance was endorsed at World Health Assembly in May 2015. And this plan aims to ensure the prevention and treatment of infectious diseases with the safe and effective medicines. This plan on antimicrobial resistance has the 5 strategic objectives to improve the awareness and understanding of the antimicrobial resistance, to strengthen the surveillance and the research, to reduce the incidence of infection, and to optimize the use of antimicrobial medicines, and to ensure the sustainable investment in countering antimicrobial resistance. WHO, the World Antimicrobial Awareness Week, held annually since 2019. This is a global campaign that aims to increase the awareness of antimicrobial resistance worldwide. They include the antibiotics, antivirals, antifungals, and antiprotozoa. It takes place every year from 18 to 24 November. The slogan antibiotics changed to antimicrobials in 2020 to reflect the broadening scope of drug-resistant infections. Joint initiatives of WHO and drugs for neglected diseases, these are basically the parasitic diseases. Initiative encourage research and development through the public-private partnerships. And by 2023, the partnership aims to develop and deliver up to the 4 new treatments. The United Nations Secretary General has established IACG to improve the coordination between the international organization and also to ensure the effective global action against this threat to health security. Thank you so much, respected faculty and colleagues.
Thank you very much, Dr. Farheen. So we're going to take questions for both the talks, if there are any from the audience, before we move on to the chairpersons for their comments. So, comments only? Okay, right. So in view of, running late, I will just request our very worthy chairpersons to please make a few comments.
Thank you very much. It was a wonderful session. Both of the speakers had a very good talk on very, very essential topics. So regarding the HIV, there was an outbreak of HIV in my hometown in 2019, and that created a very havoc in the city. That was in the Ratwadero in 2019, and we experienced around 2,000 cases over a period of 2 to 3 months. And that was a very crucial situation there. So it was a very wonderful presentation on treatment of HIV. So we hope that we can control this disease, because this is a taboo also in the society. Second, regarding the antibiotic resistance, yes, it is a problem. It is a very serious problem nowadays. What we collected just in our ward, we collected around 4,000 just urine CS reports from the different laboratories, just to observe what is the pattern of drug sensitivity. And surprisingly, what we found that most of the antibiotics were resistant in a simple case of UTI. So the reason behind that, Dr. Saab described very elaborately, that we are using our public is using antibiotics just like multivitamins in an appropriate dose in complete period. Just like agar kisi ko bhi, if they are having just any symptom, they take a single tablet a day. If a dosage is 3 times, they are taking single tablet. So this will create a problem and increase the resistance of antibiotics. and we are very fearful because in last 10 years we are having only few new antibiotics, and we have developed lot of resistance from the already available antibiotics. So policy makers should think on this point to have some regulations for antibiotic prescription and proper ways. Otherwise, it is we are fearful that if this scenario will continue, we will have a lot of problems in the future for treating infectious diseases. Thank you very much.
Thank you very much. Two brilliant talks on two very important topics which have become a public health issue in Pakistan in particular. I have a comment and a question from Dr. Safdar Kamal Pasha regarding availability of HIV drugs in the open market. I don't know about the rest of the Pakistan, but when you talk about Punjab, the antiretroviral therapy that we offer in HIV is not available in the market. It's always available on the HIV centers, and still we have that stigma attached to HIV where people are reluctant to get themselves registered in the HIV center. So what are we doing? I've talked at multiple times with UNAIDS, with WHO, with the Punjab AIDS Control Punjab about the availability of these drugs in the open market for the general public, so a consultant or a physician can prescribe them just like hepatitis C or hepatitis V treatment and offer and do not miss out on the patients. One, that. And secondly, the figures that you quoted about 26,000 annual cases of HIV in Pakistan, I think they are grossly underreported, because we are seeing a huge number of patients in our outpatient and inpatient setting for the last couple of years now. This was a rarity in previous years where would you hardly see a patient, one or two patients in a month, but in a regular admission rate that I see in my hospital, which is the Mayo Hospital, one of the biggest tertiary care hospitals of Punjab, you see an HIV case on a daily basis. So this figure of 26,000 new cases every year seems to be very underreported. So sir, first your answer, and then I will talk about the antibiotic stewardship.
Quite well that the ARVs, in fact, they are procured through PPM mechanism, and all the funding for this is being provided by the Global Fund. So Global Fund is in fact helping the government of Pakistan and the provincial Department of Health in procuring ARV. The Department of Health at the moment, they are not procuring ARVs, though they have funds available with them in form of PC1s. The second thing is that is quite important, that ARVs are not produced or developed or manufactured within the country. It has to be imported from other countries. So, but the thing is, at the moment, as I mentioned in my there are around 27,000 who are in fact on treatment. So we don't have a very in fact, it should have been more than 50,000 who should have been getting ART. But due to stigma and the other factors, there are still clients who have been confirmed positive, but they are not getting to the treatment centers. That's the dilemma that we are facing at the moment. The data that I have just shared with you is based on two facts. One is based on estimation modeling. We call it estimation projection. So that's how it is being done all over the world, or globally we do it. The second data related to the service delivery is from ART MIS. That's the only information we have available with us, and it's the data from the government of Pakistan and the Department of Health.
Okay. Thank you, sir. Dr. Farheen, brilliant talk. Another topic which is very close to my heart because it has become a havoc, this antibiotic resistance and the abuse of the antibiotics and other drugs, and especially in the COVID area when we know that COVID was a viral disease and we were treating right, left and center everybody with an antibiotic. I would just recommend to the audience that there is a meta-analysis published in 2021 by BMC about the antimicrobial resistance in Pakistan and the burden of antimicrobial resistance in Pakistan. It's a very nice paper, everybody should go through that, which shows that about 79% patients have antimicrobial resistance and 93.1% patients had resistance to third generation cephalosporins, 93.7%, in bloodstream infections on culture, and 100% to fluoroquinolones on salmonella. So these are the three very, very alarming figures, and we must, from the Forum of Pakistan Society of Internal Medicine, must propagate this message of starting an antibiotic stewardship program and providing guidelines for empirical antibiotic therapy and promote that we should be prescribing antibiotics according to the culture and sensitivity. Thank you.
Thank you very much. Regarding the HIV situation in Pakistan, there is no lack of funding. What we lack is able leadership and coordination mechanism. So to make any program successful, all the diagnoses should be linked with reporting and the loop should be complete, because adherence is one of the key performance indicators which tell you how successful your implementation program is. So there is funding, drugs are available, diagnostic tests are available, but the people who are supposed to run the program successfully probably lack the motivation to do it. They are not trained, so we don't have right people for the job. Regarding resistance testing for HIV, again we have funding. We had a huge opportunity last year and we got funding from Global Fund for whole genome sequencing, and that could have been channeled to look for resistance in HIV, but the funds are available. There is nobody to take up the project and to actually initiate resistance testing in HIV. So our problem is with leadership and trained personnel to run the programs effectively. And the same holds true for TB as well. So linking diagnosis with reporting is the key. So easy availability in market should actually be prohibited. So anyone who's managing HIV or TB should be reporting it to the government, and they should have this free availability of drugs which can be used for treatment of patients. Regarding AMR, Dr. Somia has very rightly mentioned, we are in a nightmare situation. So we very commonly encounter hospitalized patients where we don't have any effective antibiotic available, and then we have to resort to prolonged courses of empiric treatment, which actually further perpetuates the problem of AMR. Thank you very much.
Thank you very much. I'd like to conclude this session and thank the speakers as well as the chairpersons. As we move on to the next session, which is the Cardio-Metabolic Symposium, I'll just take a quick second to introduce myself. My name is Dr. Wafa Kaisar, and I'm serving as Assistant Professor at Rashid Latif Medical College, Lahore, and I'm also the Joint Secretary, Pakistan Society of Internal Medicine. We've begun our day 2 with great enthusiasm. Today we've got parallel sessions throughout in Hall A and B both, and so an estimated 47 million people in the US are living with cardiometabolic disorders, putting them at an increased risk of developing heart disease or type 2 diabetes. The situation in lower to middle income class countries is even worse. Cardiometabolic disorders represent a cluster of interrelated risk factors, primarily hypertension, elevated fasting blood sugar, right, elevated fasting blood sugar, dyslipidemias, abdominal obesity, and elevated triglycerides. Obesity is also associated with a range of disorders that might cause gastroesophageal reflux disease, such as increased abdominal pressure, impaired gastric emptying, and increased esophageal acid exposure. Before we dwell any further into this, I'd like to introduce our chairpersons for today and would request them to please join us on stage. I would welcome Professor Shehbaz Qureshi. Sir, thank you for taking out the time. He's Professor of Cardiology, Consultant Interventional Cardiologist at the Heart Clinic, Islamabad. He's also the President, Pakistan Aspirin Foundation. I'll also welcome Professor Shahab Abid. He's Professor at Department of Medicine, Aga Khan University Hospital, Karachi. He's member of Executive Council of Asia Pacific Association Study of Liver. He's an active member of several national and international professional organizations, notably ACG and ANMS. He's a certified examiner and assessor of fellowship examination of CPSP for medicine. I will also welcome Professor Tahir Saghir, our third chairperson for today. He's Professor of Cardiology at NICVD Karachi, currently acting as Director of Clinical Research Department and Associate Director of Cardiac Cath and Intervention Department at NICVD. The Clinical Research Department has conducted several successful researches under his leadership. Acid-related disorders is a broad term that's used to describe a whole range of conditions from the Zollinger-Ellison syndrome, where acid is entirely responsible for the problems, to aerophagia and motility type non-ulcer dyspepsia, where acid plays little role in the dyspeptic symptoms. Careful evaluation of the patient's symptoms is required to establish the basis, and then careful selection for effective treatment may be needed. I'll request these symptoms are the basis for advising on the most effective management, and as medicine is ever evolving in nature, I'll request our first speaker, Professor Dr. Lubna Kamani, to present her talk on a new era for the treatment of acid-related diseases. Professor Lubna is President, Park GI and Liver Disease Society. She is Publication Secretary for PSG, Co-Chair Women in Hepatology Forum of South Asian Association of Study of Liver. She is a Professor of Gastroenterology, Consultant Gastroenterologist and Hepatologist at Liaquat National Hospital and Medical College, Karachi. Ma'am, thank you for taking out the time. Please join us and take over.
Thank you very much for the kind invitation, and I would like to thank the organizer for giving me this opportunity for presentation in this prestigious conference. Today I was told to basically present about vonoprazan because it's a new treatment and in acid peptic disease, and basically most of the doctors here does not know basically how to write this medication. So vonoprazan is a first-class potassium competitive acid blocker that has been available in the market in Japan. Basically, it was launched in Japan, and initial studies were done in Japan way back in 2015. And then this vonoprazan marketed in South Asian countries in Pakistan last year. It's a reversible potassium competitive inhibitor. It's more potent, almost more than 300 times potent in acid suppression as compared to conventional proton pump inhibitor like lansoprazole, and it's a reversible potassium competitive inhibitor. So the dosing is usually we give it 20 milligram once a day for gastric ulcers and duodenal ulcers. We can give in 10 milligram in basically for prevention of reflux esophagitis, and if symptoms are not better, we can increase it to 20 milligrams per day. And 10 milligrams daily we can also give in prevention of in those patients who are prone to get gastric ulcers and duodenal ulcers, especially those who are on non-steroidal anti-inflammatory and low-dose aspirin. And recently, a couple of days ago, on 4th May, the FDA has approved vonoprazan for Helicobacter treatment because we are seeing more resistant cases for Helicobacter because of less acid suppression, because of antimicrobial resistance, as the previous speakers talk about regarding the antimicrobial resistance. So we are also seeing this in Helicobacter treatment. So the dose is in combination with amoxicillin and clarithromycin or amoxicillin. It is for 14 days. Sorry, there's a misprint. It's not for 7 days, it's for 14 days. So regarding the pharmacokinetics, I won't be going detail into the pharmacokinetics, but if we compare the pharmacokinetics of vonoprazan with other PPI basically. So you can see that the half-life of vonoprazan is much longer as compared to other conventional medications. So what's the mechanism of action? Mechanism of action is basically gastric parietal cells. It's a competitive enzyme inhibitor. It has long half-life. It is more stable in acid. It's high accumulation in canaliculus and very slow dissociation rate. And it has 24-hour potency, so you can give it once daily basically. Except in Helicobacter treatment where you have to give twice daily, 20 milligram. So what's the uniqueness basically of this drug? Why to give this drug? It is more potent. It can be given once daily basically, and it is accumulates in the resting gastric gland is higher than an actively secreting gland. And one thing which you see is basically, it's not working. Okay, I'll show it. So if you see that, if you start on day 1, okay, so if you start on day 1, the response will continue to increase till day 7. So it is not just equivalent to conventional PPI where the response almost stays same or with placebo, but the response will continue to rise from day 1 to day 7. And it has a long-lasting acid suppression as well. Another advantage is it is not related with meal time. So you can give it with meals, before meals or after meals. And again, the blood concentration remains the same as compared to other conventional PPI in which we give before meals, the omeprazole. What about the erosive esophagitis? If you check all erosive esophagitis patients, and this is a study in which you compare with lansoprazole, basically, the vonoprazan was better as compared to lansoprazole in all classes of erosive esophagitis. So what about the recurrence? And as you see that if we see that the recurrence of esophageal erosive esophagitis as compared to lansoprazole, vonoprazan was better. And if you compare the dosage, 20 milligram, 10 milligram, the 20 milligram was even better as compared to 10 milligram dosage. So the nighttime and the daytime heartburn. Usually when you give proton pump inhibitor once daily, the patient often said that we have nighttime reflux. Initially in olden days when I was a fellow or a junior consultant, we used to give H2 receptor blocker for nighttime reflux. But now it is banned. We don't get, ranitidine anymore for the nighttime reflux symptoms relief because it was linked to some oncogenic mutations, and there was increase in cancer-related deaths with H2 receptor blocker. So if we compare vonoprazan with lansoprazole, the daytime and nighttime heartburn was much better and much relief as compared to conventional PPI. So this was a study which was done in Japan, in which there was efficacy of vonoprazan for gastroesophageal reflux symptoms in patients with proton pump inhibitor resistant non-erosive. And what they concluded was that changing the medicine from PPI to vonoprazan was significantly associated with improvement in GERD symptoms. So what I'm doing is those patients who are on PPI for long period of time, and now we have changed PPI to various classes, still having symptoms. So the clinical evidence of H. pylori, if you see in all patients, vonoprazan do better in H. pylori eradication as compared to PPI, lansoprazole, even in resistance cases. And the vonoprazan can be given as a dual therapy, which means we need to give vonoprazan twice daily with amoxicillin, or we can give a triple therapy in which we can give vonoprazan, amoxicillin and clarithromycin. So those patients who cannot, tolerate clarithromycin can be given dual therapy, and the response rate is similar. So the FDA approved just a couple of days ago, so this was a big, news in GI community, because after a long time, another acid suppression is now is available in the market, and we have something to write, something to give benefit to the patient. especially those who are resistant. This was a recent study which was done by one of our colleague, Dr. Professor Fayaz, locally, and it was recently published on vonoprazan, and it was a randomized controlled trial on vonoprazan and amoxicillin dual therapy versus standard triple therapy which we are using these days with proton pump inhibitor. And what they saw was that the results were comparable. The H. pylori eradications were comparable, and in fact the side effects was lower in vonoprazan group as compared to conventional PPI group with triple therapy. So what about the special population? Because when we are sitting in the clinic, you have patients with renal failure, you have patients, pregnant patients, liver disease patients. So you can use vonoprazan in patients who have renal dysfunction, but you have to use it with care and you have to do close monitoring. And also you can give it in liver disease patient, but if the patient has acute hepatitis or if patient has started having hepatitis, then you need to stop this immediately. Vonoprazan can be used in elderly patients, but not in patients less than 18 years of age, so still it is not approved in pediatric population. Vonoprazan is not indicated in pregnancy or should not give in patients who are lactating, so we need to avoid that. Keep that in mind. Before prescribing vonoprazan in young female, married female, you need to make sure that they are not pregnant. And a drug is basically metabolized by hepatic, CYP3/4A. So what questions to ask yourself? Are there any unmet medical needs that require addressing? Why do we need a new drug? We have many PPI basically treatments. And what are the limitations of PPI? The treatment rate, the duration of symptomatic relief, are there any challenges associated with patient compliance, and how to treat PPI resistant or refractory cases? Basically, this medication comes when the patient is not responding or they are on PPI for last many years, and now the symptoms have relapsed. So the current management basically of acid peptic disease is long, but to summarize, it's lifestyle modification. This is very important that you have to, if there is reflux, you have to ask the patient to pop up their head end, and the last meal should be 3 hours before the bedtime. And weight loss is the key basically, because if they have large bellies, then the reflux problem will stay. And then there are other medical, that there are multiple proton pump inhibitors, then there are surgical basically, fundoplication or magnetic ring, and there are now various endoluminal therapies which are available worldwide, especially in US. There are transoral incisionless fundoplicator, Medicus ultrasonic surgical endostapler, and the most famous is the Strata device, which is a radio frequency energy delivery to lower esophageal sphincter. So approximately 10 to 40% of the patient with GERD fail to respond symptomatically either partially or completely to PPI. The proportion of patient with persistent troublesome symptoms despite one daily use PPI is 32% of heartburn and 28% of regurgitation as reported by randomized control trial. Meta-analysis have found that more than 25% of patients fail to respond to PPI therapy with erosive esophagitis and NERD. So what are the challenges associated with PPI? It requires an acidic environment for activation in which PPI are unstable as well. The effects of PPI influenced by cytochrome P450 polymorphism. They provide maximal acid suppression after 3 to 5 days of dosing. For optimal efficacy, PPI should be taken at least 30 minutes before breakfast, whereas vonoprazan you can give it even after meal. It's not related with meal time. Reflux symptoms of GERD are not sufficiently relief after first dose of PPI in 2/3 of patients because of slow onset of action, and in vonoprazan it's rapid onset of action, plus it's a 24-hour coverage for the acid suppression. Acid inhibition during the nocturnal period is weaker, and approximately 25%, as I've said, they experience symptoms at night basically, with one morning dose. So you have to give PPI in double dose basically. So you can have lifestyle modification. You need to increase the compliance. You have to call them periodically. You have to ensure them that they are taking proper dosing time, duration of therapy. You have to split or double the PPI dose and switch to another PPI if the patient is not responding. So in patient-related issue is with non-compliance to treatment, because these are long-term treatments. So patients usually sometimes take it, or you take it with on-demand basis. If they need to take it for twice a week or less than twice a week, then we can tell them to take on demand. In one study, only 46% of patients dosed for PPI optimally, and 54% who were dosed were suboptimally. They were either not taking it properly, or they are taking it at bedtime, or they are not taking before meals. And they are not, most of the patients, they eat, especially when I did clinic yesterday, after 4 to 5 days of holidays and Eid festival, people had a lot of, heavy meals. And most of the patient I saw yesterday was with this acid peptic disease. And I had to increase dose temporarily, because they were stable for last many months, and now after having many fatty meals, their symptoms are relapsed. So lifestyle modification is the key. So we have come a long way, basically. If you start when I was not even born, the H2 antagonists were there. Then there was change in era in 80s, the PPI, omeprazole was there. And then there were various omeprazole. We have lansoprazole, we have dexlansoprazole, esomeprazole, and now we have another treatment, 2015, and recently FDA approved PCAB inhibitors. So in summary, clinical superiority versus PPIs, it's maintained pH of more than 4 and relief heartburn throughout the day. It's lower erosive esophagitis recurrence rate, faster healing of esophagitis. There's improved, especially in PPI resistant cases, when sometimes you are stuck. Even increasing the dose does not improve the symptoms. So now we have another medication to write for the patient, and has comparable H. pylori eradication with, in some of the studies, with less side effects. It's rapid, potent, and durable acid control. So these were the references that I used while quoting various studies. So vonoprazole overcomes many of the weakness of traditional PPI therapy. Vonoprazole is superior to conventional PPI for suppressing acid secretion, especially at night time. No difference in efficacy depending on CYP2, C19 genotype status. So taking this opportunity further, I would like to extend my invitation to all of you. We are having a 4th annual PGLDS meeting next month, 11 June, PC Karachi, and you are all invited. Thank you.
Thank you very much, ma'am. Diabetes mellitus is a complex disease that compromises all systems in the human organism. Previously, traditionally, management was mainly focused on the blood glucose optimization with antidiabetics. That was the glucocentric approach. With the enormous impact on CVD, treating type 2 diabetes in a holistic cardio-renal metabolic approach has now become the norm, shifting the paradigm from the traditional simplistic glucose lowering approach. To talk more about this, I would like to invite Dr. Ali Asghar. He's assistant professor and consultant endocrinologist at Liaquat National Hospital and Medical College. He's also the vice president, Pakistan Endocrine Society, and he will be talking about combining glucocentric and cardio-centric approach in management of type 2 diabetes. Dr. Ali, please join us.
Bismillahirrahmanirrahim. Thank you very much, Pakistan Society of Internal Medicine, for inviting me. I mean, I hate these stages to stand up there, so I'll just come down and try and be close to all of you. So my topic today is combining glucocentric and cardiocentric approach in type 2 diabetes. So with the permission of the chairs, I would like to start. So I see quite young physicians up there, so I'll be coming close to you as well, so be on guard, be awake as we talk. Thank you. So technology has its own problems. So why do we treat diabetes? So I'm an endocrinologist, I am somebody who treats diabetes. So anybody from there, why do we treat diabetes? Why I am interested to control fasting plasma glucose, random plasma glucose and HbA1c? Why? Just to treat the numbers? Or what is the goal when I am treating the numbers? to avoid complications. I mean, that's the biggest thing, that we need to avoid complications. So if you see, people with diabetes are 3 times more likely to die of heart disease. People with diabetes are more likely to develop heart disease at a younger age. And as an endocrinologist, as somebody who treats diabetes, I would like my patients to get prevented from this heart disease at a younger age and also at a later age. Now, up to 80% of people with diabetes will die as a result of a heart attack or a stroke. This means that if I see 100 patients with diabetes, 80 will die from heart attack or stroke. So my responsibility is not only to treat the numbers, but actually to translate these numbers into preventing these heart attacks and strokes. And that is where the modern concept comes in, not only the glucocentric, but also the cardio-centric approach in managing diabetes. So what do you think? Controlling HbA1c is important? Yes or no? Come on, you're awake? Yes, it is. Glycemic control should be the top priority in diabetes to prevent complications. So whatever we do, we have to control fasting plasma glucose, random plasma glucose in HbA1c. That is the crux of diabetes management. Now just see this, stroke and acute myocardial infarction. I'm sorry, I can't just point it there. So you see stroke and acute myocardial infarction and the factors which are important in causing stroke and heart attacks. Now just see myocardial infarction, top of the list is glycated hemoglobin. Next is systolic blood pressure, LDL cholesterol, physical inactivity, smoking, marital status. So don't smile, you cannot change marital status. You can change a lot of things up there that you see. So HbA1c is very important. Bad HbA1c is something that will lead to stroke and heart attacks. So as somebody who manages diabetes, you have to control HbA1c fantastically. We talk about many fancy things, really. We are into new medications, we talk about fancy things, but what are we doing for diabetes itself? So this is what is happening globally. Uncontrolled diabetes, 69% in diabetics in Pakistan have an HbA1c that is more than 7%. So we talk about a lot of things, but the base thing that is there, controlling diabetes, we have not yet mastered this basic thing in managing diabetes. So as the world is talking about more glucocentric and cardio-centric approach, probably in many parts of the world and in this part also, we are yet to actually attain glucocentric approach also in the management of diabetes. Now we all know 1% reduction in HbA1c reduces myocardial infarction by 14%, microvascular complication by 37%. So when I am treating diabetes, I am not only looking at the numbers, no. I know that the numbers that I am treating will prevent my patient from going to a wheelchair or a stretcher, and that is why I practice. That is why I tell them that you are taking medication and listening to me. Now, UKPDS. So, okay, we all agree we have to control diabetes, I mean, full stop. Early diabetes is very important. Somebody who comes to you at 30, 35 years of age, he's pretty young, he doesn't have symptoms, he doesn't want to control diabetes. मरीज तो कहता है मुझे कुछ होता ही नहीं, मैं जब होगा जब देखा जाएगा. But this is a national culture that is there. As a good physician, we need to tell our patients, look, the early tight control of diabetes will give you a life which can be free of complications or with less complications. Look at the UKPDS. When it finished, then there were 2 arms, conventional and intensive glucose control. Even after 10 years when the study finished, even after 10 years, the intensive arm had less microvascular and macrovascular complications. And this is known as the legacy effect or the metabolic memory. बच्चों को होता है ना, छोटी उम्र में आपने बच्चों की अच्छी तरबियत कर दी, अब वो सारी जिंदगी चलते रहेंगे. Same goes with diabetes. So it's very important that young diabetics should be explained that you need to control diabetes well in the early part of your diabetes. All these studies, I mean, all these landmark trials, we see that the events, the non-fatal myocardial infarction were less when diabetes was controlled intensively. This means that whatever fancy things we think about, controlling diabetes is at the heart of management of diabetes. Simple as that. And as I talk about glucocentric, I'll move towards the cardio-centric approach pretty soon. So these are the deaths from cardiovascular disease from 1999 to 2013, and we see that cardiovascular deaths are coming down. Kudos and congratulations to our cardiologists sitting here. They've been working hard to bring down the cardiovascular disease. But still there is a gap between cardiovascular disease and diabetics and non-diabetics. And what we can do as somebody who is diabetes specialist, and there is so much diabetes in Pakistan that everybody has to be a diabetes specialist, whether be a cardiologist or a gynecologist or an orthopedic surgeon, everybody has to manage. There are 3 crore diabetics in Pakistan. I mean, 125 endocrinologists and probably thousands of diabetologists alone cannot do it. So again, what can we do to bridge this gap and reduce the cardiovascular morbidity and mortality in diabetics? Probably we can't do that, but we can actually think and do something at least. Look at this, heart failure is also more in diabetics. Then heart failure with type 2 diabetes has less survival than heart failure without type 2 diabetes. Another challenge for the cardiologist as well, and the endocrinologist and diabetologist as well. So it was decided that whatever diabetes medication will come in, it has to have a cardiovascular outcome trial. I mean, come on, I treat diabetes, but that can increase heart disease, so I treat ही क्या किया? I mean, 80% of my patients will die from heart attack and stroke. If I control HbA1c and my patient still gets a heart attack or a stroke, I mean, what have I treated then? He can still have it, but I can think, how can I go down in reducing heart attacks and strokes? So again, the modern day management is now changing. You know, what is the gold standard approach in diabetes? How do you start in diabetes? Yes, come on. I have limited time, I'll try to finish on that. Lifestyle, fantastic. In busy clinics, many a times you don't talk about lifestyle. Well, lifestyle has a major role to play, diet and exercise and no smoking, and there's marital status as well, but I don't go into that discussion, my time is only 15 minutes. So metformin is the first line medical treatment then, and the 2 emerging therapies are SGLT2 inhibitors and GLP-1 analog. Before I move forward from here, GLP-1 analogs are injectables and 10 times more expensive than SGLT2 inhibitors. SGLT2 inhibitors का महीने का खर्चा है 1,500, GLP-1 analog का महीने का खर्चा है 15,000. Pakistan के economic status, inflation आपके सामने. So be careful when you write medications to your patients. So again, these are SGLT2 inhibitors and GLP-1 analogs and their trials. And most trials with SGLT2 inhibitor and GLP-1 analog have shown reduction in MACE, major adverse cardiac event. And then the heart failure hospitalization is also reduced with SGLT2 inhibitors. And then we see renal benefit is seen with both SGLT2 inhibitors and GLP-1 analogs. So as you manage diabetes, lifestyle is the word go. You have to do lifestyle. Lifestyle पे तो बात करनी है. और lifestyle पे से बात नहीं करनी. मरीज से आप पूछे क्या खाया सुबह, डॉक्टर साहब परहेज, excellent. कोई खाया क्या है तो बताएं. तो डॉक्टर साहब 2 पराठे खाए थे मक्खन के साथ और साथ में देसी घी. I mean, we need to ask what they are actually taking. So again, the guidelines, the recent guidelines have completely changed. From 2018-19 guidelines, focus of the guidelines are now shifting. What they say is, somebody who is diabetic, newly diagnosed diabetic, who has atherosclerotic cardiovascular disease, or he is at high or very high risk of cardiovascular disease, you start not with metformin but SGLT2 inhibitor or GLP-1 analog. 60 years say metformin was the first line medication. First time European Society of Cardiology displaced metformin from first line and said in heart disease or high or very high risk of heart disease, start SGLT2 inhibitor or GLP-1 analog. This is the ADA guideline. They always used to say metformin first line hai, फिर second line आप खुद ही choose करें according to parameters. Then they changed. They said no, if you have atherosclerotic cardiovascular disease or high risk of cardiovascular disease, then your second line medication after metformin should be either SGLT2 inhibitor or GLP-1 analog. पहले क्या होता था? Metformin, DPP4 inhibitors, sulfonylureas. Now things are changing. Metformin, SGLT2 inhibitor and GLP-1 analog. And remember, the cost difference between SGLT2 inhibitor and GLP-1 analog is tremendous. Again, the focus, the target in diabetes management, HbA1c था 2009 में, 2015 में HbA1c, and now it's all about cardio-renal events. See, the shift has changed. It's not only about treating number. मैं बेगम को गिफ्ट ला के भी दूँ, उसको पसंद भी नहीं आए, तो फायदा हुआ कोई? No. We have to manage in a way that affects patients' life, that makes patients' life better. Again, SGLT2 inhibitor promotes weight loss, reduces blood pressure, no hypoglycemia, and all these features, they help heart. I mean, hypoglycemia can trigger heart events. Weight gain can cause more cardiovascular disease. Blood pressure reduction helps cardiovascular disease again. So again, these features of SGLT2 inhibitors, they favor to reduce cardiovascular disease. Some quick slides to tell about the benefits of SGLT2 inhibitors and GLP-1 analogs. Time to first MACE, most of the studies for SGLT2 inhibitors showed that time to first MACE reduces, first cardiac event reduces with SGLT2 inhibitors. Again, time to first heart failure hospitalization significantly reduces with SGLT2 inhibitors, the studies have shown. GLP-1 analog, again, injectable agent, once daily to once weekly, very costly, 15 से 17,000 रुपए महीने की cost है. Again, the time to first MACE with most of the studies done with GLP-1 analog shows improvement. All-cause mortality reduces. So what is the current diabetes management then? Lifestyle has to be there. Metformin has been the gold standard medication. So does metformin affect cardiovascular morbidity and mortality? Studies have not shown clear-cut evidence. One, in 2017, a meta-analysis did not confirm to this. In 2019, the meta-analysis said metformin reduces cardiovascular mortality, all-cause mortality and CV events in coronary artery disease patients with diabetes. This is a recent 2021 meta-analysis which shows metformin is significantly associated with lower risk of MACE. So even after 60 years, metformin is number one. Probably we still cannot remove metformin from number one. But what has to be the number two and number three treatment is a debate. But remember, times have changed. Diabetes is a progressive disease. And beta cells are dying every year 4 to 8%. आज मैंने A1C control कर लिया, 6 महीने बाद A1C फिर ऊपर चला जाएगा. What traditional diabetes management is? जैसे ही HbA1c ऊपर जाएगा, we will add a डाकू आने के बाद हम घर का दरवाजा लॉक नहीं करते हैं, पहले लॉक करते हैं. We don't need to wait. Sorry, मैं तो समझा टाइम खत्म होने लगा है. Thank you. So right in time, हाँ, मेरा टाइम अभी तो नहीं स्टार्ट हुआ, ठीक है. Okay, just 2 more minutes, right? So what happens is we wait for the HbA1c to go up and then add a medication. I mean, that's a failed approach. The new approach is start from a combination therapy, preempt, don't allow the HbA1c to go up. So modern science says start with a combination therapy. And this is the verified trial which combined DPP4 inhibitor and metformin. और अगले स्टेप पे उन्होंने सिर्फ metformin दिया और बाद में DPP4 inhibitor ऐड किया. Treatment failure was lesser with the combination therapy starting first up. So remember, in diabetes, you need to probably start with the combination therapy. And remember the legacy effect. The better control of diabetes initially, your patient will continue to get benefit years down the road. Again, so the new approach, that is, the world is moving from a glucocentric only to a glucocentric cardio-centric approach and a combination therapy to start with. So metformin, of course, there, and then SGLT2 inhibitors in GLP-1 analog where there is high risk or very high risk for cardiovascular disease. So mostly in the world today, it's metformin and SGLT2 inhibitor which is coming up as the first line medication in diabetics. And this is where I want to focus. Start with a dual agent, start with an agent that protects heart right from the start and control diabetes as well, because if you don't control diabetes, you have done nothing actually. So again, there are many other things. My time is just finished. It's the last minute. Weight management, exercise, diet, adequate sleep. How many of you sleep 7 hours every day? How many of you sleep 7 hours every day? मैं तो हाथ नीचे कर लेता हूँ पहले ही. कल सोया था 7 घंटे, ठीक है? Yes. Hardly any hands, so thank you. So you see 7 hours of sleep every day. Studies have time and again shown good sleep reduces cardiovascular disease, helps diabetes, and no smoking. In busy clinics, sometimes we are more engaged with medications only rather than these many other things. That is actually the cardio-centric approach to manage diabetes. So again, in diabetes, it is mandatory that cardiovascular protection is accompanied by an early intensive management of hyperglycemia, and to harmonize the gluco and cardio-centric approach and an early combination to treat diabetes. So the whole point, my dear colleagues, is not only to treat the numbers. The whole concept is to reduce those cardiovascular complications that becomes the big reason for morbidity and mortality. Thank you very much.
Thank you very much, sir. I think it is very difficult to sort of contain a discussion on diabetes, and it has been done very well. When you talk about diabetes, it's almost impossible to not talk about hypertension. Hypertension is projected to affect 1.5 billion people, which is 1/3 of the world's population in the coming time. Blood pressure control can be considered the collaborative success of at least two partners, namely the attentive prescribing doctor and the constant compliant patient. Difficult to control hypertension represents a real life, and this is what our next topic is about, which is managing managing patients with difficult to control hypertension. It is going to be presented by Dr. Suhail Khan. He is the CEO, Arya Medical Complex, which is an upcoming tertiary care hospital in Quetta. He is also consultant interventional cardiologist of cardiology in National Institute of CVD, Cardiovascular Disease, Karachi. Dr. Suhail Khan is Chairman NCVH Salt Lake City, Director American Heart and Vascular Institute, Salt Lake City, Utah, America. Sir, please join us. Thank you.
Assalamu alaikum. Pakistan Society of Internal Medicine, thank you so much for this kind invitation. It is indeed an honor. Today we'll talk about managing patients with difficult to control hypertension. I have no financial disclosures. So if I look around here, I see for the most part a lot of South Asians here, and the one thing that we share among us is our passion for carbohydrate-rich food, cricket, music, and a lot of things. And the one more thing that we do share, which I won't say it's a nice thing to have, but we made the cover letter for American College of Cardiology. Just being a South Asian now is considered as a high risk factor for CAD or heart disease. And there are about 40% higher chance of mortality from heart attack in patients who have South Asian ancestry. And by WHO report, by 2020, South Asians will comprise 25% of the world's population, but will suffer 50% of the world's cardiovascular deaths. South Asians develop coronary artery disease up to 10 years earlier than the general populations. And if you look at Pakistan, again, if you look at the overall patients who have hypertension, which is the leading cause of cardiovascular morbidity and mortality, of 1.3, 1.4 billion people who has hypertension in the world, about 60-70% of them are into low to middle income countries, and Pakistan is one of them. And in Pakistan, 80% of adults and 33% of adults over age 45 and above are hypertensive. And again, of all the complications from hypertension, the worst is mortality, and most of that mortality is about 45% is due to heart disease and 51% is due to stroke. So there are many things that we can do how to prevent heart disease, but hypertension is one of those low-hanging fruit that, if we are careful enough, that is something that we can easily manage. But despite of all the data which is out there, all the medications that we have, despite of that, there are only 12% of the population for hypertension is adequately controlled. Again, there are factors to it. So what I will do is that I would first talk about what are the causes or the main causes for patients whose hypertension cannot be controlled well, and then we'll talk about resistant hypertension, and then we'll also touch upon certain guidelines. So again, going back to the basics, how do we classify hypertension? Based on International Society of Hypertension, the optimal blood pressure should be less than 130/85, and grade 1 hypertension starts at 140 millimeter of mercury systolic and above. And this is in contrast to American College of Cardiology, ACC guideline, which is a little more conservative when it comes to hypertension, and they call the stage 1 hypertension if it is more than 130. Then hypertension diagnosis also depends where you measure it. If it is office-based, it should be more than 140 systolic, more than 90 diastolic. The ambulatory blood pressure, which is, in my opinion, or there is some data out there which is more predictive of end organ damage as well as mortality, the average daytime should be more than 135 systolic, diastolic more than 85. Going back to the basics again, and a lot of time when we say that, why this patient is very resistant to hypertension, are we measuring it correctly? Most of the time, we are not. Again, ideally, the patient, when we are measuring blood pressure, should be rested with some back support. There's no talking. The patient should not have had any coffee or alcohol within the last 30 minutes, should have empty bladder, it should have been rested for 3 to 5 minutes before you measure it. I mean, how often we do that? I mean, I would say 99.9% we don't. So this could be one of the reasons that you may not get some good readings, or if someone is using the blood pressure cuff and the size is smaller compared to the arm's circumference, it can overestimate the blood pressure measurement. Going back to the medications as well, again, we all know there are other causes of non-adherence or excessive salt intake or inactivity, but one of the things that I've noticed is a lot of patients, the doctors, when they see their patient, they start their patients on a single agent. And there is a data that it is inadequate in 40 to 60% of the patient, and in majority, 2 or more antihypertensive are required, unless if someone is older, age more than 80. In those cases, in a grade 1 at low risk, you might start a single therapy. So again, no monotherapy has been shown to achieve target blood pressure in more than 20 to 30% of cases. Combination is better than monotherapy. Again, it is very effective. It can improve the response rate up to 75 to 90%. So again, this is not me saying all that. So let's look at the guidelines, what the guidelines are saying. So once you see the patients where it is established, you have taken the blood pressure measurement very well, you have like repeated it in the office a couple of times, now it is labeled as diagnosed. So the drug treatment threshold, if they have blood pressure more than systolic 140, the target blood pressure in those patients, if it is less than 65, should be less than 130 systolic. If it is more than 65, it should be less than 140. Per ESC guidelines, it does recommend 2 drug combination therapy from the get-go, and in those patients who you cannot control, we can also talk about the triple regimen. So basically, if you have uncomplicated hypertension, the initial therapy should be a combination, either ACE or ARB plus calcium channel blocker or diuretic. Again, if someone is pregnant, you should avoid ACE inhibitor. We can look at other combinations. And then even then, if you cannot control the blood pressure, then you can add some diuretic. And the resistant hypertension that I will talk about later, we can add spironolactone and some of other medications as well. And again, at any point, if someone has coronary artery disease or angina or congestive heart failure, we can add beta blockers as well. Again, it's the same repetition that we just talked about. If someone has CAD, then the beta blocker should be on top of the list in combination with some other drugs. Again, someone with CKD, we should start off with ACE inhibitors and calcium channel blocker. Again, if we have to use diuretics, we should look at using loop diuretic. ACC guideline also recommend combination therapy in stage 2 hypertension. This combination is readily available in Pakistan, which is amlodipine, valsartan, and hydrochlorothiazide. And again, the single dose combination therapy is preferred in patients who are difficult to control, and it has consistently shown to reduce blood pressure. And even if you look at many other dual combinations, this triple combination works very well in reducing mean systolic blood pressure as well as mean diastolic blood pressure. And they're also complementary. For example, if the ARB can lead to hyperkalemia, it is counteracted or neutralized by diuretics. And if RAS blockers may attenuate the edema that is caused by calcium channel blockers. So let's briefly talk about resistant hypertension. Per GNC, the blood pressure, if someone has blood pressure more than 140 despite on 3 drugs, including diuretics, is labeled as resistant hypertension, or AHA is uncontrolled blood pressure despite 3 drugs, or blood pressure controlled but require at least 4 drugs, or it's called control-resistant hypertension. The actual prevalence, again in the US, I don't have data for Pakistan, but I do expect it to be higher than this. It estimates around 8 to 9%. And the Kaiser Permanente, the estimate is again 1.9%. And these numbers tend to underestimate, just like when we look at the cardiovascular risk score for South Asian, whatever we use in the US, it does underestimate it for South Asians. Again, it is associated with increased cardiovascular morbidity as well as mortality. So 50% of uncontrolled blood pressure is due to pseudo-resistant. Again, that's why I was trying to emphasize on accurate blood pressure measurement is improper blood pressure, BP measurement, and that is some basics that we all need to focus on. These patients also can have white coat effect, and in those patients we can use ambulatory blood pressure monitoring, and also poor compliance in approximately 30% of the patient. And in my experience, I've been at NICVD for the last 8 months after spending 18 years in the US, and Dr. Tahir Sakhir will also attest to it. The non-compliance is pretty higher. And again, it is one of those centers that we see about 40 heart attacks a day, and I've never seen that in my life. So again, this is a major deal here. The true resistant hypertension comprise about 50% of the population. I mean, these are run-of-the-mill causes that we all know. It's due to excess sodium intake, inadequate diuretic therapy, medication dose or side effects, excessive alcohol intake, and secondary causes of hypertension. There are medication, side effects, for example, if someone is on NSAID COX-2 inhibitors, oral contraceptives, sympathomimetics like decongestant, diet pills, cocaine, stimulants, amphetamines, alcohol intake, antidepressants, erythropoietin, cyclosporin, and herbal compounds. So again, before we label someone as someone is having resistant hypertension, we have to rule all this out. In these patients, again, it's challenging. I mean, lifestyle modification and exercise, I mean, it does decrease the, some, but it's not as effective. The things that we can do differently, I mean, those guidelines that we talked about using different combination, we should maximize or optimize diuretics. Chlorthalidone is 2 times as potent as HCTZ, so that is something that we should be using more often in these patients. Again, not every combination is created the same. Some are better than the others. For example, ACE inhibitors and calcium channel blockers are superior to ACE inhibitors and thiazide diuretic. And control blood pressure, ARB and calcium channel blocker, it does control blood pressure in about 60% of individuals on prior 3-drug regimen, including a diuretic. And the third line is after you maximize with the dual agents, then or triple therapy, you can add spironolactone or eplerenone. You have to make sure that the patients have GFR more than 30. It can lead to hyperkalemia, so we should avoid this drug in someone with potassium of more than 4.5. And it does lead to breast tenderness and gynecomastia that we need to be careful about. Again, there is a data out there which has shown its efficacy. Again, going back to the same thing, once we do all those 4-drug therapy, including spironolactone, even then if we cannot control the blood pressure, then we can think about adding labetalol, or we can think about using centrally acting alpha-2 agonists like, for example, clonidine. In the US, we used to have patches of clonidine. I don't know if we have that available in Pakistan. And then vasodilator like combination of minoxidil plus loop diuretics. Most importantly, we have to rule out secondary causes of hypertension. And of that, the one that I see very often in Pakistan is obstructive sleep apnea. There is a obesity pandemic, and the one thing that Dr. Ali just asked all you guys about, sleep patterns, and that is something that I always ask my patients. Patient with obstructive sleep apnea can increase the risk of hypertension, diabetes, congestive heart failure, and even these patients, if they lose 20 to 30 pounds, and you will see that it is much easier to control their blood pressure. So that is something we should always screen our patients. And then we should also look at primary hyperaldosteronism as well as renal artery stenosis. If someone is on 3 drugs, including diuretic, if it is a male more than 50, and it's always a good idea to get a renal Doppler ultrasound to rule out renal artery stenosis. Or if it is a female, in those patients too, they may have fibromuscular dysplasia, and the renovascular diseases needs to be ruled out. So in summary, hypertension is a major cause of cardiovascular morbidity and mortality, and when treating hypertension, consider combination therapy at the outset. and also think about SDC therapy or a single dose combination therapy. Rule out sleep apnea and other secondary causes for difficult to treat hypertension. And in continuation of this talk, we will be hosting this webinar, which is a South Asian and heart disease. Is this a new pandemic? This will be hosted online on May 10th, and we will have speakers from India, Bangladesh, as well as in the US. It will be at 90 minutes, so all of you are welcome to join us. Thank you very much.
Thank you, Dr. Sohail, for your talk on how to manage patients with difficult to control hypertension. I'm going to request our very esteemed chairpersons to please make a few comments. In view of shortage of time, we're running late. We will not be taking questions, but if there are questions, we can take them later on after the sessions. And I'm going to request the chairpersons now to please share your valuable feedback.
I'm going to comment on the first speaker, Lubna Kamani, and she spoke about vonoprazan. As we know that this is a new agent, relatively a new agent in the armamentarium for the acid suppression. Before that, we have proton pump inhibitor, and she clearly demonstrates the relative advantages of vonoprazan, which is a PCAB, potassium competitive acid blocker. But at the moment, we do not know the long-term outcomes of PCABs. We do not know what are the side effects of long-term therapy with PCAB. So there is a word of caution whenever we are using this new agent, although it is going to suppress for 24 hours acid production. And one more thing, that the upper GI symptoms are beyond acid suppression. What about bloating, fullness, nausea, apprehension, and anxiety associated with upper GI symptoms? As you know that the acid production, the parent cell is the enterochromaffin-like cells, which produce not only the acid, but the parent thing which they produce is the histamine. H1 and H2 antagonists are the backbone. When there is a need, you can supplement your patient's acid suppression with H1 and H2 antagonists. Moreover, another chemical which is being produced by enterochromaffin-like cells, which is the parent cell which produce acid as well, which is through the G cells. So that is a serotonin. So there should be a judicious use of H2 antagonist, H1 antagonist, as well as serotonin inhibitors in combination with acid suppression whenever you are dealing with patient with upper GI symptoms. Thank you.
Thank you very much.
Thank you. I will just discuss about the Ali Asghar Saab's lecture. It's a very simplified, comprehensive approach for the diabetes management based on hemoglobin A1C and other latest recommendation. The most important thing that he highlighted is that you go for the prevention of the complication on the day one. So it's a very comprehensive and simplified approach for the management for diabetes. Regarding Dr. Sohail's lecture, it's a very simple approach to management of the hypertension, and then later on he discussed the latest and salient features for the dedicated treatment for the hypertensive classes in uncontrolled blood pressure. Sir.
Thank you very much. I think all the three speakers did an excellent job, starting with vonoprazan. I actually endorse the comments of my co-chairperson regards this new drug. It is important to know what are the long-term effects of this drug, and we do not have the data for that as yet. Secondly, in our patients who undergo intervention, or who are also taking aspirin and statins, we need to see what are the interactions of this drug with the drugs that we are prescribing, because most of the patients are going to have polypharmacy, and there you have to be very careful. Regards the last lecture on hypertension, I think the message which I would like to give is, remember, the blood pressure that you have to control is 140/90. That is the magical number. Reduce the blood pressure to less than 140/90 in most of your patients. In those who are elderly, who are frail, be careful there. But those who are elderly and fit, even there you should be able to control your blood pressure better, because the complications will definitely reduce. Now, the thing is that in all the guidelines, whether they are the American College of Cardiology and the American Heart Association guidelines, whether they are from the European Society of Cardiology and the European Society of Hypertension, or they are from the International Society of Hypertension, the most important message is use combination drugs. A combination therapy is much better, and it should be used early. The International Society for Hypertension states that you start with low doses of 2 long-acting drugs. If the blood pressure is not controlled, in the second step, use them to the optimal dose. If still the blood pressure is not controlled, use mineraloreceptor antagonist. However, having said that, before you do all this, you start with the lifestyle modifications. That is the most important thing, whether it is diabetes, whether it is hypertension. The lifestyle modification should be instituted early on. And the other important message is control the blood pressure within 3 months. Don't wait for the next birthday. This has to be controlled as early as possible with the best possible drugs that you have. And I advocate long-acting ARBs and ACE inhibitors in combination with long-acting calcium channel blockers. This is what you have to do. Regards the lecture by Dr. Ali Asghar on diabetes, I think he very aptly described it as you have to be very careful. You can't just be glucocentric. It has to be cardio-centric. And the new speciality which is emerging everywhere is cardio-diabetology. Sohail, that is the most important subject which is now going to come up. And then you have to actually coordinate. It has to be a team effort. And the second thing which I want to emphasize is that the SGLT2 inhibitors, maybe they are a drug for the diabetologist, but they are definitely a drug for the cardiologist. And also in diabetes, like in hypertension, it has to be a combination therapy from the very beginning. Don't be glucocentric. Try to control all the other factors and see how it affects. The reason why you have more cardiovascular events in patients with diabetes is because you are managing patients with diabetes much better. They're lasting longer. And since they're lasting longer, they're going to have cardiovascular complications and they're going to have stroke. So I think from the very beginning, and then these patients also develop heart failure. So it is the SGLT2 inhibitors, and a very important message about the SGLT2 inhibitors is whatever Dr. Ali Asghar said about the mechanisms, that the way they act, I think they act like they reduce the preload and they reduce the afterload. And that is how they act. And that is how they have actually revolutionized. And the SGLT2 inhibitors are the drugs to be used in heart failure with preserved ejection fraction. They should be used with reduced ejection fraction, mildly reduced ejection fraction, and the only drug which has shown benefit in heart failure with preserved ejection fraction. I congratulate all the 3 speakers for their excellent presentations, and I think the message was very clear by them. Thank you so much.
Thank you. Thank you very much. I'm also going to, before we move on to the next session, I'll like to thank all three of our speakers. Professor Lubna had to leave early, but thank you to Dr. Ali Asar and Dr. Sohail and also the chairpersons for this session. Also a quick mention for Getz Pharma. Thank you for sponsoring this Cardio-Metabolic Symposium. I'm now going to, apparently we're not done talking about hypertension, and that is what our next session is about. I'm going to request Professor Bilal Mohyuddin, he's CEO, Punjab Institute of Cardiology, to take over. So please, thank you.
Assalamu alaikum ji. First of all, Pakistan Society of Internal Medicine, fantastic. Finally, we are talking of things up now. Pata nahi hum apnaenge ke nahi apnaenge, but one way or the other, things will take on forward. शहबाज साहब सिर्फ एक सवाल आपके लिए था कि अगर 3 महीने से पहले सालगिरह आ गई तो फिर क्या करेंगे? So वो, when we say of all the targets that have to be met, they have to be met. Sir, next birthday is coming after 1 month. So वो वाली बात थी, but anyway, so the diseases of diseases, the hypertension. And luckily the hall is vibrantly full at the moment, so that basically means that everyone is well trained to understand the thing. Before we start, may I first request the chairpersons to kindly come up. The teacher of teachers, Professor Solat from Lahore. Solat sir, it's been an honor being for us to have you over here. He's a teacher, and if you have had the chance of being educated by him, you will learn the basic thing, and that is how to be empathic to your patient. He is a person who, of course, like all of us, knows science, but he also knows the art of medicine. And that is why where he stands totally different from the rest of us. Professor Javed Akbar Syal, is he here? Javed Akbar Syal from NICVD, I presume he must be doing an angioplasty at the moment or something like that, because, you know, they're slightly busy over there. Last year, once again, I had the pleasure of getting to know a bit more detail Professor Nawaz Lashari, a man with great enthusiasm towards hypertension. And he is one of those few people who actually helped to get rid of the mask and bring the Pakistan Hypertension League back on life. Professor Nawaz Lashari, kindly come up. And unlike a lot of other speakers who are going to be here, we are going to now be bewildered by a talk from a very, very eminent speaker, for whom we have also got our YouTube channel in action. And may I request my very dear friend, Professor Farooq, to kindly come up and give us and talk about the silence to be broken. And he touches his mobile and he makes the thing move. Thank you.
This, I think, is Thank you, Bilal. And I'm going to talk about the topic given to me, breaking the silence of a silent killer. I personally believe it's not killer. So that's why I've changed it slightly, exposing silent stalker. What it really means, killer चाहे कितनी खामोशी से आपको मारे, उसका खौफ बहरहाल बैठ जाता है. And the difference between killer and stalker is that stalker, a person who harasses or persecutes someone with unwanted and obsessive intentions. या उर्दू में आप समझ लें ऐसा शिकारी जो छुप के शिकार करता है. So it's not killer, it's actually शिकारी. तो आप डरते भी नहीं है खामोशी से, वो कहीं से आके आपको. And I was lucky that my preceding talk was regarding management of hypertension, and my talk will be succeeded by management of hypertension as well. So that gave me a liberty to discuss more about as such what hypertension is, to understand, because usually we think hypertension is a number game. A disease which relates to number, if you have a blood pressure beyond certain limit, you are hypertensive. So what we will do in this presentation, we'll define how to diagnose and how to distinguish. You will be able to treat after knowing all these things. So it should be very clear how to define, how to diagnose, how to distinct your patient prior to embarking on management. And treatment, I don't have to cover because Amir is here, he'll be covering management. So when we are defining hypertension, first thing is to understand this complex pathophysiology of blood pressure and hypertension. You see so many, it's very important to identify your patient. Are you dealing with an increased blood pressure which is compensatory increase or a diseased blood pressure? That's why it's not very easy to define this is hypertension. And the limits for that reasons are changing since its discovery, and we'll see in a moment. So first we need to understand this complex pathophysiology, and that complex pathophysiology leads to variability. Blood pressure कोई ऐसी चीज नहीं है जो यूं है, ये हर लम्हे और हर बीट पे चेंज हो रहा है, हर कदम पे इधर जा रहे हैं तो कुछ और हो रहा है, ये बोल रहे हैं तो कुछ और हो रहा है. So it's really difficult to identify who of your patient is really hypertensive. Then second thing about hypertension is it's not just risk factor. It starts as a risk factor, but it leads to everything. A stalker, खामोश शिकारी, हर चीज को असरअंदाज हो रहा है. Wherever you have microvasculature or macrovasculature, it's affecting all those areas, starting from your toe to your head, brain, eyes, kidney, everything. So with these three basic, let's move on to how to define. It's a persistent increase in blood pressure beyond a certain limit. And these limits are constantly changing with passage of time. Dynamic nature according to situation under the influence of regulatory mechanisms as we looked into the pathophysiology. And that's why sometimes sporadic increase in values even without disease. You can have increased blood pressure without hypertension. So it's very important to understand what hypertension is and when to label an increased blood pressure as hypertensive. So it's, since when we had this measurement techniques, we start to know about what blood pressure is. Initially it was just an compensatory response, needs no treatment. Then subsequently some conservative measures or medical treatment if your patient is very high risk. यानी हम initially इस तारीखी दौर में blood pressure को मर्ज ही नहीं मानते थे, ये एक response था. फिर ये ख्याल आया कि सिर्फ ऐसे लोगों में जिनमें बहुत ज़्यादा पेचीदगियाँ हों तो blood pressure को treat किया जाना चाहिए, otherwise treatment की ज़रूरत नहीं है. Then certainly upcoming evidence always kept on questioning existent facts, progressive changing of blood pressure thresholds for diagnosis and treatment. और अभी हम latest देखते हैं कि अभी हम कहाँ पे हैं. ये JNC 7 थी, सबको याद है, प्री हाइपरटेंशन स्टेज 1 स्टेज 2. फिर ब्लड प्रेशर के हवाले से प्रॉब्लम्स शुरू हुई, कहाँ का ब्लड प्रेशर, क्लिनिक, होम, 24 आवर एम्बुलेटरी. और जब इस तरह से ब्लड प्रेशर को मॉनिटर करना शुरू किया तो पता चला कि बच्चे ने 2017 में एलिवेटेड और स्टेज 1 को 130-139 कहा था. तो अभी तक ये फैसला ही नहीं हो पा रहा वो नंबर कौन सा है जिस पे ब्लड प्रेशर, जिस पे आप किसी को हाइपरटेंसिव कहेंगे या नॉर्मोटेंसिव कहेंगे या एलिवेशन अनकॉम्प्लिकेटेड, लेस देन 140-90. लेकिन अब ये वाला टारगेट भी सोचना बड़ा मुश्किल होता है. ये एक रीडिंग पे फैसले नहीं हो सकते मुस्तकिल बुनियादों पे. फिर वो रीडिंग्स किस सिचुएशन में ली गई हैं, اس پہ بھی ابھی آپ نے ویریبلٹی دیکھی, کمپلیکس پیتھوفیزیولوجی دیکھی. سو ٹرائی ٹو گیٹ یور پریشر ایز کلوز ٹو نارمل سچویشن وداؤٹ انفلوئنسز. 100% تو کیویٹ فری نہیں ہو سکتے, لیکن کوشش یہ ہونی چاہیے کہ وہ ریڈنگز ہوں جو کلوز ٹو بیس ریڈنگ ہوں, جس پہ آپ فیصلے کر سکیں ایون ٹریٹمنٹ سٹارٹ کرنے کے, اپ ٹائٹ کرنے کے, ڈاؤن ٹائٹریٹ کرنے کے, یہ تمام چیزیں. اچھا, کچھ ایسے بھی لوگ ہیں جن میں بلڈ پریشر ہائی رکھنا ہوتا ہے, نو رسک فیکٹرز ہیں, بہت لو رسک ہے, آپ نے انیشلی ہائی بلڈ پریشر دیکھے ہیں تو فوری دوا شروع کرنے کی ضرورت نہیں ہوتی. 6 سے 12 ویک آپ کنزرویٹو میجرز پہ اس پیشنٹ کو فالو کر سکتے ہیں اور دیکھ سکتے ہیں کہ کہاں جا رہے ہیں. اولڈ ایج میں کچھ سچویشن میں اگر بہت زیادہ کوموربڈیٹیز نہیں ہیں تو بہت ایگریسو کنٹرول کی ضرورت نہیں ہوتی ہے. سملرلی پریگننسیز میں بلڈ پریشر بڑھتا ہے which can be due to other reasons like gestational, chronic pre-existing, medication indicated if 150/95 according to variability ہے, اس میں بھی کوئی ایک hard and fast آپ رول نہیں بنا سکتے. اور سب سے بڑھ کے stroke patient جس میں ہم ٹھک کر کے فوراً بلڈ پریشر کو گرا دینا نہیں. ریڈیوس اف سسٹولک بلڈ پریشر 200/220 سے ابو ہو تو, ڈائسٹولک اس سے ابو ہے تو. یہ صرف اس لیے بتانا چاہ رہا ہوں کہ یہ بلڈ پریشر کوئی ایسی ڈیزیز نہیں ہے کہ ایک نمبر یہ اور اس سے نیچے. اٹس ویریبل فار ویریبل پیشنٹس, اٹس ویریبل انٹینسٹی اور ڈفرینٹ سچویشن میں ڈفرینٹ ہے. یہی بلڈ پریشر عام آدمی میں نقصان دہ ہے لیکن ایک اسٹروک کے پیشنٹ میں فائدہ مند ہے, اس کو نیچے. تو دیٹ مینس بلڈ پریشر کانٹ بی ڈیفائنڈ ود جسٹ ون لمٹ. You have to identify your patient's background as well as that particular situation. کس موقع پہ بی پی لیا جا رہا ہے اور مریض کس قسم کا ہے, اس کے بعد فیصلہ ہو پائے گا کہ اس بلڈ پریشر کو ٹریٹ کرنا ہے یا نہیں کرنا. صرف نمبروں پہ فیصلے نہیں کرنے. That's the key when you are managing hypertension. اب ہم 2-3 ایسے سینیریوز ڈسکس کر لیتے ہیں کوئکلی, جس سے ہم یہ اندازہ کر سکیں کہ ہم کیا غلطیاں کرتے ہیں اکثر. کیونکہ دس واز اے میڈیسن کانفرنس, سو آئی کیپٹ دوز سمپل سینیریوز. 30 years female with palpitation, vertigo and headache for few hours, found to have blood pressure of 190/90. یہ ER میں آپ کے پاس آتی ہیں 10 سے 15 منٹ میں, یہ ساری سچویشن ہوئی اور ER میں اس بلڈ پریشر کے ساتھ یہ فیمیل آتی ہے. سوال میں نہیں پوچھوں گا, آپ ہی کو میں بتاؤں گا کہ آپ کا نیجر ریفلیکس کیا ہوتا ہے ایسی سچویشن میں. یہی ہوتا ہے نا, ڈز. کوئی ہسٹری نہیں, کوئی اسسمنٹ نہیں, کوئی بیک گراؤنڈ نہیں, فوری ان کو ایک وہ دے دو اور ایک یہ دے دو. اور اب اس کے ساتھ ہوا کیا, کرنا کیا ہے, پہلے ویلیڈیٹ کریں. آر یو ڈیلنگ ود ریئل ہائپرٹینسو کرائسس اور ناٹ, or this is a situational increase in blood pressure which may be due to other influences, and once you take care of that influence you will be able to take care of blood pressure. Second, اگر واقعی کچھ ہے بھی تو اس کے پیچھے ایک 30 years female میں کیا ایٹیولوجی ہو سکتی ہے. صرف بی پی کو ڈاؤن کرنے سے فائدہ نہیں ہوگا, کیا کوئی ایڈیشنل کمپلیکیشن بھی ساتھ چل رہی ہے یا نہیں چل رہی ہے. کیونکہ بلڈ پریشر doesn't come with just increased number, it usually comes with some associated thing, especially if it's emergency. Emergency میں بھی کچھ نہ کچھ گڑبڑیں تو ساتھ چل رہی ہوتی ہیں, but emergency situation کوئی آیا ہے تو اس کو کوئی نہ کوئی ان 5 میجر آرگنز میں سے کہیں نہ کہیں افیکٹ ہو رہا ہوگا. وہ کبھی کبھار کھل کے سیلاب کی صورت میں سامنے آتا ہے, کبھی کبھار ڈھونڈنا پڑتا ہے. اور پھر other comorbids, جب تک آپ یہ 4 چیزیں کسی بھی پیشنٹ کی اسیس نہیں کریں گے اس کے بعد اس کے بغیر آپ مریض کو مینج نہیں کر سکتے جسٹ آن بلڈ پریشر نمبرز. اب اس کے ساتھ کیا کیا, آفٹر 20 to 30 minutes keeping her in relaxed environment with 2 tablets of paracetamol, blood pressure reduces to 130/80 without any intervention. Nothing positive in history, examination or preliminary investigation. اچھا, اس کو کیپٹوپرل اور لیسکس دینے کے بعد ایک اینٹی ہائپرٹینسو بھی دے دی جاتی ہے کہ یہ لے لیں, اور اس کے بعد فیصلہ یہ ہوتا ہے کہ جب بی پی ہوا کرے تو لے لیا کریں, نہیں لیا کریں. سو سمپل. 80% of the time these scenarios are dealt with this situation. अगले दिन ये 100 110 के साथ उसी जीपी के पास जाती है, अभी छोड़ दें, फिर जब होगा तो ले लीजिएगा. और फिर ये लोग समझते हैं कि शायद हमें ब्लड प्रेशर का मर्ज है. आगे ब्लड प्रेशर नहीं होता, वो दूसरी प्रॉब्लम्स चल रही होती हैं जिनकी वजह से बीपी वक्ती बढ़ता है. तो इसमें इस कैटेगरी को हम सूडो इमरजेंसी कहते हैं, जो है कुछ नहीं, किसी सिचुएशन की वजह से बढ़ गई है. जल्दी से 2 सिनेरियोज हम कवर करेंगे. 55 years male, known diabetic and hypertensive, non-compliant to treatment, complaining of indigestion since 2 hours, temporarily leave with antacid, but constants for last 15 minutes, found to have blood pressure 190/90. इसमें कुछ इशारे हैं, समझदार आदमी उन इशारों को पिक कर लेगा. लेकिन हमारे 50-60% जीपी बस सिर्फ ये जो उनको चीज नजर आई है, इसको ट्रीट करके इस पेशेंट को ऐसा पुरसुकून करके घर भेजेंगे, बीपी बढ़ा हुआ है बस, बाकी घर जाओ. और फिर जब ये एनी भी जस्टिफिकेशन, प्रिलिमिनरी इन्वेस्टिगेशन से कंसिडरिंग दीज 4 ऑब्जेक्टिव्स इन योर माइंड दैट आई हैव टू पिक दीज थिंग्स, देन आई विल डिसाइड मैनेजमेंट. आपको कुछ ना कुछ जरूर मिलेगा. सो आइडली दिस पेशेंट नीड्स ईसीजी. बाकी तो सारी चीजें करनी ही करनी है. एक 55 years डायबिटिक को इंक्रीज ब्लड प्रेशर के साथ चेस्ट पे कुछ हो रहा है, तो इन चारों ऑब्जेक्टिव में जो सबसे इंपॉर्टेंट चीज होगी कि आपको ये पिक करना है कि इसके साथ हाई ब्लड प्रेशर के साथ कोई ऑनगोइंग कॉम्प्लिकेशन हो रही है या नहीं हो रही है. और वैसे तो आपकी एक स्क्रीनिंग किसी भी हाइपरटेंसिव की बुनियादी स्क्रीनिंग बेसिक प्रिलिमिनरी टेस्ट हर के होने चाहिए, जिसको वो वही 4 ऑब्जेक्टिव फुलफिल होंगे. अब ईसीजी में क्या है? डिप्रेशंस, जस्ट high blood pressure, it is acute coronary syndrome. So clear cut hypertensive emergency. You're not dealing with just increased blood pressure number. Actually you are dealing with acute coronary syndrome. It may precipitate into ST elevation, non-ST elevation, maybe just unstable angina. So this management is not just bringing down the blood pressure. You have to take care of other things as well in this particular patient. For medical people, 60 years male, known hypertensive, started having right-sided weakness with aphasia for 1 hour. Examination revealed right-sided weakness with blood pressure of 194/110. With rest normal, CT excluded bleed. Neurologists want to give TPA and wants opinion about blood pressure management. ठीक है? और मजे की बात है 1 घंटे का है ये सब कुछ. अच्छा, हमारे यहाँ भी कुछ भी नहीं, बीपी का नंबर देखा और क्या किया, कैपोटेन डज, और फिर भी नीचे नहीं आ रहा तो एक आइसोकेट और लेबिटलॉल, पता नहीं, हालांकि उसको वीकनेस चली जा रही है, लेकिन कोई फिक्र नहीं है, बीपी को नीचे लाना है हर हाल में. 140 बीपी होना चाहिए. Now here you see, we'll discuss it with updated guidelines. Clear cut emergency है. अच्छा, मैं आपको ऑप्शन देता हूँ. Can receive thrombolysis with present blood pressure, need to have blood pressure below 160/100, need to have blood pressure below 180/110, can't give thrombolysis for next 3 hours. इसका आंसर भी मैं आपको बताता हूँ, ये इसमें आंसर है पूरा. Acute less than 72 hours from symptom onset ischemic stroke. अब ये देखिए एक विंडो कितनी बड़ी है, 3 दिन के अंदर अंदर अभी स्ट्रोक हुआ है. Patient qualifies for IV thrombolysis therapy? Yes. Lower blood pressure up to less than 185/110, बस यहां तक कम कर रहे हैं, इससे कम नहीं करना है अगर इसको आप थ्रोम्बोलिसिस दे रहे हैं तो. अदरवाइज अब देखते हैं क्या है, अगर नहीं तो फिर क्या करना है. अगर लेस देन 220/110 है तो अभी इसको छेड़छाड़ नहीं करनी है, बस उसका अकॉर्डिंग टू प्री एग्जिस्टिंग हाइपरटेंशन किस तरह मैनेज करना है अगले 1-2 दिनों में, उसको देखते हुए फैसला करते जाना है कि आहिस्ते आहिस्ते आप उसकी दवाइयां पोर इन करेंगे. इसके ब्लड प्रेशर को नीचे नहीं करना. इस सूरत में करना है कि अगर आईवी थ्रोम्बोलिसिस देनी है तो लेस देन 150. अच्छा, अबव 220/110 है तो आपने करना है, और वो भी इस अंदाज से कि 15% ड्यूरिंग फर्स्ट 24 आवर ट्रक करके भी नीचे नहीं गिरा देना है. सो आंसर विल बी जी सी. वेरी गुड. अब इसको हम थोड़ा सा पेचीदा करते हैं. सेम पेशेंट रीच अ सेटअप वेयर नो थ्रोम्बोलिसिस फैसिलिटीज अवेलेबल. चूज ऑप्शन फॉर ब्लड प्रेशर मैनेजमेंट. इसमें क्या होगा ऑप्शन? जी बी क्योंकि 220 से कम है, no lowering of blood pressure at moment, can continue existing blood pressure treatment. ठीक. So in conclusion, hypertension damage are present. पर ये कब फैसला होगा? जब आप मरीज को comprehensively. Thank you.
The beauty of a speaker always is that he creates a controversy which needs to be discussed. Waad has once again reiterated and discussed about the use of captopril that is going on in our medical community rampantly. Something which no randomized trials or even, and definitely no textbook actually condones. Things that we are practicing need to be corrected. As far as who has hypertension is concerned, that as the age advances, hypertension is there for everyone. It's just like arthritis at times, that gode reh jate hai, and you're having those NSAIDs, etc., so things start creeping into your life. Another great friend of ours who had a tough task given to him a couple of years back was that let's review what the world is doing and let's review what we have been doing. Our next speaker is Dr. Amir. He is currently serving in Aga Khan. I wish he was serving at Lahore with us in Punjab Institute of Cardiology. That would have been fantastic for us to learn. And his enthusiasm and desire to reach out every day is beyond explanation. From where does he get that energy? I hope it is not from a hypertensive episode that he keeps getting every day. May I request Amir to kindly come up.
Thank you, Professor Bilal. So I have the task of talking about the hypertension guidelines. I have the chair who's encouraged us to go from the 3rd guideline document to the 4th guideline. It's not too well read, but let me assure you that it's quite well referenced and it's simple to follow. So I have nothing relevant to disclose. So BB trends show a clear shift of the highest blood pressures shifting from high income countries to the low and middle income countries. And the problem is that the low and middle income countries like us, a lot of international guidelines were quoted over here. We try to follow those guidelines, but remember, those guidelines are built for their own infrastructure and they've got a very robust infrastructure. It will be very, very difficult to translate. So today I'm not going to go into a lot of detail of management of hypertension, but just show you data that we have, local data emerging that can help us bring the blood pressure control. Now, guidelines, we speak of guidelines. What is a guideline? Guidelines basically are business-driven documents. And the business people, just like हमारा जो crisis management है, comes from the cockpit of the airliners. Similarly, guidelines come from business models where they go to the grassroots levels and जो उनका lowest level worker होता है उसको empower करते हैं through a algorithmic approach so that they can tailor the need to the patient or their customer and create satisfaction and control and whatever. So they don't have to make large loops to come back and decide what they want to do. So algorithms are very, very important. Now, so A is, for example, in our case, hypertension, then there are rules that will apply, and then there are situations 1, 2, 3, 4, and then there are paths, dotted paths that you can take to reach point Z. And then, of course, there is an algorithmic guided intellectual and scientific freedom that the worker at all levels can, be it the general practitioner, be it the consultant in a tertiary care hospital, or be the health minister, can exercise. So for hypertension guidelines, community level approach, we should empower the healthcare workers. We should have national programs, which will be tools that we use. we should ensure delivery and measure outcomes. If we are not measuring outcomes, it's useless. And then tailor treatment plans, cross-link programs. We've been talking about cardio-metabolic, cardio-diabetic. We've understood, and it's not today, for the past 2 decades since I've been in cardiology, I've seen that lipids affect blood pressure affect diabetes, they all are interrelated. So cross-linking programs is very important. Ensure control, which is the outcome. And of course, local relevance is very, very important. A lot of medicines that we use over here will not be used in the West. So we need to understand that. So we know the prevalence in the adolescents is coming up to pool prevalence is about 26.34%. Similarly, 46.2% prevalence of hypertension in our urban and rural population. It's a massive problem. And of course, we've been given cutoffs, and we are used to following cutoffs. It's not that it's new to us, but do we हमें speed limit 120 होती है, we drive at 130, despite the fact that we know that every 5 miles per hour increase is associated with an 8% increase in highway fatalities. But we do. So we have numbers, we don't follow those. And the problem is, we believe that we will fail when we apply guidelines. And it's because our clinics are structured in such a way that we give 5 minutes to our patients, and then how can we talk about lifestyle modification? So lifestyle modification, and we are not trained to do that. Similarly, hypertension is an asymptomatic disease. We give drugs, we cause symptoms by creating complications from 0 to 10%. And of course, physicians are too busy to educate themselves over a period of time. Now, if you look at this, and I asked you to choose, which therapy will you choose, pill A, pill B, and you look at the drop in blood pressure on the right side of the panel, each one of you, I'm sure no one will choose other than A, because A drops causes the largest drop in blood pressure, and it's a sustained drop. And what is that? It's weight loss only. Rest of the drugs, all the drugs that we use, good drugs, good combos, are not dropping blood pressure as significantly as your lifestyle modification, or to be specific, weight loss of a significant nature. So in the Pakistan hypertension guidelines, which will remain as such, we have readdressed, and this is from the JNC 7. It's the most comprehensive table which speaks of sodium, weight loss, exercise, and it shows a benefit across. Look at the right panel. Blood pressures are being dropped. Now, the problem is, why do we not believe in weight loss? Because weight loss has got a lag effect. You lose weight today, blood pressure is not going to go down today. It will take up to 6 months to 1 year, and then it will drop. So we don't have patience. So our guidelines have suggested step 0, step 1, and step 2, which is first is educate and create awareness, which we are doing right now over here, and at a household level. Then step 2 is recommend, and this recommendation is that you follow it, and you close the loop by seeing that it has been followed. And step 2 is it is enforced, and you have programs. Now, we do not have this infrastructure across cities in Pakistan, but that's what we should be working towards if we need to control or make a dent over time. Hypertension is not going to kill today. जो आज मर रहे हैं वो पिछले 30 साल से affect हो रहे हैं. So we're going to save someone 30 years down. And this is our algorithm, and I'll give you an example of one, and we will add this thing to it. We were at that time in 2018, for low levels, we just suggested start with the low dose of 1 or a moderate dose of 1 pill. But that it's counterintuitive now, so we are recommending, just like the International Society of Cardiology, International Society of Hypertension, that 2 low doses of 2 drugs. Now, you don't find low doses in a fixed dose combination. So if you're going to start, you have to start with a combo separate pills. Like 2 milligrams of prindopril will not come in a combination, fixed dose. But the ultimate goal is to go to fixed dose combinations. Okay. And we are suggesting going to 130 by 80, because across the board, no matter which trial you pick, look at upfront or post hoc analyses or meta-analyses, 130 by 80 is a significant number. If you can achieve that without causing harm to the patient, then there is benefit across the board, even in octogenarians, 80 years old, or the very elderly. Okay, and this is our simple table, and we've all seen that you start with an ACE-ARB long-acting calcium channel blocker, then you go to a thiazide type diuretic, and then if it's resistant, you add spironolactone. Now, the only thing we will add over here in the new guidelines is start with low doses of 2 drugs, even when it is simple hypertension, other than people, as has been specified, 80 years old, postural, getting up, dropping blood pressures. Over there, you can go with a low dose of a single drug, but that's a very, very small group. Similarly, sacubitril valsartan is making a dent in preserved ejection fraction as well, and it is a good hypertensive. When compared to olmesartan or other ARBs, it has significantly shown to drop blood pressure. Now, it is not part of the guidelines. I've just put it over here because maybe not in this guidelines, but in the next guidelines, it will make a mark. In the Paragon heart failure trial, in a post hoc analysis where 95% of patients were hypertensive, there was significant improvement in resistant hypertension. So they could bring down the number, whereas the number could not be brought down by conventional methodology. So this is something that probably will be we will be addressing in the future. And of course, spironolactone is for resistant hypertension. And if you have resistant hypertension and you give spironolactone and even then you are uncontrolled, it's called refractory hypertension. And for that, there are drugs, like you can add doxazosin to the bisoprolol and then go with alpha blockers and other stuff. Over there, probably ARNIs and or the sacubitril valsartan combination will make a dent. So I'll just take you through a case. So it's a 53-year-old man. A lot of people in this hall will be around 50 plus. BP checked according to protocol. So the first index event was 3 readings, first discarded, the second and third averaged, blood pressure is in the hypertensive range. You don't treat, as Fawad was very rightly suggesting. Diagnosis itself is a very tedious prospect, and it has to be done properly. Otherwise, we will end up treating and under-treating and over-treating a big chunk of patients. Then the next visit will be the first visit, and on that visit also he has average of 2 readings of 150 by 90. Then the second visit, again he has the same, and at that time he got all his tests done, and his fundus exam shows AV nipping and cotton wool spots, which are signs of hypertensive change, which means that there is hypertension mediated organ damage setting in. ECG shows borderline LVH, and of course there's microalbuminuria. So across the board, this blood pressure at 53 is causing hypertension mediated organ injury. So what to do? So we'll go with step 1. Lifestyle modification now becomes, because it is with hypertension mediated organ damage, it will overlap rather than be in a series. Otherwise, if it was pure simple hypertension, low blood pressures, no target organ damage, you would give time up to 12 weeks, and then go with medical therapy. But over here, you can start medical therapy and go with low doses of 2 drugs, and then see. Now, sometimes you give low doses of 2 drugs, and the blood pressure is very controlled very well. Others, you have lower blood pressures, but they don't get controlled, and that is why hypertension is a hybrid animal. It is not the same in all cases. So somewhere you will just need 2 drugs, somewhere you will need 4 drugs. So the milieu is different in both these patients. So in this case, we'll start with low dose drugs. Now, what to do further? Now we cross-link all the programs and we bring in lipids. So his lipids are definitely up. LDL being a target is 180. HbA1c again is a number, is where you don't want it to be. You've started him on moderate doses of 2 drugs, which is a good combination. But after doing this 4 weeks, blood pressure is still up. What do? Do you escalate to maximum doses of these 2 drugs or add another? And that's where room is still open and you can tailor therapy. Each one of us may be different in this. But remember, going with fixed dose combination. So try to go into fixed dose combination as quickly as possible, because that is what ensures compliance. And compliance is important for control. Then you calculate. Now, the ASCVD risk, this is, I have put over here because we use it a lot and it's a very easy score to use. Otherwise there are Interheart, Framingham, whatever you have on your phone you can use. Interheart probably is more reflective, Framingham is, but ASCVD they made amends. So we can do that, and in this case, the current risk of 10-year risk of having a event is about close to 14%. So it's intermediate risk. Optimal risk for the age should have been 2.9%. So he's significantly at a higher risk. What do we do next? We can get a calcium score. It's a simple CT scan, not a very expensive test. It will tell you whether the calcium score is what the number is. And if the number is more than 100, you can add aspirin and cause, over here it will be a soft indication for a secondary prevention. And of course go high on the statin dose, which you would have started on 180, and bring the target to less than 70 as you would do in coronary artery disease if the calcium score is 100. So now hypertension being the pivot, because it's the most obvious risk factors for coronary artery disease. If you can pivot everything around it, I think it will make a very good structural fix for management. This is just to show the international, it's already been shown. So data even in the elderly has been suggested that if you go with smaller doses of more meds, it led to a larger decrease than compared to when you're going with higher doses of a single dose. This is even in the elderly people who have stiff arteries and where blood pressures can boomerang up and down. And Sohail Khan also mentioned Kaiser Permanente, and I'm happy that he was someone who's referenced it also, because I have always been referencing this. This group in the private group in the United States has shown BP control rates of 90% plus. And this is the model private institutions or private mega structures like the AKU Foundation has roots all over Pakistan, can use, and so over here the patient is the center. What they've done is they've shown dedication, they've shown clear commitment on paper, and they've used all their resources, and they have caused an enabling environment to deliver, and that's how they have been able to produce 90% control. Now, can this be done in a public setup in the United States where they have been able to do that? Oh, I'm sorry. So Kaiser Permanente, they have created a registry, which is very important, which we should be doing. They have treatment algorithms which are fixed for the entire their setup. They cause regular follow-up and pep up their patients, and that's how they make sure that adherence is there, and they're using fixed dose combination pills. So I think we can learn from them. Now, not only permanent private health setup has done that. In the US, the veterans, and veterans are like us. Those who have been to the United States know that the veterans hospital are no better than our hospitals. And they have shown, they've used resource, again they've used guidelines, they've used algorithms, practically reproduced what Kaiser Permanente have done in North Carolina, and they have shown controls, raised the controls from 76.3, from 45.7 to 76.3%. In a public setup, it's amazing. So this is where we stand. This is our paper, Tazeen Jafar is the lead, and in the trial, this is reflective of Bangladesh, Pakistan and Sri Lanka, and we are all nearly in the same setup in the low middle income countries, and the control was 58%. In Pakistan, specifically in the rural areas, it was 70.6% uncontrolled blood pressure. So we have a very uphill task to do. And we have again shown, we are always looking towards the West. We have shown in the trial, this is the urban COBRA, and then we did the rural COBRA trial also. It was a smaller trial, but it was a very tedious, meticulously done trial, and we showed that if we gave home health education to the households, we trained the general practitioners in that area annually, we caused a significant decrease in blood pressure. And I've not added that slide over here. There's a echo arm of this study in which we did community echoes. We reported those, and it was sent to the Duke Center Echo Lab, and they vetted those that they were rightly done, and we showed that the LV mass index improved with this control. And this effect, although attenuated a little, spread over and across 7 years. So in our own population, both in the rural and setting, we have shown a model, and this should be presented to the government, and the government should be having public-private partnership. And so this was done in Karachi, it was done in Thatta, Gharo. These are the areas where people were, benefited. Okay, so this is my last slide. What do we lack? We do not have syllabus. Undergraduate training is lacking. Everybody assumes that you know blood pressure, you don't. Postgraduate training, you don't. You ask a PG trainee, ask questions on hypertension, and they are not aware of simple things. So what we need to do is have diploma courses and home health education. So you need a professional education arm of a loop and the home health. Complete that and have the government buy in, and that is how we can control things. So with a few change, we will move to the 4th guidelines, and hopefully we'll be presenting it in Hyderabad in September, hopefully, inshallah. This guideline has 20 cases, 22 cases at the end of the guideline, so it's a live document. You can read it, the answers are there. So I would encourage you to even go to the 3rd guideline and read it. And so with this, I thank you.
May I request both the speakers to kindly come up on the stage in case there are any questions that people want to ask. The only thing wrong with hypertension is, in the words of a wise professor from USA, Professor White, is that one day someone is going to look at them and is going to foolishly try and reduce them. Well, that of course is history, and things have moved on to a place when we are fighting against these pressures in a very, very hard manner. But how far the battle has to be fought, how far we have to be consistent with it. When you look at an HbA1c of 6.2, and you start wondering that in case I start prescribing on him statins, and this HbA1c is going to shoot up, thus I will be so-called unmasking the diabetic part of a person's disease, and then I'll be putting him on another pill. The difference between a disease and a condition is that in a disease you need certain support medications. Most of us sitting over here suffer from a condition which is need of glasses. If you don't use these glasses, we can't read properly, and thus our life's work becomes limited. It is this that is essential. Of course, a lot of us never needed them as a young person. So are we diseased that we need to carry it? Of course, the history goes back to say that it was the polycystic diseases from where everything started off and the understanding. And again, the hypertension battle was basically fought by the insurance people and later on was taken up by us. So I understand there are certain questions to be taken up. May I ask the mics to become up over there? Beta, mic? May I have a mic for the doctor over there? Yeah, Dr. Somia said mic aa jaye.
Assalamu alaikum, sir. Thank you very much. The question is regarding different type of BP apparatuses which we use, like mercurial or your dial wala ya digital. Which one is better to be used?
Now previously the mercury one used to be the gold standard, but now the digital is the gold standard, and that should be used. Most trials are using those apparatuses, and they're good reliability.
And to add to your knowledge, mercury is supposed to go out. We are not supposed to retain the mercury anymore. For example, if you're carrying a mercury BP apparatus and you board a plane, you will be asked to leave or at least leave the mercury apparatus because it's considered dangerous now. Now the digital apparatuses for that, we have got calibration systems going on, and they are further, and I'm sure Professor Solid is going to shed some light on your answer.
I just say one thing in that sense, it's man behind the gun. That's again very important. How to measure blood pressure. There are preconditions for patient, for cuff applications, your arm position. So you saw so much variability because of that reasons. डिजिटल से अमूमन लोग घरों पे करते हैं, कभी हाथ इधर रखा हुआ है, कभी हाथ उधर रखा हुआ है. That's not the way to check blood pressure. There are pre-specified ways of measuring where your hand should be. It should be relaxed, supported, and all other things. So it's very important to understand how to correctly measure BP. That's again very important, along with apparatus.
Thank you, sir. This is a nice presentation. I have a question from first speaker. A question rather than a comment. It's been said, according to a Harrison Book of Medicine, it has been said, whenever a person is having hypertension emergency, you should bring the blood pressure down by 25%, which we have showed over here, 15% within the first hour. While someone is suffering from hypertension emergency, the blood pressure should be brought down of less than 160 in the next 24 hours. Although what the recent guideline is being said in the neurology guidelines, you have showed that the blood pressure of 180 and above. While looking for the thrombolytic therapy, they have showed that the blood pressure should be brought down of less than 160 because of the reason, if we are giving thrombolytics to these patients, there is a chances of luxury infarct, that this infarct will be converted into a bleed. So to avoid that, better to have a blood pressure down of less than 160. But although it's very good that we can't wait for the same. And the other reason for the same, that if we are treating the hypertensive emergency with intracerebral bleed, previously it was you shouldn't bring down the blood pressure because of the reason that it will decrease the blood flow, the peri-bleed edema. But recently they have said, the recent neurology guidelines said you should bring the blood pressure even up to 130. It will decrease the re-bleed chances and it will improve the patients. So what about that? Thank you, sir.
Actually, there is no hard and fast as a single. शायद मैं नहीं समझा सका आपको कि blood pressure measurement हर individual का different है. Individual situation में according to other associated comorbid, clinical status and everything. These guidelines just give you an arbitrary limits कि भाई कम से कम ये होना चाहिए. बाकी हर इंडिविजुअल का क्या मैनेजमेंट होगा, दैट इज ऑन द ग्राउंड सिचुएशन कंसिडरिंग ऑल अदर कोमॉर्बिड्स, क्लिनिकल सिचुएशंस. बट आई कोटेड हियर AHA 2017 गाइडलाइंस एल्गोरिथम. दैट्स द apparent right. Yeah. So usually it's apparently, I personally feel it's around 180. It's 160 dropping as a stroke patients, because there is other side of the coin as well, because once you drop pressure, you decrease perfusion as well. And that may aggravate your infarct subsequently in first 24-48 hours once you drop pressure beyond a certain limit, which may be a hypertension for other, but not for an acute ischemic stroke patient.
I'll just add a little bit into it. There are two aspects behind what you are actually saying, and what Fawad has also mentioned. There's one aspect which is called essentials, which must be done. And then is the optimals, which must be achieved if you can. If you have a person is moving around, comes to you with the blood pressure of, I remember Professor Tariq Wasim was my senior registrar, and I was a young attorney at that time. And I don't know whether he would recall this patient or not in Mayo Hospital. It will be interesting for you to know this gentleman came in with epigastritis, gastric discomfort. That was about it. And in the, as part of my duty, I did the blood pressure check, and I thought there's something wrong with the BP apparatus. Got another apparatus, did it. His blood pressure on that apparatus was 300 plus. At 300 there was, I could not include the blood vessel, and again at the diastolic, it would disappear, the Okrutnikov sound would disappear around 210. Did the fundus examination, grade 4 findings were there, as far as that part is concerned. What to do? So Professor Hafiz Khan, my teacher of teachers actually, and So he was there, they said, okay, try and admit him. Mind the words, try and admit him. And of course he would not like to be admitted. He's a hale and hearty or elderly man. Why will he be admitted? So we tried, then we kept on getting him on our progressive follow-ups. And we did try get his blood pressures down. But the moment we got him slightly down, he would start getting dizzy. So thus, that Professor White's statement that some fool is going to try and control it. But these are extreme examples. Your extreme example, on the other hand, is the 80-50 blood pressure lady who is carrying twins and she is moving around comfortably and she has got no problem. So these are the extremes, and the guidelines when are established, they are about those 70 to 80% in between. So we have to do the tailor making of medicine for them, and as far as these are concerned, it has to be what it has to be. So if a person, like you pointed out clearly, that they come in you have a bleed, you have to get those 10-20% down. You have to, this is the essential, you have to do a CT scan prior to thinking of giving a lytic therapy, even if the person is within the golden 30 minutes. So these are some things which are essentials, and from there we move forward always. Tariq Wasim sir.
No, it's just in response to someone asked that which apparatus to be used. Rightly answered that this digital one is not the fashion, not that it is there. It takes away your inter-observer variability. You give one person with the mercury apparatus and arenide, Mr. A records it 180 or 110, Mr. B may be recording 10 because of his acoustic variability and all that. So that factor is gone. Then it is not, the human action is gone. A very smart lady or a nurse recording it, the blood pressure would be different, and the house officer recording would be different. So this digital one takes away these two things which do
Tariq Wasim sir, अगर smart lady लेगी तो मेरा तो वैसे 20 ऊपर चला जाएगा.
Right. So the digital is not that it is now probably all the guidelines are also, sir.
ये जो sprint trial है जिसकी वजह से हम अब blood pressure को redefine कर रहे हैं was done on digital apparatus and unattended digital apparatus.
That is unattended, but we do not use digital unattended. That's the problem.
So exactly. So if we are going to, so that is why the AHA have not gone to 120/80. They've gone to 130/80 because they've taken out the wrist is wrist पर कोई validation नहीं हुई हुई. तो आप अगर करना भी चाहते हैं तो आप नहीं करें because it's not validated.
Since we are more and more towards home blood pressure monitoring, and the objection most of the time we had घर में BP record करने वाला कोई नहीं है, अम्मा जी और ये कहती हैं, so that also takes away कि जी घर पे अगर हमें you have a digital apparatus and you just have to click the button and you get the recording. So it definitely improves the diagnosis and probably the monitoring and probably the follow-up.
I think the most important thing regards digital blood pressure is that it should be standardized. सबसे पहले उसकी ज़रूरत है कि standardized हो against a blood pressure apparatus which is standard. उसके बाद आप उस पे जो स्विफ्ट का इसका जो ट्रायल हुआ वो unattended था और वो BP apparatus फर्क है as compared to what is available here. जो सिंपल से डिजिटल जो रिस्ट वाले BP apparatuses हैं उसका इतना अच्छा नहीं होता. Whenever you want to
I'm afraid we are slightly running out of time now, and I will now request Professor Solis Saab to first give his comments, especially regarding the digital BP apparatus, because he has done a lot of work on it.
Thank you, Bilal. Wonderful talks, as usual, by two very eminent speakers who are not just qualified but speak very well. That's very important. So I'll start with your question. I think the blood pressure monitors. The Minamato Treaty signed 2016, actually May 2016, which Pakistan is also a signatory has determined that 2020 is the time when all mercury apparatuses should be banned. That includes the thermometer also. And not just this, industrial also. Unfortunately, as is usual in Pakistan, they have signed the treaty but not passed it through the parliament, so it's still in the limbo. The oscillometric is now the dominant one. The sprint trial had the same oscillometric methodology, except the instrument is the same, except they were automated and unattended. So that's a little addition to the thing, but as far as the methodology of checking the blood pressure, that's the same. It's the same oscillometric chip which measures it. So what we need and what is recommended is clinically audited, clinically validated oscillometric, which are available in Pakistan. You have to go to the website, find out which are available. Many are available in Pakistan. They are a little more expensive than the others which are not clinically validated, but not too expensive. And if you know about it, you can spend the extra couple of thousand, I'm sure. So this is the one. The point about standardization made by many people is very, very valid. It's valid for even the mercury measurement. It's even more valid for the oscillometric because the doctor is not doing it. It's the person, individual himself who is doing it or herself. And this is extremely important. And as part of the guidelines, I'll be writing the home blood pressure monitoring, which I've started work on only 2 days ago. So that will be how to disseminate knowledge to the doctors, the GPs, as well as to the patients on how to do it, because ultimately it's the patient who is going to do it. Dr. Fawad has shown his, I would say, versatility or variability. He makes things very, very simple when he is addressing the lay persons on his YouTube channel. But to the audience here, who's a professional audience, he has made it quite difficult to understand. So I congratulate him on that. His examples were very, very valid, and he showed by examples how the same blood pressure has to be tackled differently in different situations. I congratulate Dr. Amir, number one, on his 3rd national guidelines, and now for his work on the 4th national guidelines. It's very well appreciated by PHL as an organization. And I do have some questions for him, which I'll ask. I just have one comment on Dr. Fawad's slide on environment effects on BP, which he mentioned salt and stress and so on. But I would suggest to add air pollution and noise pollution as also environmental factors which are increasingly coming in as causes of hypertension. 3 questions from, we start with the measurements of the blood pressure. Dr. Amir, which are you going to recommend, the office blood pressure or the home blood pressure monitor? That's one question. The second is the elderly. You did mention it, but your slide still said 150/90 for ever 80. I think trials have come out now which say that even for the very elderly, which is the 80+ age group, you can have normal, usual targets as for the rest of the population, with the provisos that they should be able to tolerate it, which means fragility and orthostatic hypertension and closer follow-up are necessary. So are you going to do that? And the third part is that you are going to add, which is new, the risk scoring. But you know the risk scoring, as also mentioned by an earlier speaker, is not correct for South Asians. So are you going to modify the risk scoring?
Very good questions. First is that I would still rely on the clinic blood pressure as of now, because home blood pressure monitoring is not vastly available. It has a cost to it. ABP is practically very limited to a few centers. So office blood pressures, and then of course, as our guideline, as our algorithm suggests, 3rd visit, if it's still up and we are undecided, there's no target organ injury, then we go to home blood pressure monitoring. But wherever we can encourage home blood pressure monitoring, that would be encouraged. The second thing is, I agree 100% with you that 80 plus have benefited from blood pressures below 150 by 90. But I had gone with 150 by 90 because that was the standard at that time acceptable. Now things are changing, and I have put the clause in the text of the guidelines that of frailty as well, that if you cannot achieve, if there's a lot of postural drop in blood pressure, then we can accept that. But if we can achieve in a robust 80-year-old who looks like 65, then we should go with that. So, Tisa, aapka
the risk scoring.
the risk that is, so there is Interheart and Framingham risk scoring probably comes closer to ours. They have also modified it on their own by putting us as non-Caucasians. The difference is minimal, but I think using it up right now will give us more advantage till we can validate this in our population, and that has not been done.
Persons who look after the hypertension in this part of the country. Nawaz Shahi Sahab, your comments please.
Thank you very much. First of all, I congratulate the organizer of this conference. They did well and organized, and they gather all experts in one platform in order to educate the juniors, seniors, and share the knowledge with each other, with seniors. I think a lot of discuss about the hypertension, prevalence, numbering, techniques, and management. Actually, so far the technique numbering depends upon which patients you are dealing. As Fawad already mentioned, the complicated, uncomplicated, but still there is a group of the patients, young patients, whose baseline pressure is around 90, 100 BP, and they present with a headache at the 130 and 120 of the BP. Where you put these patients? So my opinion regarding these patients, they treat every person according to their baseline BP. For that, you have to educate the population, general population. In the younger age, they should know their baseline blood pressure. What is their baseline blood pressure? So far, the uncomplicated BP is concerned. Regarding the technique and tools, I think every tool is better, but when our GP, our junior doctor should know the limitations of the every tool, because some tool needs training, some tools doesn't need any training in order to record that, and so digital BP is well, doesn't need any training, doesn't need any trained healthcare. You use them in the home, but some limitation their cost, and there is some limitation in the calibration. So just keep these things in mind when you are educating the general population. Okay, this is okay in the hospital, private hospital, or the public hospital, you can use these things. Taking is very important, a lot is discussed about that. Management and the drug, choice of drug is very important. So far we are working in the public hospital, make sure that every drug is good, but that drug should be good for the patient in the sense that he can purchase, he can use for a long term. The reason behind that is we give the little education to the patient, we give little time to the patient due to a lot of the patients in the hospital. And मैंने एक recommendation दी कि ये drug जो है ना हमारे area population में क्योंकि cost effective नहीं है तो हम यूज नहीं, वो कह रहे हैं कि आप poor patient को ये क्यों खिलाना चाहते हैं ये दवाई, why, और ये अमीरों को ये दवाई खिलाना चाह रहे हैं. मैंने कहा देखें यहाँ तो आप उनके घर में ऐसे बड़े इतना सोर्सेज बनाएं कि वो अफोर्ड कर सके. आप जो बंदा है मर्सिडीज गाड़ी चलाने का नहीं है तो आप उसको मर्सिडीज देंगे, दैट्स यूजलेस फॉर दैट. But if you give the cycle to that person, he uses properly and he uses with the limited resources. So long-term medication, short-acting drugs, they are very important. So we have to educate the peoples, use the drugs. That is the cost-effective for that person in order to make the long-term compliant. Because a lot of the conferences we are doing the different certificate courses.
Pakistan Hypertension League is doing for, they are doing the in-person online courses regarding to educate the GPs and so on. But problem still is that the awareness, poor control and poor compliance of the hypertension control is still there. So there is something lying behind, something is that that's not we are picking in order to give in the general population. So thank you very much. I feel honored to be with Professor. He is the teacher of teachers. So it's I think it's मेरे लिए बड़ी खुशी है कि मैं उनके साथ यहाँ बैठा हूँ. Thank you very much, sir.
Thank you. In our own vision, as things have moved, we have seen the urbanization and we have seen things changing. I come from a little bit of a village background and I've seen how people, rather than being walking and cycling, have now gradually moved towards motorcycles and vehicles. And I've seen their blood pressures gradually creeping up. That is true for the whole of the world, actually. There are examples and studies of Argentina, southern areas where they have demonstrated this beyond any doubt, that the lipids and the blood pressures are well monitored and controlled if you are doing regular exercise. Cycling, of course, is one of the simplest things to do, but it's the roads, the things that which are limiting us. Another thing of concern is that 3 of our friends of always, they are leaving us. The hands. Come COVID, we have stopped palpating the abdomen. We have stopped feeling around the patient. This is the reality. We now ask an ultrasound, a Doppler studies. The hands are going, the clinical skills are going. Professor Aziz is amply all the time talking about this fact, and a lot of my teachers are also, that the ability to take blood pressure correctly, repeatedly, sitting, standing, letting the patient wait, all the guidelines talk of still the old ways of medicine practicing. They all want you to come and sit comfortably. They all want you to have both your feet on the floor when you're doing your blood pressure. These are the basics, the essentials for blood pressure monitoring. Calcium score may be a very, very nice thing. Bashir Hanif Saab is supporting this idea like anything. But how do I explain to that 22-year-old boy who had his first massive anterior wall infarction yesterday in my hospital that calcium score is 0? How do I say these things? These are the limitations which medicine has. Let us try and make an effort that our other 2 friends, the stethoscope does not leave us, and we do not start relying on echocardiographies and ultrasounds all the time. And our other friend, the blood pressure apparatus, also does not leave us when, rather than sitting and doing the blood pressure monitoring and discussing with the patients, we then start relying on their home readings all the time, and we start giving other things the importance. Remember, medicine may be a science, but it is the art of communication. It is the art in which we all live and thrive. If you are not able to differentiate between these things, you will never be able to become what Professor Solith is, a teacher of teachers, and today he is the Hypertension League president of ours. These are the people who have made a clear-cut demonstration that this is the way medicine has to be practiced tomorrow. And with that, I'll say thank you, and we are going to break for 10 minutes. Professor Solith Saab, our teacher, and the President of Pakistan Hypertension League, very kind of you. Nawaz Shai Saab, a lead person over here. Thank you. Fawad, Amir, as always, brilliant, so very kind of you. Allah Hafiz. See you, we start again in 10 to 15 minutes when Dr. Nabil will take over.
We understand that we have been holding you quite long, so we are
Assalamu alaikum, ladies and gentlemen. I welcome you all on the behalf of organizing committee of PSIM, who have assigned me to the moderator of this cardiology session. My name is Dr. Nabil Akbar Chaudhary. I am an interventional cardiologist at Punjab Institute of Cardiology. Before I formally request all the faculty to please sit down, and all the delegates please sit down. Before we formally begin the session, let me call upon the stage our chairs. First, I would like to call Professor Khalda Somro. Professor Khalda is an interventional cardiologist. She is a former president of Pakistan Cardiac Society and a former chairman of Cardiology Department and Cath Lab Director, Dow University of Health Sciences. She is currently chairperson of Scientific Council of Women with Heart Disease and coordinator for Go Red program for women in Pakistan. Madam, please kindly take your seat on the stage, please. Next, I would like to call upon Professor Bashir Hanif. Professor Bashir is the Executive Medical Director, Tabba Heart Institute, Karachi. Sir, please join on the stage, please. Next, I would like to call upon Professor Khawar Abbas Kazmi. Professor Kazmi is Head of Preventive Cardiology, National Institute of Cardiovascular Diseases. Sir, please kindly join on the stage. Thank you, everyone. Heart failure is an important cardiovascular disease due to increasing prevalence and high mortality rate. Heart failure is associated with diverse range of complications such as hospitalizations, lethal arrhythmias, and deaths during the disease progression. In addition, heart failure can be a terminal condition for many cardiovascular diseases, including myocardial infarction, valvular heart diseases, and various cardiomyopathies. Due to unique characteristics, various pharmacological and non-pharmacological treatments have been developed not only to improve the underlying cardiac disease, but also prevent hospitalization and death. For years, ACE inhibitors and ARBs were the mainstay for treatment for heart failure. But then in 2014, a new kid came on the block, Ernie, and now recently in the mix has been added SGLT2 inhibitors, GLP-1 agonists, and selective cardiomyosin activators. To discuss in detail the recent updates to the management of heart failure, I would like to call upon Professor Bilal S. Mohyuddin. Professor Mohyuddin is Professor of Cardiology and Executive Director of Punjab Institute of Cardiology, and I would like to say my current boss at the moment.
Assalamu alaikum ji. Professor Khalda, Professor Khawar, Professor Bashir, it's indeed a privilege to be here and to talk on something which is close to our heart, in fact very close to the heart, because it doesn't make the heart work anymore. And as we move forward in our lives, it is these issues that need to be looked into very carefully. Before I start, may I ask you three, do you have heart failure clinics in your units, in your hospitals?
On it, starting a proper heart failure clinic.
So currently you don't?
Currently we don't.
NICVD?
Yeah, NICVD has it for last 3 years now, yes, 2 years.
For last 3 years, so that just shows the issue is still creeping up. And madam, in your center today, do we have a heart failure clinic?
In private sector, so there is no separate heart failure.
So there is such no separate heart. The reality of the matter is that heart failure is something which is there. Whether we like it or we don't like it. Whether we agree with a lot of literature and data that comes in that I'm going to be saying and talking about. You see, this arbitrary division that has been created in ejection fraction of 50%, 40% and below, then And when you say that person has got a normal ejection fraction and yet has got heart failure, so people are talking, what the hell are you talking about? The reality is the heart may be systolically functioning correct, but diastolically is not. Thus we see those flash pulmonary edemas coming in. Thus we see a lot of other issues which our friends from the diagnostic department keep talking about. The beauty of the situation is that the knowledge is gradually advancing. The unfortunate act behind it is that a lot of this knowledge which is advancing at a very interesting pace. Today my talk has been sponsored by Novartis Pharma, and these are my disclosures. There's no honorariums involved, there's just the travel and lodging that was involved. The reason why I say that this is interesting is because once you start involving yourself in these research and ideas, if you find anything in the research, in the pilot project, which is slightly on the negative side, you cannot talk about it. For good 10 years, that's what the contracts initially say. Unless then you start having those trials which then are talking about those negative things also. So a lot of data that actually comes in, and this motto of ours that we have, evidence-based medicine, many times the question becomes, is it evidence-based or is it evidence-biased? This heart failure business has been there for many, many years. People were living good, healthy lives earlier also. There are certain things in our lifestyle that have gone wrong. We are not exercising anymore. We're not eating right anymore. A lot of our food is adulterated. We have those questions coming in that, look, this is veggie meat which has been introduced. Things that were not supposed to be there. And they have all gradually crept in and made our life into a different style altogether. If a good lifestyle you have to follow, don't follow the lifestyle of a doctor. A terrible lifestyle which requires you to be under stress all the time. If nothing else, it's a patient's call. If nothing else, it's a family member's call. And if nothing else, it may be your own family which not be well. And since you know all those things, you start going into a heart failure yourself. And this is where the reality is. As the things are moving on, this heart failure business is going to progress. We all know from these slides that have been created that as time will progress, nearly 1 in 5 will have. So just imagine for yourselves that you are at the age of 50 and you can't breathe comfortably. There is someone who's going to have that problem. The only point is that like a smoker, we always believe that it's not going to be me. But when the bell rings for you, it rings hard, because then you tend to avoid it. So from a doctor's perspective, I'll request my colleagues to be very careful, because we are the world's worst patients. We are the ones who suddenly collapse. We are the ones who start committing suicides because of the burnout. These are all failures. And then the heart failure hits us like anything. And the fact is that whether you have got a preserved ejection fraction, whether you have got a midriff one, or whether you have got a low one, you are going to deteriorate. And as you can see, the deteriorations are quite same. So mortality rate at 1 year with a preserved ejection fraction is 29. For a reduced is 32, just slightly more. So you are in as big of a problem if you have had those heart failure problems. So try and find where do you exist. When you get your echocardiograms done and you find that your patient has got a 60 ejection fraction, is that all that you need to know? Don't you need to know if he has got a mitral regurgitation, mild one going on? Don't you want to know that what is the diastolic functions going on? And if you have got a better systems of friends working with you, then regional wall motions analysis in a better way. These are going to be the things which will help you and move in the right direction as time will progress. Heart failure, as you all know, is a waxing waning thing. You are doing reasonably okay, suddenly you have some problem and you end up in the hospital. The doctors over there give you inotropic supports, give you a diuretic therapy, and then once you start feeling well, you are back. But now, instead of climbing those 3 flights without any problem, you do get short of breath just before completing the 3rd one. And as time progresses, you start blaming everything on the fact that you have got arthritis and you can't walk up comfortably. The fact is that your body is decaying. And as your body decays, so does all the organs. That's where Bashir Hanif's calcium score really comes in, and he really helps us out and says that, look, things are not in the right side. Start looking beyond the basics. This is why it is essential that we need to do this. Otherwise, the standard statement is heard, Baba bilkul changa si, he had no problem, and then suddenly he had a cough and he died. The fact is that Baba had been gradually deteriorating. The fact is that we had not been looking into him carefully. And that is what needs to be done by all the physicians of today. We always talk of the diseases. We always talk of unfortunate problems that people have. Look at this, ladies. If you unfortunately end up with a breast cancer, your chances of surviving are far, far better than, God forbid, if you end up with a heart failure. Nearly 3 times better. The only thing which actually outclasses the heart failure in long term is lung cancers and lung issues. They're the only one which really outclass. That if you have it, you are gone in the next 2 to 3 years. But the rest is there. If you look up some of the old textbooks on heart failure, you'll see that they say that you lose 20% every year. 5 years, you are gone. Gradually, the medical sciences started working on it, started recognizing the whole things. This whole debate that we had earlier today about the hypertension numbers and the guidelines things, when they said that the blood pressure should be considered and they started monitoring it at 125, you are hypertensive. The idea was not as if you have to take medicine. The idea was that you should start taking precautions. If you have got a pot belly like I have, I should start doing an exercise a bit. And it seems a lot of us have these pot bellies over here. If you're not doing your regular walks, start doing them. If God Almighty is extremely kind on you and you have got the correct lipid profile, don't push your luck. If your pressures are good, that will not mean that they will remain good. So these are all the factors that you have to remember as time will progress. ESC guidelines have come up, and they have come up with all of these things, that sacubitril, valsartan. I'm going to go through these a bit at a faster pace because most of you have seen these slides many a times. And then they had this ACE inhibitors and being challenged out by sacubitril, valsartan as now the drug of choice. And do you know one thing? That if you look up all your pills, the 100 milligram pill which says 51 milligrams valsartan, this 51 milligrams is an anion, and that is why its efficacy is same as that of an 80 milligram. But a new trend that has started off is that this is not a hypertensive medication. This is still a heart failure medication. This is not being promoted on that side. So you have to remember to prescribe it and use it on that line. SGLT2 are there, and they are here to stay. Yes, tomorrow they may sound very good and they may go. But at the moment, they are here to stay, and thus in your patients, once you have got the heart rates and everything stabilized, it's probably appropriate to add this because this will help in a further better lifestyle and blood pressures monitoring further. Same is for, of course, the ARBs, and never forget the diuretics, especially in a condition when the patient has got a bit of decompensation going on. These are all the drugs which are now gradually being moving up from class 2B to class 2A. And in a few years down the road, you'll see these drugs moving into class 1. Because as the evidence is going to come up and as they are going to move into the textbooks, they will be in class 1. The ESC guidelines which have come up over here, excuse me, according to the ESC the diagnosis should include the following: symptoms and signs, ejection fractions, objective findings. The heart failure clinics, when are being run, they have to be run on these very models. You have to have these things. And the most basic thing is usually not practiced in our outpatient, and that is we never weigh our patients. If you weigh your patients, you can always have a better assessment to those swellings that the patient is complaining of. And from there you can start saying that you need to and guide the patient that they need to get rid of 3 or 4 or 5 kgs of fluid, and that is where the body weight is going to go. These are, of course, all those algorithms that you have seen multiple times: the ACE inhibitors, the BBs, the beta blockers, the mineralocorticoids, now the AMPA is there, and the loop diuretics. And as the things are, that whether you have got an ICD need or whether it is a CRTD need, these are all there for them. By the way, anyone have, the young people sitting, anyone has any idea what does a CRTD cost? What is the cost of this device? That we so quietly tell our patients, go and get this device. Then let the young one, you of course know the prices. Young people, do you have any idea? Well, you are always young, so for that matter, there's no problem. When these devices are placed, you are talking anything, they cost 2 million rupees at least. Now remember this, that you are so easily going to say this thing to a patient while you are resisting the fact of the treatment cost. The treatment cost from the day 1 to day end, which is, let's say, about 20 years that a person's life you want to progress, if possible. Normally it's about 5 to 10 years that you are hoping for, but if you are able to. So if, let us say, in 20 years, you have to spend those 20 million, so it's $1 million a year that you are talking about. So 2 million, so it's 100,000 a year that you are talking about. लाख रुपया 1 साल का. इस लाख रुपए को 12 पे तकसीम कर लो, 8,000 रुपए महीने का. 8,000 रुपए को 30 दिन पे तकसीम कर लो. तो अगर तुम एक मरीज को अपने 200-300 की दवाई दे देते हो और वो दवाई उसको वो फायदा लॉन्ग टर्म में दे सकती है, तो डोंट गो इनटू दिस डायरेक्शंस. Another thing that we very quietly talk about is, and tell the patient, go for a heart transplant. Do you have any idea what does a heart transplant set you back? Even in USA today, about 2,500 or 3,000 heart transplants are done, and the normal survival is about 5 years. Yes, there are people who have done better. आपको 4-5-6 करोड़ रुपए की बात कर रहे हो, 1 साल किसी और मुल्क के शहर में जाके रहने की बात कर रहे हो, बिकॉज उन्होंने बायोप्सीज रन करनी है आपकी. यू आर टॉकिंग मिलियंस. सो डोंट, जैसे कि पिछले ने कहा था, डोंट ऑफर पेशेंट्स things that they cannot do. Don't make them feel deprived. What you need to do is tell them, do this, start off now, and that is where your protection is. अगर ये करते जाओगे तो कल को तुम बचे रहोगे. अगर ये नहीं करोगे तो फिर तुमने अपने लिए खुद ही मुसीबतें पैदा कर ली है. तो आगे से सवाल आएगा, सर क्या ये लाजमी हो जाएगा मैं बच जाऊंगा? The answer is you don't know the answer. वो हुक्म रब्बी है. And you have to say that very clearly. That if you have it, but if you take up the right path, it will protect you. And that is where we'll make a difference. So your basic things have to be done. Your essentials have to be followed. And then, of course, there are the new mechanical devices that are now coming up, the left ventricular assist devices, which again set you back good about $1 million. The normal survival of a left ventricular assist is about 5 to 6 years. Yes, we have 1 or 2 of those patients who have survived even a decade. But again, there are limiting factors. These are the things which we because we have them in our knowledge bank, we very easily talk about them. But the fact is that it is your basic medication and the corrections of life that have to be done. And that is where the physician's role as a human being comes in. So let us not create patients for others. Let's do the basics for our own people. Of course, the basic treatment is the ACE inhibitors, the beta blockers, the MRAs, and now the SGLT2s, and in case of crisis, you go for the diuretics. Make sure that out of the 100,000 patients that you're seeing, you don't need to push any further down the road. And it can be done if your hospitals have those heart failure clinics. I'm totally ashamed of the fact that I come from an institute now, that I'm leading now, and we don't have a heart failure clinic over there. While a friend of mine in Sialkot, he has a heart failure clinic, and it's not even an interventional center. The basic thing is that we are not paying attention to what needs to be done. We are paying attention. You are not a cardiologist if you do not know how to hold a wire. You are a cardiologist actually if you know how to look after a patient. Wiring, these things are something totally different. Your focus for tomorrow should be on that direction, which makes you a better human being, a better doctor at the end of the day.
There are 1 minute left.
खुदा के वास्ते अभी तो स्लाइड मैंने दूसरी भी नहीं की. Anyway, so I'll rest it out now. So ANI is something is recommended in de novo, etc. And acute heart failure is there. These are the 22 guidelines which came out. This, of course, is the validated line guidelines which actually were there to be looked into. Of course, the paradigm heart failure trial came out, and most of you have already seen it when these trials were being done, and had that run-in period with enalapril, sacubitril, and then they had those 2 groups divided, and they showed that the primary outcome was 20% reduction in CV death, 20% reduction in CV mortality, and 21% in hospitalization. Do you know the reason why we are talking of these hospitalization costs? Go to your hospital and do a basic maths. The salaries that you are paying and the utility bills you are paying, and divide that with the number of beds you have. That is the basic cost of treatment that you are giving. Currently, that cost in our country is anything between 5 to 10,000 rupees in a government hospital. This is the amount the government is spending on every patient every day, and the Branula is not even in yet. So these are the facts that you need to know. That is why they don't want the patients to come into the hospitals. That is why they need to have that reductions going on. This, of course, is a slide that you have seen that your quality of life improved a lot in your personal lives and in every way. The Pioneer Heart Study trial was exceptionally good because it actually had a crossover also between the enalapril and sacubitril, and then it showed over here that you made a big difference between the two. Enalapril was taken up as the drug of choice because initially it showed the best improvement in the heart failure trials that were done earlier, and over here they showed that a difference. But the beauty fact came later on when at the 8th week they did a crossover that those who were on enalapril were given sacubitril valsartan, and even they started improving a lot. Paragon trial is another one. 2 minutes, okay. Paragon trial is another one, and that also goes on from there. And over there the trial analysis was that based on these were the findings, the Paragon heart failure narrowly missed the primary ones. The overall safety profile was similar to that of Paradigm, and based on previous trials, the potential benefit showed that the patient with EF below the median 57% had biological possibilities of improvement. Ejection fraction was there, and this basically showed that if the slide shows basically that if your ejection fraction is really down 15-20%, probably it's not going to make much of a difference. But if your ejection fraction is good, 35%, start prescribing it, and probably at around 60%, it will not make much of a difference in the patient's life. But again, you have to find out why did the patient have a heart failure with an ejection fraction first. The European Society of Cardiology guidelines advocate the implementations of nurse-led heart failure, and this is something which is extremely essential. So if you have got those heart failure clinics, get your nurses trained into it, and they have shown a definite benefit about it, and the cost benefit, 25% was seen over there. And if you look at this graph, basically, the study done in Lorraine in France, that the heart failures really improved a lot. So basically what they were doing was that things like they're looking after the patients, monitoring their heart rates, getting the chests cleaned out all the time, and making things that the basics were right. So if you do your basics right, I hope that is going to the place. And let us hope that we all can go ahead back to our units and set up our heart failure clinics. And thank you, sir. And sorry for the extra 2 minutes and 55 seconds. Thank you.
Thank you, sir, for giving a holistic approach to the heart failure. Talking about holistic approach, we'll be moving on to the next talk. Cardiovascular disease is a major cause of morbidity and mortality across the globe. Prevention and management of cardiovascular disease pandemic calls for the concerted actions on part of all healthcare professionals, and as well as the concerned stakeholders. We call it cardiovigilance, and it is defined as the action or state of keeping careful watch to prevent, screen, diagnose, and manage cardiovascular disease in a timely and appropriate manner. To discuss this holistic approach for prevention of atherosclerotic cardiovascular disease, I would like to invite our second speaker for today's session, Professor Tariq Wasim. Professor Tariq Wasim is a renowned physician with deep-rooted interest in cardiology. He was former professor of medicine at King Edward Medical University and currently working as professor of medicine at Akhtar Saeed Medical and Dental College, Lahore. Professor Tariq Wasim, please.
Thank you. On? Right. Thank you, Nabil. And so, atherosclerosis is probably the root cause of a lot of cardiovascular diseases, and the spectrum of morbidity ranges from angina and ischemic heart disease and mortality to erectile dysfunction as well, right? The mortality is quite high. We do have about 17 million deaths because of this atherosclerotic disease, and it is likely to rise to around 24 million by 2030. Now, what's this data has been shared by Nabil, our moderator, who comes from Punjab Institute of Cardiology. What's the situation over here? This is the situation in our hospital, and I think Khavar and Bashir will bear me out that the same is everywhere. This is the situation of our emergency department, screening rooms, waiting area. You can't even walk, right? And this is the figure. We have about 1,000 patients visiting our emergency department of Punjab Institute of Cardiology, which is the largest center in Punjab, and we have much bigger over here in, say, Karachi. And of course, the figure would be 1,000 patients in emergency, 100 admission a day, output 3,000 admission from emergency, and up approximately 30,000 admissions a year. And this is 2020, all right? And it must have gone up, and you may have much larger figure if you extrapolate it to all of Pakistan. 7,000 emergency cath procedures every, say, in 1 year. 18,000 elective cath procedures, and about 3,000 surgeries. Now, if this is the situation, what we are doing too little, too late. We are at the tip. There is a lot of burden on the rate, right? And whatever we are doing is that interventions allow the patient to live and cope with the advanced disease and heart failure, and probably not preventing disease at the first hand. So if we want to make some dent into this, we probably need to work down when the disease has just started, right? So there has been, the efforts have been focused primarily on treatment of the manifest disease, what we are doing in our institutions, but this needs to be changed, right? So there is a need for a holistic approach to assessment and to detect and to treat the disease well before it becomes clinically evident in the form of heart attack or heart failure, or if interested, erectile dysfunction, right? So there is, how do we start with? It was 1948 when we first time the Framingham study established that the factors which are responsible for possibly causing atherosclerotic disease, they stand into hypercholesterolemia, hypertension, smoking, diabetes, and if we manage them, we can reduce this risk. Then came this MR Fit or Mr. Fit trial, that if you intervene and if you reduce these factors and you treat them, you are likely to prolong reduce the incidence of manifest disease. Then the famous physician heart study, which about 50 or 60 years ago we started putting everyone on aspirin for prevention, whether he has or does not have 40-year plus, give aspirin to everybody. And then there was a follow-up, this was statin studies, and this statin probably made the major difference, that starting from 1994 when 4S study was published, there is a lot of data onto that the statin do help, and probably out of the many things, they are the ones which are likely to stay with us for preventive purposes for quite some time. There was a follow-up of this Mr. Fit trial 27 years after the first trial, and it still showed that even 22 years later, it still was benefiting and it was beneficial. We know the risk factors: diabetes, smoking, obesity, physical, the conventional one, and some non-conventional, and some of the newer one. Even autoimmune diseases make you more at risk. Depressive illness, there was talk by Zaman Sahib in the morning, depression and diabetes, depression, heart disease. So that also is a risk factor, right? Then there are risk enhancers. There are conventional risk factors which further increase your risk. Family history of premature disease, chronic kidney disease, metabolic syndrome, preeclampsia and premature menopause has also been linked with an increased or risk enhancing for this atherosclerotic disease. And now this inflammatory disease and immune system and inflammatory markers, they also been, and of course the South Asian ancestry, I mean, we are more at risk of this, right? So the risk enhancers would be a persistently elevated cholesterol of more than 160 or persistently elevated triglycerides of more than 175 are risk enhancers. In selected individuals, we can measure highly selective CRP, lipoprotein A level, lipoprotein B. For the juniors sitting over here, these are all the markers which enhance or which increase the your chances of patient having this. Add to it albuminuria, and add to it a very simple tool of ankle brachial index. Bilal was talking in the morning that we are getting away from the clinical examination more into the tools and more into the gadgets, but there are simple things which can predict your possibility of your patients having this, right? In diabetic patient, there is an additional thing, all right, like duration of diabetes, more than 10 years increases your chances of developing say atherosclerotic complications more. Albuminuria, GFR, retinopathy, neuropathy, and again ankle brachial index comes into that. Now, how much a factor adds to or contributes to? A diabetic has 4 times more risk of developing atherosclerotic disease. Smoking probably increases your risk by 2.5 times. If age above the 40, every 5-year increment increase a risk by 1.6 times, and of course there are other factors as well. So this is the factors which contribute to atherosclerotic disease. And of course having one factor versus multiple factor, that also adds up. You have one factor without risk factor, the mortality probably with multiple risk factor goes 3 times higher as compared to a single factor being there. Similarly, they don't come in isolation. They usually come together or one after the other, right? So you have a previous MI, you are more likely to have 5 to 7 times more risk of having another MI. If you have a 3 to 4 times like risk of having a stroke, a previous stroke, you are 9 times more likely to have another stroke in your lifetime, and 3 to 3 times more likely to have an MI, and same with the peripheral arterial disease. Despite all that factors known that prevention works, treating things probably can prevent the disease at a later stage and probably would reduce or lessen the cost of care. Cost of care, as Bilal mentioned, in the earlier phase would be much lower rather than when it is onto the stenting or cabbage or onto this, and similarly the morbidity and mortality it would be much lower if you prevent it earlier on. But attention on prevention is lacking, and similarly the Bilal posed the question, how many of our institutes have a preventive cardiology setup started on? Is there a dedicated preventive cardiology service at any of our institutes? However,
I think Dr. Havar has it.
Havar has it probably, the only one probably, they are the pioneer one.
We have it at Taba also.
Right.
Yeah, but other than that.
And do we have a dedicated preventive cardiology program?
Yes.
Teaching program?
Teaching program, no.
Yes,
we are actually starting a MPhil in preventive cardiology.
Right.
We are in the process
because
of
that's where I finally want to bring it to, that we have to set up a dedicated preventive cardiology services or okay. Right. So the Pakistan situation is we define the risk factors, and what we do have independently, only 41% of our population is hypertensive, 1% is using tobacco, 21% are obese by definition, 17% have high cholesterol, and 17% plus minus have diabetes. Right? So, before we start anything, we need to know the risk. And for knowing risk, there are a lot of tools available. This is a simple tool available on your mobiles, on apps, ASCVD risk calculator, ASCVD plus risk, and just 1 or 2 minutes data filling can give you your patient's risk of having ASCVD in next 10 years. All you need to do is put in your age, your gender, your race, whether you're white, American, or Latin, or Asian. You put in your systolic blood pressure, diastolic blood pressure, cholesterol level, HDL cholesterol, LDL cholesterol, whether you're diabetic or not, and then whether you are a smoker or not, and whether you are on any hypertensive treatment, on statin, and this would give you, calculate your risk of having atherosclerotic disease or event in next 10 years, right? Okay. Now this is the calculation comes out. If your risk comes out to be 5% or less, you have a low risk. Between 5.5% to 7%, you are at a borderline risk. Between 7.5 to 20%, you are at intermediate risk. And a high risk individual is who has a risk score of more than 20%. What do we do? You have this calculation and you have this data. So what ACCA recommends, that those who are in a bracket of 20 to 39 years, they should be screened every 4 to 6 years. Even before, whether we are talking of those patients who do not have any symptoms, they are 20 to 40 years of age, and you have to calculate this every 4 to 6 years, and if the risk is intermediate to high, then we'll talk about the interventions as well. For those 40 to 75 years, you calculate their 10-year risk by using this is called pooled cohort equations, which we use for this, and then in adults or who are at a risk which is borderline or intermediate risk, you have to start additional risk enhancing factors. I just showed you the risk enhancing factors. So you take in consideration of those and then decide about whether any pharmacologic intervention is needed or not. We'll talk about pharmacologic intervention in a moment. Right. Now in adults with an intermediate risk of 7.5 to 20 or are selected adults with 5 to 7%, if race decision is based decision is that preventive remains uncertain, कि जिसे कुछ देना है कि नहीं देना है. We're talking of interventions, not right. Then there has to be this calcium artery scoring done, and if their score is high, then they probably would be requiring some interventions, right? For adults who have
score between 7.5 and 10-year risk, there we estimated lifetime risk or a 30-year risk. There is another ASCDVD plus calculator, and that will give you a risk for next, say, about 30 years or lifetime risk. And if that has, right, we can beat. This is an area in Japan where government promotes the simple living style, living on vegetarian diets only, and the average age of these individuals is approximately 85 years. So if they can be done, how can be done? We have to start from the basics. Nutrition. All adults should consume a healthy plant-based or Mediterranean diet, rich in vegetables, fruits, nuts, whole grain, preferably. So that is the first point, that we start not from the medication, we start from dietary modification. Then you have to promote the physical activity. All adults should be engaged at least 150 minutes per week of a moderate intensity, or 75 minutes. I hope Professor Javed Akram is here, very enthusiastic about the gym and all that physical activity. Sir, may I have your attention? Your topic, that physical activity. Right, okay. So then the obesity, simple 5% weight loss would give you a lot of benefit in the form of improving your blood pressure, lowering your cholesterol, reducing your risk of diabetes or improving diabetes. And if all this, there are recommendations now that you may think of some pharmacological therapies or even bariatric surgery if this obesity is in a, say, range which is probably comes into the morbid obesity range. Smoking, and I just want to one comment about this new fashion of this electron nicotine delivery systems or e-cigarettes. They are equally bad. They are equally bad, and they should be discouraged. Look, this what we call as vaping and all that, and we have all this shisha clinic and all that coming up. वो cigarette हमने छोड़ा था धागे को कागज वाला, तब वो जो उसकी जो नई जगह है वो उतनी ही नुकसानदेह है. So we have to cut down, and also every visit they should be say counseled about quitting smoking, not reducing smoking. वो कभी कभी थोड़ा थोड़ा करके छोड़ने वाला कभी नहीं होगा. Right. Diabetes, of course, you need to control that, but Bilal mentioned that this new class of drugs have shown evidence of not only controlling the diabetes, but also cardiovascular benefits. And this SGLT2 inhibitors and GLP-1 are receptor agonists. They have shown benefits beyond their glycemic control, and sometimes they are recommended in patients and select patients for weight reduction and for management of this prevention of heart failure and prevention of others. The lipids, so what the guideline says, for those who are less than 19 years of age and have a familial hypercholesterolemia, statin should be started. 19 years at that very younger age. But for young adults, they estimate your lifetime risk and promote a healthy lifestyle first before you think of adding a statin or any therapy. But for those who have a family history of premature atherosclerosis, risk enhancers, their LDL cholesterol is at more than 160, a statin therapy should be considered, preventive, not after he has had a heart attack or a diabetes. And for age 75, there is a question mark that overall lifetime risk assessment should be done, and then you decide about this. Right? Statins, again, the decision to start statin may also take into consideration with a high calcium artery score of more than 100, they should be started on statin. Those with intermediate range, we should discuss that whether or not to start. But those with a risk of more than 20%, risk discussion, and to initiate statin therapy and to reduce LDL-C by 50% should be a preventive strategy. Hypertension, a target of less than 130/80 should be kept in mind, and repeatedly on each and every visit should be enhanced or discussed with your patients. Aspirin. We have President Aspirin Foundation here. and great advocate of aspirin. Aspirin has been with us, and we have been, this physician art study made us that everybody should be on aspirin. This has now changed. So it should not be administered on routine basis for prevention to age below 70 years, should not be. But it should be considered for prevention at the, in those, for a secondary prevention, it would stay on. But for primary prevention, there is, since the risk of GI bleed and all that, and particularly in patient age 75 plus, you probably have to be cautious about. And in fact, this is the latest about 2 weeks ago, this US Prevention Services Task Force, which said that this absolutely not is becoming a more of a repeat. So it should not be absolutely not recommended for those aged above 60 years. I'm talking about primary prevention, not for those who have already had an event. Of course, that still would stay there in patients who have had an event or had an intervention, right? But not right. For those 40 to 59, aspirin could be considered if their risk, which हमने शुरू में calculate किया था, is more than 10%, and should consider stopping after the age of 75 years for primary prevention purposes. What's prevention? Prevention is the action aimed at eradicating or eliminating or minimizing the impact of disease and disability before it has hit you. There are various levels or stages of prevention. The primordial starts with that you have to maintain health and avoid risks. That is, again, healthy living, healthy diet and everything. Then comes the primary prevention, which our topic is today. You reduce and eliminate the risk and avoid clinical disease events, right? And then comes the secondary prevention, that you had an event, and after that you don't want that event to happen again. So that would be secondary prevention. And of course, tertiary would be where those interventional cardiologists and all those they would come into. So we want to talk about this primary prevention, right? So who does it? That's the important question. State, local government, because we need to have places to exercise, footpaths to walk, right? School teachers who advocate, parents, peer groups, that would be right. Food authorities, कि जी हमारा जो food content है उसमें क्या हम खा रहे हैं क्या नहीं खा रहे हैं वो हमें बताएं. Family physicians, the first encounter उसके पास आता है उसका, he should tell us. Or internist, diabetologist, cardiologist, smoking cessation program, and of course all this may have to join. It may not be that's what we call the holistic approach, and that's where this preventive cardiology comes in. That you have to take in everything into consideration, and that cannot be, we have isolated diabetic clinic, isolated hypertension clinic, isolated lipid clinics. But we need to combine them together to have a holistic approach for that, right? So secondary prevention, as I told, probably would be more at after the event has happened, and there of course it would be, again, you need to take people on board, not only the interventionist but probably the internist and family physician as well. Now this is, you maintain blood pressure, physical activity, use of aspirin, diabetes, diet, emphasis on good diet, tobacco. So this is the jigsaw puzzle. You have to fit in each and every this chunk of this pie to complete the prevention. It is a team based. You have to have everybody on board, and it has to be patient centered. You have to look at the patient preferences, cultural background, dietary preferences and literacy. So this is where we need to join. Local authorities have to play their role. General practitioner has to record their blood pressure at every visit. Pharmacists should have a opportunistic technique कि जब भी आप दवाई लेने जाएं आपका blood pressure भी check हो जाए. That could be a very simple of detection of hypertension. कामरान लशारी, हम लशारी असल में कामरान, हमारे पास कामरान लशारी बहुत है तो हमारे कामरान मुंह से निकल जाता है. Okay, right? And then the community settings that आप अपनी जो work places है उसको इस तरह से friendly बनाए कि वो थोड़ा सा प्रिवेंटिव फ्रेंडली हो, कुछ चलने की जगह हो. हम एस्केलेटर ना यूज करें, हर वक्त लिफ्टें ना यूज करें. हम ये जो काम है, माल में जाएं तो वो क्या कहते हैं आप उसको कि ट्राली पकड़ने के लिए एक अलग बंदा होता है और सामान रखने के लिए एक और 7 बंदा होता है, वो ओके. दिस इज माई लास्ट 2 slides. फैज सेज बर्बादी दिल जब्र नहीं फैज किसी का, वो दुश्मन जहां है तो भुला क्यों नहीं देते. राइट, सो दुश्मन जहां, ये सारे वो जो रिस्क फैक्टर्स हैं वो हमारे दुश्मन जहां हैं, और जब हो गया तो हमें कहता है बेदम हुए बीमार दवा क्यों नहीं देते, तुम अच्छे मसीहा हो शिफा क्यों नहीं देते. थैंक यू वेरी मच.
Thank you very much, sir, for your elaborative talk. I would like to update the numbers. I think he showed 23,000 procedures and 7,000 PCIs. Unfortunately, last year we increased to 34,000 procedures and 9,900 PCIs, including 900 PCIs. So I don't say that is a good news for we and an interventionist, but is a very bad news for our patients and failure of our preventive cardiology side. So in the interest of time, we will be saving the questions for the lunch and a break. I would like for our panelists to brief comments. First, I would like to call Professor Khabar Abbas Kazmi for his comments on the 2 talks, please.
Okay, thank you very much. Excellent talks as expected. Prevention obviously is something which is very dear to me, very close to me. I've been passionate about it. But we must admit, I think we haven't been able to achieve much here in this field. It's not even, attractive slogan as yet. I mean, we have been talking about it. I have spent about 20 years plus talking about this thing, and I don't feel that we have really made a progress. There's no question, I think, as Zima said, that we all need to be together doing it. It has to be a holistic approach. But I think the question remains that who is going to bring all of us together? We remain in our silos, unfortunately, in isolation, and that's why we have not been able to make a difference. Prevention is also a key to heart failure. I mean, that's going to be the new epidemic for all over the world, including Pakistan. The numbers are bad for Pakistan also. But majority of the heart failure happens because of either atherosclerotic coronary artery disease or because of hypertension. So prevention again remains the key for heart failure as well. Management of both the diseases, whether it is coronary artery disease or heart failure, remains very expensive and inadequate. So the way has to be prevention, but how do we do it? I'm not sure what are the new things. I mean, maybe our younger nation population can do something better, bring something out of the box which really makes this as the priority. Thank you.
Thank you very much, sir. Professor Bashir Hanif.
Thank you very much. Excellent talks by Bilal and Professor Tariq Wasim. I think both topics are very, very important. And I would have just 2 quick comments, one on heart failure and then on prevention. See, what I feel is that I think prevention is definitely important, but even the treatment of heart failure, as a cardiologist, I can tell you that in last, 20 years, I think I have felt that heart failure is the most poorly treated heart condition, which I see from all physicians, whether it's a cardiologist or a general physician. I've seen patients with a heart failure with a reduced ejection fraction on ivabradine and trimetazidine and all those kind of things, but not on beta blockers, not on ACE inhibitors, and now ARNIs is the new thing. But those are the 2 most important things which reduce the mortality in heart failure, clearly shown in multiple studies. But despite that, patients won't be on that. They will be on furosemide and a lot of other things, but the most important like MRAs, aldactone or beta blockers and ACE inhibitors are not. So I think we definitely fail in that. Secondly, regarding heart failure clinics, I think it's important to have heart failure clinics, but it's not just going to be a clinic. You need a lot of if you really want to have a heart failure clinic, which is like in Western centers, there is a lot goes in, because we are actually right now working on it to really establish a kind of heart failure clinic, and we have been in touch with a lot of people in US and UK to see how can we do it. And it's not just a clinic. You have to have a lot of support system at nursing level, at physician level, as well as later on at home level. So lot will need to go in, but these are the most important thing. I think in Western culture, it has significantly reduced the mortality to have separate. So I think all centers should try to work on to establish those heart failure clinics. Lastly, regarding prevention, I think Howard has said it, and I would say it also. As a cardiologist or as healthcare professionals, I think we have miserably failed in trying to do anything about prevention. And as Professor Tariq mentioned, I think heart disease mostly are preventable, and we need to really do something about it. Unfortunately, there are a lot of factors and the reasons behind it, and obviously one of the major one is financially driven. As an interventional cardiologist, obviously I will be looking for CATs and interventions, and I think it's very difficult. There's only 1 or 2 preventive clinics or preventive departments, no preventive seats in government hospitals, and private hospitals also have the least really to buy into it. So I agree that we need to work as together, but I think as silos, every center starts doing something, at least there will be some drop in the ocean. So we need to work on that and try to see. There is no data available, there is no research. We were talking about these risk calculators, and earlier it was mentioned too. These risk calculators may not be applicable to our setup. When you go and look into this pooled cohort equation for risk calculation, it's Caucasians and others. We come into others, so we don't know what that others mean. So we need to have our own data to really have that kind of a risk calculators and try to find out why we are having heart disease at young age group. We are working on, luckily we have a funding and starting a study by the name of Pak Sehat, in which we are going to have young patients with no heart disease and have their baseline workup, including a CT angio and calcium score, and follow them over 10 years, and we'll be also calculating the risk score in those patients. Hopefully that will help us to find something, but again, I think everyone need to put their efforts to try to do something about it, because this is really becoming an epidemic. The heart disease is becoming epidemic, and in low and middle income countries, and Pakistan is going to be affected the worst. So I think we all need to play our role wherever we are working. Obviously teamwork is very important, but I think till that stage, whatever as individual we can do, we should definitely try to do that. Thank you very much.
Thank you very much, sir. At the end, I would like to ask Professor Khalda Sumro for her closing remarks.
सबसे पहले तो ऑर्गेनाइजर्स को मुबारकबाद देना पसंद करूंगी, जिन्होंने इस तरह का इंटरैक्टिव सेशंस जो मैंने आज ऑब्जर्व किए, उन्होंने अरेंज किए. अगर यही इंटरैक्टिव सेशंस जो हम बड़े शहरों में बैठकर होटल्स में बैठकर करते हैं, अगर हम छोटे शहरों में छोटे इंस्टीट्यूट्स में करें तो शायद इसका इम्पैक्ट कुछ ज़्यादा ही हो. क्योंकि मैं जो यहाँ पर डॉक्टर्स कम्युनिटी देख रही हूँ, दे बिलोंग टू अर्बन एरिया. मोस्ट मेजॉरिटी ऑफ आवर पेशेंट्स कम्स फ्रॉम द रूरल एरियाज. यहाँ पर ये मैं नहीं कहूँगी कि हमारी जो इस प्रिवेंशन की रेस्पॉन्सिबिलिटी है सिर्फ एक तबके पर नहीं है कि कोई इंस्टीट्यूट कर रहा है, आगा खान कर रहा है, या तब्बा कर रहा है, या NICVD कर रहा है. नहीं, जहाँ पर हमारा गवर्नमेंट भी रेस्पॉन्सिबल है, सोसाइटीज़ भी रेस्पॉन्सिबल है, कॉलेज ऑफ फिजिशियंस एंड सर्जन्स भी रेस्पॉन्सिबल है, और हमारा PMDC भी रेस्पॉन्सिबल है. जब हम वर्कशॉप्स कॉलेज ऑफ फिजिशियन एंड सर्जन्स में अपने पोस्ट ग्रेजुएट्स को करवाते हैं कि भाई ये भी होना चाहिए, रिसर्च भी होना चाहिए इस पे, व्हाई नॉट ऑन द प्रिवेंशन एंड हाइपरटेंशन और ये आपके हार्ट फेलियर प्रिवेंशन के इसके पर क्यों नहीं करवा रहे होते हैं? दिस शुड बी इंक्लूडेड एंड फॉरेन फंडिंग एजेंसीज जैसे WHO है, वो मस्ट इन्वॉल्व देम कि वो हमारे साथ पेरिफेरल एरियाज में जाएं और जाकर इस पर काम करें। वो सबको पता है कि हम प्रिवेंशन की जब बात कर रहे हैं तो दैट इज़ वेरी मच इम्पॉर्टेंट। और जो जैसे डॉक्टर बिलाल ने कहा कि हम इंस्ट्रूमेंटल या मतलब ये जो डिवाइसेस हैं we cannot afford, we are the low socio-economical country, we cannot afford. Simply, we have to produce our doctors. मुझे याद है मेरा प्रोफेसर कहता था कि जी सिस्टोलिक डिसफंक्शन अगर है तो you must listen the third heart sound. If there is diastolic dysfunction, you must listen fourth heart sound. हमने अपने हाथों को यूज़ करना छोड़ दिया, हमने स्टेथोस्कोप यूज़ करना छोड़ दिया है, हमने सुनना पेशेंट को छोड़ दिया, हमने खुद ब्लड प्रेशर एपराटस यूज़ करना छोड़ दिया है. वी आर डिपेंडिंग ऑन दी पैरामेडिकल स्टाफ. हमें नहीं पता है कि वो कैसे देख रहा है. वी हैव टू एड्रेस ऑल दीज थिंग्स. being a doctors community, being a physician societies and being a cardiac societies. So I hope कि आज अगर कोई कंक्लूजन होगा तो हमें इन सारे सेक्टर्स जो हैं इसके रिस्पॉन्सिबल सेक्टर्स उनको एड्रेस करना होगा, उनको ये पैगाम देना होगा कि हर आदमी अपने एंड पर इसमें कंट्रीब्यूट करे. थैंक यू सो मच.
Thank you very much, madam. Professor Bilal would like to make a brief comment, please.
Thank you, Naveed. Basically, I just want to promote a point that Tariq Wasim Saab has very elaborately pointed out. He pointed out the risk profiling, how disease risk profiling is calculated. He showed to you that if you have diabetes, you are 4 times more liable to have a problem. And if you're a smoker, you're more than 2 times liable. By the way, do you have any idea which is the world's cheapest country where the cigarettes are made and sold?
Pakistan.
Anyone?
Pakistan.
Pakistan. We are the cheapest country in the world today for smoking. Your best cigarette, the gold leaf, is $1 only. डॉलर महंगा हो गया ना, और वो पहले से इतने का था, पहले $100 का था, आज उतने का है. यही गोल्ड लीफ पैकेट outside is $10 to $15. You are all having a party these days in this country as far as smoking is concerned. We always think it is impossible. सिंगापुर में 30 साल पहले उन्होंने कहा जी ट्यूब्स ट्रेन्स बनानी है, और उधर फैसला ये हुआ कि ट्यूब ट्रेन्स का जो न्यूयॉर्क का डेटा था, they were spending a couple of $1 million in New York in 70s in cleaning only the chewing gum. So they decided that if they want to have this thing and they want to cut down the cost, Singapore is a country where you're not allowed to sell your chewing gums. And if you're consuming any, you have to dispose them off very carefully. Otherwise, you get fined $500 first time, second time $2,000, and third time a 6 months imprisonment. These are the facts of countries who have been able to do things. हाँ, आपके पास एग्जाम्पल मक्का की है कि जहाँ पे सिगरेट अलाउड नहीं है, लोग ब्लैक करते हैं वहाँ पे. मगर अगर आप अपने सिगरेट को मुल्क से बैन नहीं कर सकते, अगर आप इसकी कीमत भी नहीं बढ़ा सकते, तो कम से कम अपने मरीजों को ये तो बताओ कि तुम्हारे साथ होता क्या है. अगर आप मरीज को सिर्फ ये कहते हो सिगरेट मत पिया करो, और वो आगे से आपसे पूछो क्यों, तो कह रहा है कि बिलाल साहब ने कहा था. Now that doesn't work. You have to know the fact that it causes vasospasms. You have to know that that increases your carbon monoxide content. You have to know that it increases your chances of thrombosis. You have to know all of those facts. And then you have to show to them, जैसे इन्होंने कहा कि जी अगर एक बंदे को एक दफा स्ट्रोक हो गया, how did he have that stroke? So unless you don't all start working on preventions as it has to be, you will never get anywhere. और सर आपके साथ एक छोटी सी गुजारिश, मेरे अस्पताल में गलती है, प्रॉपर हार्ट फेलियर क्लिनिक नहीं है सर, कल शुरू कर दें। अल्ट्रासाउंड जो कैपेबिलिटीज आज रखती है ना, जब ये बनी थी तो इसमें नहीं थी। सो यू स्टार्टेड ऑफ, यू विल फाइंड द प्रॉब्लम्स at Punjab Institute of Cardiology. We were not doing a 24/7 365 primary PCI. 27th of Ramzan at night we started off that program. We are having a lot of set of problems with that. We will fight, we'll continue to improve. Unless we do this primary prevention, and of course as Professor Khalda said, that for this you need to go to the grassroots level. वो जो आपका घी तेल जो गलत आ रहा है ना, वो हम पढ़ा नहीं सकते, वो हमें पता है, हमने जाके उनको चेक करवाना है और गवर्नमेंट से बैन लेने हैं। आप लोग ऐसी जगहों पे हैं जहाँ पे आप ये करवा सकते हैं। Let's try and put our hands together and improve this country. Thank you.
Thank you very much, sir. Thank you very much. I would like to thank all my chairs and all the senior faculty and all the delegates for being a wonderful audience. We'll be breaking for a short while for lunch and prayer break for 30 minutes, and we'll be joining back in this session at 2:15 with the internal medicine session, where Dr. Wafa will take over the session and move forward with the internal medicine session. Please be back at 2:15. And lunch is at the back of the registration desk.
Medical University. Sir, thank you for chairing this session for us. Our first talk for today is about the second National Diabetes Survey of Pakistan that was planned to ascertain the updated prevalence of diabetes, pre-diabetes and associated risk factors at the national and provincial levels. And to discuss the results, I'll invite our first speaker, Professor Abdul Basit. He's Professor of Medicine, Bakai Medical University, Regional Chair, IDF MENA Region Council, Director, Bakai Institute of Diabetology and Endocrinology, Karachi, Pakistan. He is also the Joint Secretary for Diabetic Association Pakistan, founder, member of the Pakistan Endocrine Society, Vice Chairman Health RAP, Principal Investigator Diabetes Registry of Pakistan, and he's also the Project Director for the Gestational Diabetes Mellitus Prevention and Control Program Pakistan. So please, you may take over and discuss the results of the survey.
अच्छा करो लेकिन फिर मैं नेक्स्ट स्लाइड में करूँगा बस ठीक अस्सलाम वालेकुम थैंक यू फॉर द इंट्रोडक्शन चेयरपर्सन मैं स्टार्ट एक साहब ने पहले ही कह दिया कि तो रिजल्ट्स तो पुराने ही होंगे क्योंकि 2016 और 17 का सर्वे है तो दिस इज़ राइट इंशाल्लाह आई विल टेक यू थ्रू द रिजल्ट्स ऑफ द सेकंड नेशनल डायबिटीज़ सर्वे. This survey was conducted jointly by Diabetic Association of Pakistan, which I represent as I am the Secretary General now and Director of Bakai Institute of Diabetes Endocrine. We had the Ministry of National Health Services Regulation and Coordination supporting us, and at that time the PHRC, Pakistan Health Research Council. We had the approval from the National Bioethics Committee of Pakistan. These were the 17 teaching hospitals and or diabetes centers which worked with us for this survey across the country. And these are the urban and rural distributions which we had for each of the colleague. Some were truly rural like Chichavatni and Kotaddu, thousands of people, and Alipur, Kotdiji, Nara. I'm just talking of the rurals and not talking of the urbans. So across the country, it was a very good representation, pure epidemiological survey taken through the computerized way, the way it's being done these days. The important aspect of this survey before I discuss the result was the funding. And once, first of all, when we sent to BMJ and for funding, we wrote no funding involved. So there came the reply that how can we have a survey done without funding? So we have to elaborate what we mean when we say no funding involved. The field visits and data collections, including clinical and anthropometry measurements, and fasting and GTT were run by the respective teams through their own funds. तो हमने कहा हमारे पास पैसे नहीं हैं, आप टीचिंग हॉस्पिटल्स में हैं, आपके पास स्टाफ है, आपके पास स्टूडेंट्स हैं, आपके पास पैरामेडिक्स हैं, आप फील्ड पे जाइए, फील्ड हम आपको बता रहे हैं कहाँ जाना है. तो रूरल या अर्बन आपका कंप्यूटर से जो निकला है वहाँ जाइए. और चूँकि ग्लूकोज सैंपल्स के अंदर फास्टिंग और रैंडम में स्टैंडर्डाइजेशन बहुत ज़्यादा मुश्किल नहीं है, ग्लूकोज सैंपल्स वहीं करके आप GTT करके ये रिजल्ट्स तो हमें दे दीजिए. रह गई बात HbA1c और लिपिड प्रोफाइल्स की. देन वी वेंट टू द मिनिस्ट्री एंड रिक्वेस्टेड कि भाई 10,000 का सैंपल साइज़ है, वी हैव गॉट द GTTs डन, प्लीज़ हेल्प अस आउट. सो दे काइंडली अरेंज इट थ्रू PHRC. पूरा सर्वे कोऑर्डिनेशन, पूरा सर्वे का माइंड, प्रिंसिपल इन्वेस्टिगेटर्स एटसेट्रा, ऑल वाज सपोर्टेड एंड डन बाय बाइट for 1.5 years through their own resources. अब नंबर्स कितने निकले? तो न्यूली डायग्नोज डायबिटीज़ 7%, नॉन डायबिटीज़ 19.2, ओवरऑल डायबिटीज़ 26.3. जब ये नंबर्स आए थे तो दो किस्म के रिएक्शंस थे, विच इज़ ऑब्वियस. कुछ ने तो कहा ऐसा तो हो ही नहीं सकता कि हर चौथा आदमी डायबिटिक हो, और कुछ ने कहा ये एक्सपेक्टेड था क्योंकि अगर इसका आधा 20 साल पहले था. द फर्स्ट सर्वे विच वाज डन वाज 1994 to 98. तो 20 साल में वी वर एक्सपेक्टिंग दीज रिजल्ट्स. सो मिक्स बैग था, मगर it took a time to prove that these are the numbers. Pre-diabetes 14.4% निकली, ये IDF Atlas है 2021 में जो एडिशन आया, which is the latest 10th edition. Unfortunately अब तक पाकिस्तान नीचे था, यानी जब मैं डायबिटीज़ की प्रैक्टिस करने पाकिस्तान आया था तो उस वक्त हम 8 थे, फिर 7th हो गए थे, फिर एक एटलस में 6th हो गए थे, उसके नंबर्स क्वेश्चन मार्क डाले गए, काफ़ी अरसे से 4th थे. Now we are 3rd in the world, only after China and India, and that is because of the populations there. पाकिस्तान की, इंडिया और चाइना की पॉपुलेशन के इस वक्त कोई कंपैरिजन नहीं है. तो अगर एक लिहाज से देखा जाए, और जी भी IDF के एटलस में एक जगह लिखा है कि द लार्जेस्ट प्रिवेलेंस इन अ लार्ज कंट्री, तो वो पाकिस्तान है. लार्जेस्ट प्रिवेलेंस परसेंटेज के हिसाब से, नंबर्स में आके चूँकि इंडिया और चाइना की पॉपुलेशन ज़्यादा है तो वो हमसे ज़्यादा है. अब 3,30,00,000 पाकिस्तानियों का मसला है. इसी को ग्राफिकल ले ले, जो मैंने कहा कि पीछे बीच में क्वेश्चन मार्क आ गया था कि ये नंबर्स कहाँ से आए, बट द ट्रू नंबर्स आर दिस एंड दीज आर द एक्सट्रापोलेशंस व्हिच IDF डज. ऑन टॉप ऑफ इट हाइपरटेंशन ले लें डायबिटीज़ के साथ साथ, तो 46% हाइपरटेंशन है इस कोहोर्ट में. और ये चूँकि प्योर एपिडेमियोलॉजिकल सर्वे है, क्लिनिक बेस्ड सर्वे नहीं है. ये आपने बोर्ड नहीं लगाया कि डायबिटीज़ हाइपरटेंशन स्क्रीन होगी. अगर ये लिखेंगे तो सारे हाइपरटेंसिव आ जाते हैं, सारे डायबिटिक आ जाते हैं. ये प्योर सर्वे कि जी हेल्थ सर्वे है, आप आइए, अवेयरनेस है वगैरह वगैरह. एक दिन पहले पूरी टीम घर घर जाके काउंसिल करके आइए कि ये पाँचवा बंदा आप आएंगे, आपका टेस्ट होगा. लाइक वाइज फॉर ओबेसिटी के बारे में तो अब एक लेक्चर अलग से लिया जा सकता है कि WHO कट ऑफ्स, एशियन कट ऑफ्स में जो हम ओवरवेट कहते हैं, अब तो सभी ओवरवेट हो गए ऑलमोस्ट एशियन कट ऑफ्स पे तो. एंड देन वी डू नॉट बिलीव दैट दीज कट ऑफ्स आर करेक्ट विच आर सो साइंटिफिकली प्रूवन. मुझसे ज़्यादा मेरे कार्डियोलॉजी के और ऑन्कोलॉजी के कोलीग्स बेयर मी आउट के इस लो BMIs पर वी आर सीइंग ऑल what we tend to see with obesities in Caucasian population. तो हमारे obesity के numbers staggering है. डिसलिपिडीमिया अजीब कंसर्न है. हमारा कोलेस्ट्रॉल, पूरी कौम क्या डिसलिपिडीमिक है. तो कुछ लोगों ने तो कहा कि जी जब ऐसा होता है तो वी नीड टू रिवाइज द कट ऑफ्स. हमारा कहना ये कि साइंटिफिक एविडेंस लानी होगी इवन फॉर रिवीजन ऑफ द कट ऑफ्स, और लार्ज डेटाबेस या लार्ज डाटा सेट चाहिए होगा. स्मोकिंग का या टोबैको कंजम्पशन का मैं एडमिट करूंगा कि ये नंबर सही नहीं है. इससे बहुत ज़्यादा नंबर है, क्योंकि सर्वे डायबिटीज़ ओरिएंटेड था, NCD ओरिएंटेड था. इसके अंदर स्मोकिंग के या टोबैको के या स्मोकलेस टोबैको एटसेट्रा उसके वो क्वेश्चन एरा में नहीं डले थे. तो ये बहुत रूडिमेंट्री नंबर है. इससे आगे की मुझे बात करनी है असल में, और ये एक WHO का डॉक्यूमेंट है, अभी ग्लोबल कॉम्पैक्ट में आ रहा है. ये मैं हायरार्की जो ऑडियंस में उससे शेयर करना चाहता हूँ. ये पॉइंट्स हैं जो ग्लोबली असेस किए जाते हैं एज कि आप डायबिटीज़ में कितना काम कर रहे हैं. तो डू यू हैव अ रीसेंट सर्वे? पहले मेरे साथ पॉइंटर को फॉलो कर लें. रीसेंट सर्वे है, कोई टाइम बाउंड टारगेट्स हैं NCD के, ऑपरेशनल पॉलिसी है, वर्टिकल प्रोग्राम्स फॉर डायबिटीज़, ओबेसिटी, फिजिकल इनएक्टिविटी, कोई नेशनल गाइडलाइंस हैं, स्क्रीनिंग मोडेलिटीज़ आपके पास क्या हैं, मेडिसिन्स, ओरल इंसुलिन, और प्रेजेंस ऑफ नेशनल रजिस्ट्री. अब ये मीना रीजन में दिखा रहा हूँ जो मिडिल ईस्ट नॉर्थ अफ्रीका है. तो एक ग्रुप 1 में आप वो लोग देखेंगे अक्सर बहरीन, कुवैत वगैरह, जहाँ अक्सर ग्रीन टेक्स्ट नज़र आ रहे हैं. वेरी सेल्डम रेड क्रॉसेस. सऊदी अरेबिया, UAE, इनमें पॉलिसीज़ भी बन गई हैं, वर्टिकल प्रोग्राम्स भी हैं, रजिस्ट्रीज़ भी हैं, एट्सेट्रा. अब उसके बाद आ जाए ज़रा सा सेकेंड टियर, ग्रुप 2, जिसमें इजिप्ट, ईरान, इराक वगैरह, ये मिडिल इनकम या लो मिडिल इनकम, इनफैक्ट हाई मिडिल इनकम में आते हैं ये लोग. इनके भी आप देखेंगे तो एवरेजली ग्रीन और रेड क्रॉसेस तकरीबन बराबर है. अब इसमें आ जाए जो ग्रुप 3 है, जिसमें अनफॉर्चुनेटली बट नॉट सरप्राइजिंगली पाकिस्तान एक है. और आप देखें हमारे पास सिवाय ये सर्वे जो मैंने शो किया और सिवाय रजिस्ट्री जो हम अभी आके डिस्कस करते हैं, और ये थोड़ी सी दवाइयों के यानी टेक्नोलॉजी के, कुछ भी नहीं है हमारे पास. नो वर्टिकल प्रोग्राम्स, नो ऑपरेशनल पॉलिसी, नो टाइम बाउंड टारगेट्स, एटसेट्रा. تو ہم کیٹیگرائز ہوئے ہوئے افغانستان، جیبوتی، صومالیہ، سوڈان، یمن کے ساتھ انفارچونیٹلی. اینڈ دا ریزن آئی کیم ہیئر ایٹ PSIM از کہ یہ بہت بڑا پلیٹ فارم ہے اور اس میں کارپوریٹ سیکٹر کی طرف سے بھی اور فنڈنگ کی اور طرف سے بھی بہت ایکسپیکٹیشنز ہیں. وی نیڈ ٹو ریئلی ڈو سم تھنگ if we have to have a change in the society one day or the other. اب یہ میں دکھانا ہوں رجسٹری کے بارے میں. تو ہیلتھ ریسرچ ایڈوائزری بورڈ آف وچ آئی ہیپن ٹو بی وائس چیئرمین انڈر دا لیڈرشپ آف پروفیسر بلو صاحب, ہم لوگوں نے رجسٹری کا کانسیپٹ دیا کہ وی نیڈ نیشن وائڈ رجسٹریز, ڈیزیز رجسٹریز بنا رہے ہیں. ون آف دیم از ڈراپ وچ از ڈائبٹیز رجسٹری آف پاکستان, اور اس کے اندر ہم ڈراپ 1, 2, G فار جسٹیشن, F فار فوٹ ایٹسیکرا بھی بنا رہے ہیں. اب یہ رجسٹری اس لیول پہ پہنچ گئی اور اس وقت جیسے یہ پولیٹیکل چینج تھوڑا سا آ رہا ہے, ورنہ یہاں تک پہنچ گئی تھی رجسٹری کے NIH میں ساری رجسٹریز بیس ہو جائیں گی. اینڈ ڈائبٹیز ول بی دا رول ماڈل یا ٹریگرر یا پہلا والا ٹیسٹ سیمپل ڈائبٹیز رجسٹری ہوگی. ڈیش بورڈز وغیرہ بن گئے ہیں, فیڈرل اینڈ پروونشل منسٹریز کے پاس ڈیش بورڈز ہوں گے تو ڈائبٹیز رجسٹری کک آف ہو جائے گی. وہ انفارچونیٹلی ابھی فی الحال کچھ مہینوں کے لیے ڈیلے کہہ سکتے ہیں, پروسیس ہو گیا, لیکن رجسٹری سٹارٹ ہو چکی ہے اور ڈیٹا آنے لگ گئے. اب ایک اور امپورٹنٹ ایسپیکٹ پہ آئیے, کیا ہمارے پاس یا کہیں بھی اب یہ پھر WHO کا ڈاکیومنٹ, پالیسیز آن مارکیٹنگ آف فوڈ ٹو دا چلڈرن, پالیسیز ٹو ریڈیوس سالٹ کنزمپشن, policies on saturated fats, trans fats, policies on ban on industrial elimination of industrial trans fats, taxes on sweetened beverages. یہ ٹارگیٹس ہیں جو لیے جا رہے ہیں فرام دا WHO فار دا کنٹریز. اب اس میں دیکھیں جو ہائی انکم کنٹریز ہیں, بحرین, کویت, عمان, قطر, سعودی عربیہ, UAE, you can see lot of ticks. I still say کہ یہ 100% نہیں ہے, but lot of ticks. اگلے گروپ پہ آ جائیں ابر مڈل انکم کنٹریز. اگین میں سرپرائز نہیں ہوں, مگر ایران آپ دیکھیں آلموسٹ 100% ہر پالیسی میں ہوتا ہے, آلموسٹ 100%. اب یہاں پاکستان پر آئیے, there is no tick whatsoever. No policy on food to children, no policies on salt consumption reduction, no policies on fat. یہ شہزاد صاحب آگے, ان کو ہم ویلکم کرتے ہیں, یہ ہماری دہائی کو ذرا سن لیتے ہیں اور پبلک ہیلتھ کے ہوتے ہوئے ذرا سمجھ بھی لیتے ہیں. خیر سمجھ تو سبھی رہے ہوں گے, پر یہ ہماری ذرا رونا سمجھتے ہیں کہ کیا رونا رویا جا رہا ہے. اب دیز آر تھنگس جو بہت آسان ہیں, کوئی بہت مشکل نہیں ہے. دے آر ناٹ انوالونگ راکٹ سائنسز. سچ بات ہے کوئی بہت بڑے بجٹس بھی نہیں چاہیے. یہ افغانستان, صومالیہ وغیرہ کے ساتھ ہم کھڑے ہوئے. سو وی روٹ اے لیٹر فرام ڈائبیٹک ایسوسیشن آف پاکستان. لاسٹ ایئر میں نے یہ ریکویسٹ کی تھی, بھائی ٹیکسیشنز کو دیکھ لو, 11% ٹیکس ہے FED آپ کا آن سویٹ اینڈ بیوریجز, اس کو 20% کر دیجئے. یہ میں نے لیٹر لکھ کے لاسٹ ایئر بھیجا تھا, اور بالکل اس وقت بھیجا تھا جب یہ بتایا گیا تھا کہ اب بجٹ بننے والا ہے, اور ہمیں یہ ری ایشورنسز دے دی گئے تھے کہ اس دفعہ یہ ٹیکس ریوائز ہو جائے گا. اور ہم نے کیس بنا کے بھیجا تھا باقاعدہ کہ آپ یہ ٹیکس بڑھائیے, ٹیکس سے جو ریونیو جنریٹ ہوگا آپ اس کو پرائمری ہیلتھ کیئر پہ لگائیے, یونیورسل ہیلتھ کوریج پہ لگائیے, آپ اس کو پرائمری پریونشن پروگرام میں لگائیے. اور پھر اس کو ساری انٹرنیشنل باڈیز نے میرے اس لیٹر کو سپورٹ بھی کیا تھا. اب یہ دیکھیں 3 مئی کو دوبارہ لیٹر آئے اس سال. پچھلے سال ہم نہیں سکسیسفل ہو سکے, اور کچھ لوگ سننا چاہیں گے کہ کیوں نہیں ہو سکے. تو آبویسلی ایک کمپنی بس پہنچی اور ایک ملاقات کری بجٹ سے 2 دن پہلے, اور 500 ملین آفر کیے, اور انہوں نے کہا جی ابھی ٹیکس نہیں لگائیں گے, اگلے سال لگا لیں گے. 500 ملین سے ہم پاکستان ہرا بنائیں گے, پانی اچھا بنائیں گے, اور یہی مینوفیکچرنگ شروع کر دیں گے, ایٹسیکرا ایٹسیکرا. جو بھی, میں اس میں پولیٹکس میں نہیں جانا چاہتا. تو اس سال ابھی پھر 3 مئی کو IDF پریزیڈنٹ اینڈ پریزیڈنٹ الیکٹ نے لیٹر بھیجا. اب یہ ہم نے آج سب کو ڈسپیچ کر دی. all whom we know will have an effect on the budget انشاءاللہ. پلیز انکریز دا ٹیکس. جن کنٹریز نے صرف ٹیکس بڑھا دیا, فلپائن نے کیا کیا فار ایگزامپل, ٹیکس بڑھایا, $40 ملین کمائے اس ٹیکس کے بڑھانے سے, اس کو یونیورسل ہیلتھ کوریج پہ لگا دیا. मोरक्को ने टैक्स बढ़ाया, सऊदी अरब ने टैक्स बढ़ाया, कंजम्पशन आपका कम करके दिखाया, डायबिटीज कम करके दिखाई. गवर्नेंस का इशू है हमारे यहाँ. तो PC1 KP में, पंजाब में तो डायबिटीज़ का और NCD का फिर भी बहुत अच्छा हाल है. मुझे अभी लेक्चर से पहले भी इंट्रोड्यूस किया गया कि पंजाब कितना आगे डेवलप कर रहा है. हमारे सिंध में भी कागज़ तो बन गया, यही कह सकते हैं. विद रिस्पेक्ट टू ऑल आवर दोस्त, ये MOU भी साइन हो गया. मैडम अजरा पेचू वॉज वेरी काइंड एंड शी आई थिंक इज़ वन ऑफ दोज सिंध गवर्नमेंट में, सिंध मिनिस्ट्री में जो बात ले लेती हैं. तो हमने MOU साइन किया, 1 साल के करीब हो गया इस MOU को साइन हुए हुए, फॉर स्टैंडर्डाइजेशन ऑफ केयर. फिर आप लोगों को शायद पता हो सिंध में प्राइमरी हेल्थ केयर के ज़्यादा इदारे PPHI के पास चले गए, आउटसोर्स कर दिए गए. तो हमने PPHI के साथ भी MOU साइन किया हुआ है. अब इनकी ट्रेनिंग कर रहे हैं फॉर पायलट्स. तो ये मटियारी में हुई, टंडो अलायार की ज़रा ये रमज़ान वगैरह से डिले हो गई. बट व्हाट वी आर डूइंग इज़ डूइंग 2 पायलट डिस्ट्रिक्ट्स. हमारे जो बिल्लू साहब ये बताते हैं कि हैंड्स वालों ने ये किया कि 2 डिस्ट्रिक्ट हेपेटाइटिस फ्री कर दिए मलीर के अंदर. अब उनको रोल मॉडल बना रहे हैं फॉर पैन पाकिस्तान रेप्लिकेशन. ऐसे हम ये डायबिटीज़ के 2 डिस्ट्रिक्ट्स पे कंसंट्रेट कर रहे हैं. MOU साइन कर रहे हैं फॉर स्टैंडर्डाइजेशन ऑफ केयर. ये बस फाइनली स्लाइड है जो मैं दिखाना चाहता हूँ. क्लिनिशियंस को पब्लिक हेल्थ डोमेन की तरफ आना होगा. या जैसे शहजाद साहब कह रहे हैं कि पब्लिक हेल्थ वालों को जो पहले समझते थे सिर्फ डेंगू और मलेरिया और जनाब कीड़े ने काटा, साफ़ पानी, अच्छी हवा, इसके अलावा कुछ ये भी सोचें. नॉन कम्युनिकेबल डिजीज़ का बर्डन है, एपिडेमिक है, मिलियंस ऑफ लोग इन्वॉल्व हो गए. इट्स अ पब्लिक हेल्थ इमरजेंसी. तो हमारे MOU साइन हो रहे हैं. वेरी ग्रेटफुल टू HSA, टू ZEBIS, टू JINA that we are now entering into public health programs regarding related to diabetes with such colleagues. एक फाइनल ये कि इस दफ़ा फिर कोशिश कर रहे हैं. लास्ट टाइम हमने कोशिश की 5 साल पहले, सेंसस के लिए जा रहे हैं, घर घर जा रहे हैं, पूछ रहे हैं बच्चे ये वो सब कुछ. भाई ये मोटे मोटे सवाल भी पूछ लो 2-4 कि डायबिटीज़ है कि नहीं, ब्लड प्रेशर फैमिली में है कि नहीं, हार्ट डिजीज़ है कि नहीं, हेपेटाइटिस है कि नहीं. ये आपके पास डेटा आ जाएगा मिलियंस का. तो लास्ट टाइम हम रह गए बकौल डिपार्टमेंट ऑफ स्टेट्स के और हेल्थ मिनिस्ट्री के कि पेपर्स प्रिंट होने चले गए थे सेंसस के. अब फिर कोशिश कर रहे हैं कि जो नेक्स्ट सेंसस हो उससे पहले ये आ जाए. वॉट वी फील दैट वी शुड हैव मैनेजर्स ऑफ NCD इन द कम्युनिटी. मल्टीपल स्टेक होल्डर्स को इन्वॉल्व करना, कॉर्पोरेट सेक्टर को, फिलेंट्रोपी को, डोनर्स को, इंडस्ट्री को, multiple stakeholders, many various societies को. तो you shall have people who are masters in NCDs, advocacy के अंदर etc etc. ये फाइनल स्लाइड ये कि आपको प्राइमरी प्रिवेंशन की बात करनी होगी. पाकिस्तान में आप 3 करोड़ 30 लाख डायबिटिक्स का इलाज कर भी लोगे जब तक 3 करोड़ और तैयार हो जाएंगे. तो यू हैव टू हैव स्ट्रेटजीज. ये रैपिड स्कोर है, ये एक पूरा अलग से लेक्चर है. पाकिस्तान एंडोक्राइन सोसाइटी इज़ टेकिंग दिस बर्डन ऑन. अभी बात चल रही है उनके साथ टू रोल आउट अ नेशन वाइड प्राइमरी प्रिवेंशन प्रोग्राम. मुझे ये अंदाज़ा है कि PSIM डिड साइंड एन MOU विद पाकिस्तान एंडोक्राइन सोसाइटी फॉर प्राइमरी प्रिवेंशन. पता नहीं उसको किस स्टेक पर लेके गए. ये हम IDF सेंटर ऑफ एक्सीलेंस हैं. डायबिटीज़ के हवाले से हमारे करिकुलम, हमारे कोर्सेज वगैरह रिकग्नाइज्ड हैं. ये पूरा काम हो चुका है जो यहाँ है. इन डिब्बों को पढ़ने की ज़रूरत नहीं. ये काम हो रहा है, हो चुका है, होता रहता है. क्लिनिशियंस काफ़ी काम कर लेते हैं. ये 2 काम पे हम अटके हुए हैं, गवर्नेंस एंड रोल ऑफ मल्टीपल स्टेक होल्डर्स. इसके लिए मैं जितने भी आइडियाज़ होंगे लूँगा. आई विल वेलकम एनी सपोर्ट, एनी कंट्रीब्यूशन. आई एक्नॉलेज माई नेशनल collaborators, the international collaborators, and I thank you all for your attention. Thank you very much.
Thank you very much, sir. Clearly, indeed, I think as a nation we need to realize that the burden of non-communicable diseases is ever increasing. As we move on to our next topic, genetics research studies. So we'll take questions.
We can take at the end of that.
We will take it towards the end. Genetics research studies show us how individual genes or group of genes are involved in health and disease. Understanding genetic factors and disorders is important in learning about promoting health and preventing disease. But there's a question. Is there more to this discussion? And that is what our next topic is. What controls you? Is it your genes or is it your shit? This is a very interesting topic and a great speaker, Professor Azizur Rahman. He's Professor of Medicine at Rashid Latif Medical College, formerly Professor of Medicine at Services Institute of Medical Sciences, Senior Vice President, PSIM, Editor, Journal of PSIM, and former Editor-in-Chief of Escalapio, which was the official journal of services of Institute of Medical Sciences. His main areas of interest include diabetes, hypertension, and chronic hepatitis. He is known to all to simplify things and teach in the most easiest manner possible. So sir, please take over. We are looking forward to this talk.
All right, I think, first of all, let me apologize for this name of my title. I thought it would be catchy and it will make people a little curious, what is this about? You know, our fecal matter, half of it is almost bacteria. And bacteria are a microbiota. So when I say shit, actually it refers to microbiota of our gut. Disclosure, nothing to declare. And first of all, let me talk about the role of microbiota in health, and then we will very briefly, this is actually extremely vast subject. Even if I go through it quickly, I will be only touching just the important parts. You know, it is generally thought that fetus in the womb is without any bacteria. This is what we used to think, but now the evidence says even in the amniotic fluid there may be some parts of bacteria present, not in the live form, but there may be some kind of microbiota there also. But this is how it develops when the child is exposed. First of all, depends how the child was born. Was it vaginal delivery or was it cesarean section? Then exposure to external environment, which is inherently filthy. Infancy and childhood, different microbiota develops in different parts of the body, and then they become stabilized. Almost at the age of 3 years, everybody has a unique microbiota, and then it does not usually change, but during acute illnesses it may be perturbed slightly, but then it is stabilized again. There's so many factors which actually contribute what exact microbiota you would have. So it is the exposure to the external, potentially filthy environment which helps our microbiota to develop. So I took this slogan from an advertisement, this is not conflict of interest, but this is just to highlight that dirt is indeed good to develop our immunity and our microbiota. Now, every part of the body has different microbiota, particularly gut. Gut is very, very rich in bacteria and many other organisms, but all body surfaces, all body orifices, they have unique bacteria and other microorganisms. Now, yes, okay, so this is how in the first 2 or 3 years microbiota develops, and then it remains stable and remains stable throughout our life. But during acute illnesses, there may be slight disturbance, but then it becomes, in most cases, it becomes stabilized again and healthy microflora is restored. In some cases, of course, this disturbance becomes permanent and patient develops a disease. Now, it is actually an essential organ. Maybe if I say life would not be possible without microbiota. I don't think I'm exaggerating. Now, let's give you some facts. 13 trillion human cells, and we have 130 trillion bacterial cells. So 10 times. You have 13 trillion your own cells, and inside 130 trillion bacterial cells, every normal healthy person. Almost 1,000 bacterial species and many other organisms. 20,000 human genes and 2 million bacterial genes, 10 times. And if we isolate the total DNA from your body, 99% of that DNA would be bacterial. Only 1% comes from your host cells. So these are the staggering figures. So if we measure our total microbiota, the weight is equivalent to our brain. So I think it is plausible that this rich microbiota in our body has some essential role. Of course, we will examine it, what kind of role it has. Now, microbiome, or a second human genome. We all know our genes control. My height, my complexion, my hairstyle, my way of eating, and my way of talking is all determined by genes. If you examine your genome, 99% homology. Somebody sitting in this hall is 99.5% similar to another person who may be sitting in Chile or New Zealand. Only 0.5% diversity as far as genome is concerned. But when we examine microbiome, only 5% homology. Every person, the person sitting to you, the next to you, has got 95% different microbiota. So that is what makes you actually unique. Every individual has a unique signature microbiome like your DNA. And it is definitely possible that if the science is fully developed, it will be possible to recognize somebody from the microbiota. Now, if I compare a very simple thing like plant of rice, it has got 40,000 genes. And in human, there are only just over 20,000 genes. But there are additional 2 million microbial genes. So I believe these genes, they work together. And that is how this complex body functions are performed both in health and disease. So based on this new concept, International Human Microbiome Consortium was developed in 2007. They had series of meetings and they have developed this new science. And you know, conventionally, microorganisms are studied under microscope and their stain and their culture. Do you know that less than 20% of the bacteria are culturable? Other microbiota, 80%, you cannot even culture them. You cannot even stain them and see them. They're hidden. But thanks to this new technology based on 16S rRNA gene sequencing, now apparently there may be 2 E. coli which are exactly similar looking, same staining characteristics, same morphological characteristic, but based on this 16S RNA, there may be millions of subtypes of E. coli. So this is how we have gone into new era. There are simulators of the human intestinal microbial ecosystem. They have developed an artificial environment which is very much like our colon, because colon is the host of microorganism, and that has helped to study this new organism. ITIP, these are the applications which can be used to study these organisms. Now, how host, that is ourself, which is only 10% if we count the cells. If we respect democracy, which we have to, 10% of our cells are our own host cells and microbiota 90%. How do they interact? Now you can see the human cells and microbiota, they interact either way. Both affect each other and both are affected by the environment. And this is the complex interplay. Now let me now give you some idea how we, the host, affect our microbiota. We are not yet talking about disease, we are just talking about their normal role. So how this gut microbiota, how we affect them. For example, mode of birth. I already mentioned if there is vaginal delivery, the likely microbiota is of different type, and cesarean section, microbiota will be of different type. And that may actually translate into future diseases. Diet, whether the baby was breastfed or formula fed, whether in the childhood and in adult life was the diet primarily plant-based or meat-based, that can determine your microbiota. Usage of antibiotics, and we are so fond of prescribing antibiotics, people don't even need a prescription. But let me make a point, that 90% of the antibiotics are used in agriculture industry. So even if you do not take any antibiotic, you're still taking indirectly through the vegetables and fruits, and there is effect. And so antibiotic, they definitely have effect microbiota. Then drugs, any drugs like proton pump inhibitors, metformin, statins, laxatives, many other drugs are known to affect our microbiota. Diseases, inflammatory bowel disease and irritable bowel syndrome. In both, microbiota are of different type, but it is hard to tell at this stage which is the cause and which is the effect. And sleep, even our sleep pattern, our this circadian rhythm can affect our microbiota. And pets, you may be surprised to know that exposure to pets in early life actually prevents many diseases. Exposure to pets, in our culture, it is generally considered not right thing to be exposed to pets or animals in the childhood, but it actually helps. Now the second part, how our microbiota affects us. It affects us in digestion. There are several things which our intestine, our pancreas cannot digest. We need the help of a microbiota, especially the cellulose plant region. And many bacteria, they actually produce folates, vitamin K, biotin, riboflavin, cobalamin. And then their defense, definitely they have a very, very important role in defending against colonization by opportunistic pathogens. And they also help in the development of our immunity. Very, very important. And then, 5 to 10% of the daily caloric needs are met by the calories which are harvested by our microbiota from those nutrients which would otherwise go waste. So 5 to 10% of the calories, they come from the microbiota, in other words. And they produce several short chain fatty acids such as acetic acid, propionic acid, and butyric acid. They all have some very healthy roles in our body. And then there's concept bacterial translocation. When bacteria get entry to the blood, they can cause bacteremia, endotoxemia. That is, of course, a pathogenic state, but by bacterial translocation, I mean that some components of bacteria, they actually get translocated into the circulation, and they have effect on the liver and fats and other metabolism. So this is how our microbiota affects us. Now, microbiota and human disease. When I search this topic, guess, this is the PubMed. I'm sure everyone is familiar. This is the search engine which gives you the medical literature, which are published in the peer-reviewed journal. 19,940 papers on this topic, gut microbiota and human disease. And there has been a lot of interest in the last decade or so. So a lot of interest in this field. Now this is, there are theories about many diseases that they could be linked with our microbiota, but this is a common ground theory. Now you can see interaction of environment and host and microbiome, environment versus host, host versus microbiome, and this is very nice relationship, truly win-win situation. We live in harmony, we benefit from microbiota, microbiota is benefiting from us, but something goes wrong and this relationship is disturbed. And this disturbed relationship is called dysbiosis. Now this dysbiosis can further cause a disease. But it is difficult to tell at this stage, is it the dysbiosis which has caused disease, or is it the disease which has caused dysbiosis? It could be either way. But very important concept I'm going to explain to you. If you have this animal and if you transfer this dysbiotic microbiota to a healthy animal, and if that healthy animal develops a disease, that will be proof of concept that this microbiota is actually responsible for that trait or that disease. And this has been seen, and this has been shown in this Clostridium difficile infection, autism spectrum disorder, asthma, obesity, at least in lower animals, but some cases in humans also. So this is the common ground theory, how a dysbiotic organism can cause disease. Now, when we examine the role of microbiota in different diseases, these are 5 areas of interest. There are actually more. I will just briefly examine the possible role of microbiota in these 5 groups of diseases: infection, visceral diseases like gut, liver, and brain, allergic disorders and autoimmune diseases, metabolic syndrome, and obesity, which is perhaps the biggest disease of today, and atherosclerosis, which is the ultimate killer. So there is potential role of microbiota in the pathogenesis of these diseases, and there is at least theoretical possibility, but by modulating, we may be able to prevent these diseases. Let's first take infection. And all of you know this Clostridium difficile infection. So the theory is that somebody developed some infection which was to be otherwise self-limiting, but that person was given antibiotic, and that led to dysbiosis. Mostly, even after an antibiotic, dysbiosis will be reversible, but in some unfortunate person, that would promote the growth of Clostridium difficile infection, and that would lead to very severe colitis, which would be life-threatening. Not only that, it may lead on to develop what is called multi-organ dysfunctional syndrome. So it becomes a systemic disease. Now, can it be reversed? Of course, it can be reversed. Now, we have seen in those patients who have this Clostridium difficile infection, which are refractory to the most potent antibiotic, if they are treated with this FMT, fecal microbiota transplantation, there are various techniques, there is 94% response rate. So very, very definitive proof that transplantation of fecal materia can help in the treatment of Clostridium difficile. But there is a possible downside also. There is transmission of infection and unwanted trade. What I mean by that, I will show you by an example. And that is why we will have to select the donor. Not that anybody can donate fecal matter, but we will have to choose donors also. Now, infection with H. pylori, you know H. pylori infection is extremely common, and it may cause dysbiosis, then APD, and then it is definitely possible that it may lead on to develop cancer. There are many other infections. I might not be able to go into details, but bacterial vaginosis may increase the chances of preterm birth. Some women who had some specific bacterial vaginosis, of course the symptom of vaginosis will be there, but symptom may be silent, but this infection through this microbiota can actually cause preterm birth, acquisition of sexually transmitted infection. Of course, there has to be sex, and there has to be the partner has to be infected, but if this person has got infection due to some specific microorganism, that will promote the acquisition of these infection and poor responses from antiviral drugs. So this is about infection. Now let's talk about the visceral diseases, gut, liver, and brain. I'm quickly going through because the time would not allow me to go into the detail. So let's first take gut, liver, and brain. And you know there is possible link between gut microbiota and gastric cancer, possible link between gut microbiota and colorectal cancer, Barrett's esophagus and esophageal carcinoma, Crohn's disease, and ulcerative colitis. All these diseases have been linked with gut microbiota. I have already given a disclaimer. It is not possible at this stage to tell which is the cause and which is the effect, but there is definitely correlation. And there is a hypothesis. H. pylori, you know, has been classified as class 1 carcinogen by WHO. And the theory is that it causes atrophy and metaplasia and dysplasia and then finally cancer. And these are the bacteria called enterotoxigenic Bacteroides fragilis. They produce a protein called fragilissin, and that reduces the production of helpful short chain fatty acids. This is how gut microbiota are related to these some gastrointestinal infections and cancers. Now let's examine association of microbiota and liver, the so-called gut-liver axis. If you have a predisposing condition, a specific gut microbiota can predispose to the development of spontaneous bacterial peritonitis, portosystemic encephalopathy, hepatocellular carcinoma, autoimmune hepatitis, and non-alcoholic fatty liver disease. Of course, you have to have their own causes, but presence of a specific type of microbiota may predict that the chance of developing these conditions is more. Dysbiosis may lead to increased growth of Enterobacteriaceae, which is harmful, and the reduced production of Bifidobacterium, which is relatively friendly. And it may increase the production of ethanol, ammonia, and acetaldehyde. Bacterial translocation may lead endotoxemia. This is not the usual sense of endotoxemia. This means some bacterial products are circulating which have metabolic and other effects, and this may cause immune dysfunction. Now the gut-brain axis, you know, our eating behaviors, how much we eat, and also our eating preferences, they are linked with gut microbiota. Our mood is related with gut microbiota. Memory, Alzheimer's disease, major depressive disorders, autism disorder, multiple sclerosis, all these brain disorders have been linked with specific type of microbiota. And these specific microbiota means based on those RNA, 16S RNA. Dysbiosis may lead to production of serotonin, and serotonin through vagus nerve actually have effect on the brain. So when we say my gut feelings, we may be actually talking science. You all know an old man coming and saying that I have problem gas here, and then it goes to the brain. We always laugh on this. But there may be actually science in that. And our gut microbiota may be actually affecting our mood and our memory, and it also predisposing to certain diseases. So third is allergic disorders and autoimmune diseases. Very, very strong relation with microbiota and autoimmune diseases and allergic disorder. Asthma, for example, allergies, and type 1 diabetes, because type 1 diabetes is also primarily an autoimmune disease. So there is link between gut microbiota and these diseases. This is an organism, Clostridium sensu stricto. It predicts allergic disorders because it tends to increase the production of interleukin 10 and reduces interleukin 4 and 5 and 13. I don't know actually how this thing works, but this is the proposed mechanism. Bacterial genes, they increase production of something called 12-13 dihome, and exposure to pets and cockroaches, they reduce the incidence of future asthma. And Lactobacillus johnsoni reduces asthma, and early life antibiotic or hyperhygienic condition. This might actually be difficult to believe. Hyperhygienic condition, the superhygienic state, the directly proportional to the incidence of type 1 diabetes and autoimmune disorders and allergic disorders. Like in Scandinavia, type 1 diabetes is up to 30%. In our country, it's just 5%. So I think they could learn from us how to reduce type 1 by producing filthy environment. Now the metabolic syndrome, as I said, the biggest disease of today, and obesity. The things are even more interesting. Gut microbiome is related to the weight we have, and the metabolic syndrome, and type 2 diabetes. Type 2 diabetes is undoubtedly one of the biggest challenges, and this is affected by the diet and the environment. And in certain patients, firmicutes are directly proportional to the BMI, specific type of firmicutes. And Christensenella is indirectly proportional to the BMI. And guess, this is the very interesting fact, the predictive value is 90%. If you have a specific type of firmicutes or Christensenella, your weight or BMI can be predicted accurately by 90%. So there is that strong relationship. And gut microbiota and insulin resistance, somebody with different gut microbiota would show different glycemic response to the same food, irrespective of their otherwise metabolic health. So because of the gut microbiota, the response to glucose is maybe different. And certain microbiomes signature predicts type 2 diabetes. Now, the hypothesis behind this is very complex picture. This is taken from, I think, New England Journal of Medicine. And I have made a simplified version. There is a specific type of Escherichia coli which produces a protein called CLPB. Now, this protein has got the effect very similar to GLP-1 and peptide YY. And you know these peptide YY and GLP-1 both are anorexogenic hormones, and they tend to reduce your food intake and you tend to have less weight. And if this organism is not there, then you are likely to develop problems. So this is a friendly organism. It reduces insulin resistance, it reduces metabolic syndrome, and it reduces the chance of diabetes if you are lucky to have this guy which produces CLPB. Now, association of microbiota with obesity, very, very interesting observation I'm going to share. If there is an animal who is treated with microbiota taken from an obese person, that animal may put on weight. And this has been shown, definitely. But we would be more interested if the reverse is true, because all of us are very, very obsessed to lose weight. So if the reverse experiment is successful, then that would be very, very exciting. So I think if the microbiota of 10 people may be in high demand, and they may become filthy rich. I'm sure nobody wants to gain weight, maybe 5%, but everybody else wants to lose weight. So if science develops, then I think this microbiota may be really helpful. And this also explains why some people just can't lose weight despite dieting. Everybody says that I don't eat much. But I have gone through patients' diets, and they tell me half a toast in the morning, half a bread in the afternoon, and then I sometimes feel that this is not even enough, but they are overweight. So it is maybe related to gut microbiota. You know, I have already shown you they produce about 5 to 10% calories from fiber, and there is a theoretical possibility that our microbiota can produce energy from air and water also. So if somebody is like this, he is not to be accused for being fat, and if you're like this one, you cannot be given credit for being slim, because it may be your microbiota which is determining your physique. Now, there was an interesting breaking news. The slimy bacterium may fight obesity. This is a bacterium called Akkermansia mucophilia, and you can see in those who have this, insulin sensitivity is high. That means resistance low, total cholesterol is low, and gamma GT, which is a marker of fatty liver, that is low, and WBC count, which is also a risk factor for coronary artery disease. There are some interesting papers insight into the role of gut microbiota in obesity, pathogenesis, mechanism, and therapeutic perspectives. And this is a very, very interesting case report I'm going to share with you, weight gain after fecal microbiota transplantation. There was a woman who had Clostridium difficile infection, and all antibiotics were tried, none worked, and she was 61 kg. She was offered this FMT, and she chose her daughter, who was healthy, and she had just 77 kg of weight. And the woman with ICD, she recovered, but continued to gain weight. She did not regain her lost weight, but she continued to gain weight, and she achieved 80 kgs from 61 kg. And it was because of the donor microbiota was those which were responsible for this weight gain. So this can be actually used therapeutically also. So now the last one, atherosclerosis, undoubtedly very, very important disease. So if we can find a solution of atherosclerosis and microbiota, that would be really great. Now, microbiota, Escherichia coli, this is something which comes from the diet, phosphatidyl, choline, and L-carnitine. Now this gets converted into trimethylamine N-oxide, TMAO. This one, along with atherogenic diet, may predispose to atherosclerosis. Now, if we intervene this by giving a dietary supplement which can stop the conversion and production of TMAO, despite atherogenic diet, these experimental animals do not develop atherosclerosis. So this is really great. By modulating these organisms over diet or working through them, I think we can prevent metabolic syndrome, obesity, and atherosclerosis. Now, gut microbiome potential therapies, stool transplantation is now proven therapy for Clostridium difficile infection, and this one can work for atherosclerosis if the theory proves correct, and Bacteroides fragilis can work for our anxiety and depression, Lactobacillus, IBD, CLPB producing Escherichia coli adiposity, metabolic syndrome, and diabetes, and many bacteria, they produce specific antibiotics. They may provide future antibiotics, and early life probiotics may be used to prevent type 1 diabetes and asthma. And all these actually will probably develop to probiotics and prebiotics, because it would be hard to ingest or to take FMT. Although there are ways, like for example, one can take capsule, or somebody can be given through endoscope or through the colonoscope. So summary, everybody has a unique signature microbiome. You are truly unique by your microbiota more than by your genome. It undoubtedly plays a crucial role in our health and disease. Perhaps our life would not be possible without them. So next time you call somebody a piece of shit, you might actually be giving him compliments, because shit is capable of doing so much good things. The future might see new lab tests, new therapies based on microbiome, and we might have to rewrite the pathogenesis of many diseases. And in this new science, how much is the hope and how much is the hype is yet to be known. What controls you, is coming back to my question, is it your genes or is it your shit? I think it's a teamwork. Both are indispensable. But if you go by numbers, so 99% of your DNA material comes from bacteria and only 1% from your host cells. So what we see is just the tip of iceberg. We still have to go a long way to uncover microbial mysteries, and we know that good diet, which is based on vegetables and yogurt, that actually gives you a healthy microbiota. These are the references. I dedicate this lecture to my friend, my mentor, Professor Faisal Masood. It is because of him that I got interested in this topic. This lecture is available on my channel Medicine. Thank you.
Thank you very much, sir. Indeed, it was a very enlightening talk, and something that I think all of us here present in the hall have learned. Moving on to our last topic for today. An estimated 2 billion people have been infected with hepatitis B virus, with 296 million being chronic carriers of HPV and 58 million being chronic carriers of HCV. Effective treatment and eradication of viral hepatitis involves a thorough understanding and education about the origin of these viruses, their correct and timely diagnosis, treatment, and preventative approaches. I'm going to invite our speaker, Professor Wasim Jaffrey, to talk about hepatitis B and C from discovery to eradication. He's Professor, Department of Gastroenterology at the Aga Khan University. Dr. Jaffrey is a very well-known hepatologist, gastroenterologist in Pakistan, and he has earned a great name in Pakistan and the region. He was awarded the highest merit award of Master of the American College of Gastroenterology in 2018. He had been the governor of the American College of Gastroenterology previously. He's received Lifetime Achievement Awards from the PSG in 2017 and from the Prime Minister of Pakistan in 2018. He had been Chair of Medicine and Head of Gastroenterology and Hepatology, and is currently heading the Department for Continuing Professional Education along with his clinical and other responsibilities. With over 250 peer-reviewed publications in gastroenterology and hepatology, we are really honored that he has spared time to speak today. So please, you may take over and join us here on stage. Thank you.
Bismillahir Rahmanir Rahim. Assalamu alaikum. I would like to extend my thanks and gratitude to the organizers, especially Professor Aftab Mohsin, Professor Azizur Rahman, and Professor Javed Akram for inviting me to this wonderful conference, which is third annual conference of PSMI. The society has taken a major lead when it comes to holding conferences, and who is the backbone for medical services. It really are our wonderful, wonderful colleagues who are part of internal medicine and really perform extraordinary work. I had my presentation on hepatitis B and C from discovery to elimination, but unfortunately that presentation is not opening on computers here, and I had in the same USB another one. So I thought, okay, let's start with it, and in between, when it comes to hepatitis C, either you can ask me or I can give you a brief comment about that. So let's start with general considerations of hepatitis B and, of course, C as we go along. There is a huge global burden of diseases, and if you look at the infectious diseases as causes of death, they come to, after cardiovascular conditions, 16.7 million. And when it comes to infectious diseases, almost 15 million, and then neoplastic injuries, and the data really is validated through WHO, and all the data is available for all of you to see. So about 15 million, more than 25% of 57 million annual deaths worldwide are estimated to be directly related to infectious diseases. This figure does not include the deaths that occur as a consequence of complications associated with chronic infections, such as liver failure, hepatocellular carcinoma in people infected with hepatitis B or C. Cirrhotic deaths, more than 783,000 deaths per year. Cancer related to hepatitis B, C, as they are the predominant causes, more than 619,000. So 1 of every 40 deaths worldwide really comes from these sources. So look at the enormity of the problem that the world faces really related to hepatitis and its sequelae, resulting in the ultimate form, that is death. So let's start with some historical aspects. It was through the enormous work of Bloomberg in 1965 that we came to know what we call as hepatitis B virus today, and it wasn't known as a B virus to start with. Some of my senior colleagues sitting here, they would remember that we used to call the first blood test for something with hepatitis, and let's get an Australia antigen checked for these patients. Remember those good old days? Of course, and that really how it started, and I'll come to that historically as well. Feinstein and his fine work in 1973 really told us about the hepatitis A virus. Mario Rosetto, a wonderful colleague from Italy, in 1977, he became the pioneer for hepatitis D virus. And through the work of Professor Houghton in his lab, this was his, senior registrar at that time too. But the paper appeared in Science where he was the first author, so it relates to him. And he's come from Singapore. He was working in California with Professor Houghton, and that's how, in fact, in 1989, we came to know about what we call as hepatitis C virus. And Professor Rice and his colleagues in 1990 were the architect for hepatitis C virus. So those are the 5 viruses that you guys are very familiar with. Here is this wonderful, wonderful gentleman, in fact, through enormous contribution in science in various fields. Of course, it's very interesting if you go and read his biography, in fact, that how wonderful his work was and what, other than hepatitis B, his contributions were. So Bush Bloomberg, and I had the rare opportunity of meeting him once through the ASSLD and Liver Foundation and all those things, and I was immensely, immensely impressed with him. He had immense curiosity and energy that were hallmarks of his scientific personality, described as a leading light in the scientific community and a great humanitarian as well. Bloomberg identified the hepatitis B virus and created the first vaccine to prevent the virus. The scientific findings are often serpentitious because look at what he was working on and how he got, in fact, this enormous contribution. Such was the case for Dr. Bloomberg, who discovered the hepatitis B virus. He did not set out to discover the cause of hepatitis B. As I said, there was, no hepatitis B then, it was hepatitis as such. Rather, his initial curiosity and understanding of the scientific process led him to his profound discovery. In brief, the story of hepatitis B started with a search for inherited differences and ended with the discovery of this new virus. So this is how, in fact, you can go on and on. It will consume a lot of time, but I will skip some of the written material here. But in fact, it was through his enormous contributions. He traveled with his team to the globe to collect blood samples from native populations in remote parts of the world. And that's how this Australia antigen got detected. The blood came from the Australian Aborigines. And it was when checked in patients who, in New York, who were suffering from hemophilia. And since they were getting blood, he thought that they would develop antibodies. So that blood got interacted with the Australia antigen, and that's how it was named as Australia antigen. So it's written here, reason the hemophiliacs who had received multiple blood transfusions would have been exposed to blood serum proteins that they themselves had not inherited but had been inherited by their donors. As a result of this exposure, the immune systems of the hemophiliacs patients would produce antibodies against the foreign blood serum proteins or antigens from the donor. Since antibodies are programmed to lock into specific antigens, Dr. Bloomberg decided to use antibodies from the hemophiliac patients to test the blood samples collected around the world. A series of research and clinical observations led to confirmation that the Australia antigen, later on when this was found out, then he in fact used this technology for those patients who were having hepatitis and thought, caused by hepatitis B virus, and this was discovered in 1967. 2 years later, he invented the vaccine too. It is a very interesting history for the hepatitis B vaccine. All of you know that the hepatitis B vaccine is the first anti-cancer vaccine because it can help prevent liver cancer. As liver cancer, really, majority of the patients globally are affected by hepatitis B virus. So this means that if you don't have hepatitis B, at least and through vaccination or whatever, you can do a wonderful job to yourself, to your partners, to your colleagues, and to all the patients that you see. They do not have it. The first commercially available was in 1981 by approved a more sophisticated plasma-derived hepatitis B vaccine for human use. You know that this vaccine, again, that we were using in 80s and all that, were not really up to mark because it was coming from patients with hepatitis B, and in fact they had the antibodies and we would in fact screen and all that thing. But this really later on was picked up with the recombinant hepatitis B vaccine techniques. It's impossible to get hepatitis B from the recombinant vaccines that are currently approved. Extremely, extremely safe. So why we are after the elimination of hepatitis B and C viruses? Because the enormous numbers that are affected and the enormous contributions towards both morbidity and death coming from hepatitis B and C virus, about 2 billion of hepatitis B infections. And in fact, it all comes from the WHO and CDC fact sheets. And anybody doubting it can go back immediately or use your cell phones and go onto the sites, and you would have this correct data as it stands today. And this is the world map. Pakistan, according to the WHO, is in the eastern Mediterranean region, and it is in the intermediate zone from 2 to 8% with Libya, Oman, Pakistan, Saudi Arabia, Syria, and Tunisia. That's how the WHO, in fact, puts us into it. And this is the hepatitis B when it comes to the Pakistan itself. And you can see it can be less than 2% to more than 5% when you travel from Karachi to Khyber and different parts and see what happens in our own country. So we looked at, in fact, for a period of a few years, what is happening with the children across Karachi. And when I looked at around 3,533 between the ages of 1 and 15, I found that surface antigen positivity was 1.8%, and hepatitis C was also seen in about 1.6%. So both infections were common in this very, very, young age groups. So what has changed the global endemicity of hepatitis comes through the vaccination programs that have gone on globally, courtesy WHO and all the alliances that they have. So we looked at what is happening in our own country over a period of 2001 and 8 on a specimen which was 185,825. And we found from this, study on this enormous number of patients coming across because of so many collection centers of Aga Khan University, we found that yes, in fact, there is a changing scenario in our country too with vaccination. This such study substantiated the general perception that levels of surface antigen is showing a slow decreasing trend, while surface antibody are increasing perhaps due to vaccination strategies. But still we need to work on it and work on it and work on it so that what success we have, we continue to stabilize it and improve on it. Ladies and gentlemen, can hepatitis B be cured as I stand today? No. Hepatitis B can be controlled because we do not have effective medicines to counter the surface antigen. So long you are surface antigen positive, you are hepatitis B positive, because your DNA in the blood does not reflect the CCC DNA which is present in your liver. And hence, once be, always be, unless you develop the surface antibody. And that is the best news you can have for your patients, yourself, or anybody that, after having seen surface antigenemia for X number of years, now it's gone, surface antibody has appeared, and you are, cured. The currently available medicine, certainly I'll come to that, as the antiviral treatment and universal vaccine and all that. Current treatments can induce viral suppression and sustain disease control, but as far as elimination, no. The treatment does not eliminate hepatitis B virus. Hence, we come to the elimination part, we'll know what we can do for at least B. So yes, treatment can decrease inflammation, it can decrease fibrosis, it can decrease the progression, yes. Reversal of fibrosis and decrease progression, yes. But decrease incidence, and of course, when you do all that, there is a decreased incidence, but not elimination of HCC, which is liver cancer. The currently available treatment, the first line treatment, look at the dismal surface antigen loss. 2%, 2.2%, 2.9%. Aap sari zindagi, you can give them the treatment. At the end of the day, the surface antigen loss is less than 5% with those who are E antigen positive and E antigen negative. Isse bhi bura haal hai. That's a positive negativity rate of surface antigen is maximum is 0.6%, less than 1%. HPV cure, a goal for the next decades to be seen. And as you see, that as I say that we cannot cure it today, people like ourselves and many more across the globe are working on combination of treatments to achieve the success, which means the antivirals, which we have, the nukes, the capsid antagonist and the small RNA engine, they are coming in fact, through research, not really commercially available, but coming in. The immune restoration with the TLR agonist and the therapeutic vaccine. There is a preventive vaccine, and then therapeutic vaccines are also tried, in fact, by some of our colleagues in Bangladesh and Japan and other countries. So they are showing better trends. So hopefully, as we go along in the years to come, as I stand, or my colleagues would stand in the next 10 years on this platform, we can cure hepatitis C, and that would be the news, in fact, of this century. The liver CCC DNA, as you see, it starts on the left, and with the combinations, it shows a decline and hopefully zero. So that is the need of the hour, and that is what is the most important message that is coming in for elimination of B. Prevention through vaccination. No cure, but prevention through vaccination. So vaccines are available. We know that. They are extremely, extremely safe. 60.1% decrease in incidence of liver cancer, 76.3% decrease in mortality from fulminant hepatic failure, 92% decrease in mortality from chronic liver disease over decades since vaccine got introduced in Taiwan. Everyone would quote this Taiwanese experience because that country had a huge incidence of all these things, and through vaccination, look at the excellent results that they have gotten it. Cost effective, particularly as part of triple elimination strategy to eliminate mother-to-child transmission of HIV, hepatitis B, and syphilis. So WHO has been after all the countries in the world, in fact, who are signatories that they must implement the hepatitis vaccination program in their APIs, and we are part of that too. But we are not part of this thing, most unfortunately, and that is still lagging, and that is the birth dose of hepatitis B vaccine within the first 24 hours. So this is an extraordinary attempt, a very sensitive, very safe attempt, and it should be promoted. My colleagues sitting here, in fact, in the room, without your help, this cannot be achieved through gastroenterologists and hepatologists asking for it, because birth dose vaccination is the safest way where you can prevent hepatitis B in fact. And then, of course, as we go along in the next 10, 20 years, we will see what it is gone, because in fact that population would not have it, or at least a sizable population would not have hepatitis B anymore. So this, if administration within 24 hours is not feasible for whatever reasons, a late birth dose has some effectiveness. Although effectiveness declines progressively in the days after birth, after 7 days, a late birth dose can still be effective in preventing horizontal transmission and therefore remains beneficial. WHO recommends that all infants receive the late birth dose during the first contact with the healthcare providers at any time up to the time of the next dose of the. This does not, the birth dose would not make it a part of the 3 injections, which is important. So this is birth dose, and then 3 injections would follow as per routine. Of course, WHO is also recommending, and this is part of the highest risk population who may be exposed, doctors, nurses, phlebotomists who can be in fact exposed with anybody's blood, they should be vaccinated, and patients on dialysis, patients who receive blood, for a variety of reasons. It is extremely safe in pregnancy. That is the question that is generally asked. And it is also safe for lactating women. A birth dose can be given to low birth weight babies and premature infants. So it's even safe for those. The birth dose should not count as part of the primary 3-dose series. The 3 doses of the standard primary series should still be given afterwards according to the national vaccination schedule. Now, we all fail if we do not have a strategy for all what I'm saying. In fact, it is just a speech or something. Somebody has to develop a plan. Somebody has to develop a plan not for the strategy, but for reporting, for monitoring. किसी भी चीज़ को आप monitor ना कीजिए, it's gone. You have to follow what was it in 2022, standing today on May the 7th, in 2024, May the 7th. So one has to see the results. Sometimes we achieve through our success, sometimes we say, we need to do more about it, and we have to be looking at those loopholes and tie them up. So the path towards a global elimination strategy started in 2009, but adopted in 2016, and there is a huge viral hepatitis document from WHO which will tell you all the 5 important strategies, and this is for both B and C. Information for focused action, interventions for impact, delivering for equity. Ye na ho ke, this is a better population, this is somebody highly influential, or whatever one can come out in our country, because there is so much of inequity that in fact we cannot even think about it. Equity is the need of the hour. Every human being, everyone, color, caste, religion, nothing matters. They must be equal and dealt equally so that the results are as good as we can. Then, of course, financing, stability is very important, and all these things are important. So when this got all implemented in 2015 or 16, look what the results were. The baseline hepatitis B vaccine globally was 82%, and by 2030, which is the target year for elimination should be 90%. Mother to child transmission, 38%. Again, these are global figures, not for our country. 38%, it should exceed 90%. Safe injection practices, 5% globally, should reach 90% or above. Harm reduction falls into the same category. HBV treatment, less than 1% global figures in 2015 should reach 80%, and hepatitis C treatment, which was less than 1% in 2015, should go to 80% treatment. So that is how WHO, Pakistan, and all the countries related to WHO are signatories that we would achieve the target, and my colleagues sitting here and across the country would know what figures we can relate for our own country. When we do that by 2030, and you can see that 6 to 10 million infections in 2015 would reduce to less than 1,900,000 by 2030. 104 million deaths in 2015 would be less than 500,000 deaths. So that's how both morbidity and mortality would come down if we are, in fact, hoping to achieve the target of elimination. Now, how do we do that? Word of mouth doesn't do anything. It has to be a very concrete planning. There should be a national strategy plan, including stakeholders' input, patients, and all those people who matter than the clinicians. I don't know how much the national plan, in fact, got, through all what is written here. Workforce needed to achieve elimination. What is the workforce? Where is it coming from? Budget for provision of testing and in treatment. So all these things are important, but the last one is the most important: effective surveillance and monitoring of loss to follow-up and everything else. Could be eliminated by 2030? Maybe, yes. But look at what we have faced for the last 3 years. The global, in fact, COVID pandemic has really let every country on the standstill. Of course, our country also had been affected, but luckily, in fact, we were not as badly affected by COVID when it came to morbidity and mortality, for reasons only heavens knows. But yes, we are fortunate that we did not have that kind of figures that is across the border in other countries. Due to disruptions brought by COVID-19 and giving constraints in the budgets anticipated in the face of COVID-19 response, the hepatitis elimination programs and federal and provincial levels would be effective. So this has to be addressed by all the stakeholders, in fact, especially the governments that are installed, so that they can look at it positively. I can't say for reasons that you all guys know positively, but what is harm in keeping your hopes alive? Because la taqnatu min rahmatillah is, of course, is our blessing, that we have to believe in Allah's blessings eventually. Hopefully someday they will come to us and we will be greatly benefited. So hepatitis C, I haven't been able to tell you in details because that presentation didn't open. It got detected in 1989. As I stand 2022, the major breakthrough happened in 2013 when we started to have oral medicines for hepatitis C elimination. We do not have a vaccine. We would never have a vaccine for hepatitis C. So the elimination figures of hepatitis C has come in through only treatment. So that treatment really cannot happen to anybody unless you get tested. So testing is the most important thing. The missing millions, whenever, wherever you are practicing, it is your duty that this patient, this person, because it's a silent killer. Patient would come to you with a hepatoma, patient would come to you with vomiting of blood when he is or she is already cirrhotic. So if you do just a simple Hep C antibody testing, that comes back positive, you do the PCR and start the treatment with a very simple treatment, just 1 pill a day for 3 months, and that is it. Now this responsibility has to be shared across the board, no matter what your specialty is. This woman, this person, in fact, or this person coming to a dentist, for instance, or for that gynae obs and all that bit. And same is for anybody coming to any clinic. If he or she is not tested for hepatitis B and C, from here onwards, this whole thing, in fact, would fall on your shoulders that this patient may or may not have the disease, but once you say that he has it, you have saved his family, you have saved himself, and you have saved many more patients who otherwise would get infected. So bear with this responsibility, get them checked, and hopefully that would pay the dividends for the entire environment and society. In Pakistan, with national commitments and dedication, we can achieve the target. With the current scenario, it is most unlikely that we would achieve the WHO target of 2030. It is down the road. This is 2022 for elimination of hepatitis. I hope I'm wrong, and by 2030, that, all the figures would tell us that yes, we are at par with the rest of the world, and we have eliminated it. But let's work for it, and hopefully we can do what I'm telling you. Thank you very much.
Keeping in view the time constraints, because we're already a little late, we will be skipping the questions unless, if there is any one or two important questions, then I might be taking one. Ji sir, please. Okay. Mic please दे दीजिएगा एक साथ एक question ले लेते हैं जी.
My question or comment basically is to Dr. Basit. This data was presented. This is, relatively old data now. It has been published. You said it's 10 papers now. But I still find that even today, presentation said the incidence or prevalence of diabetes in Pakistan is 17%. Now I wonder, why in the presence of such good data, which is quite extensive, we are still, and it's not just for diabetes. In the PHL conference, the last one, data was presented, 21% prevalence, 35% prevalence of hypertension. Your data, as well as the data from the PMRC, PHRC, is 46 and 50%. We are not even getting through to our own doctors, those who attend conferences, those who speak in conferences. I wonder why. There's a blocks of somewhere. Okay? That's one part. The other was there was the cigarette smoking. You self-admitted that this is an underreporting. I don't think it is underreporting by too much. The PHRC, the same data, 2016, where they found 50% hypertension, had about 10 or 15 questions on smoking. Cigarettes, how much, when, so much, non-smoker tobacco use, everything. Because of the low incidence in females, the actual data gets diluted. And therefore this 13% is actually probably 25% if you just take overall, because there's a very wide difference between males and females in Pakistan. And so it's not far wrong. I forget the exact data, but it was still less than 20% in that study, which had many questions on tobacco. Yeah? So I don't think you can worry too much on your cigarette. Actually, it's not too much. What we tend to see is the males smoking in the society openly. What we don't see is that the females don't smoke.
Thank you. Thank you. I'm going to... Ji sir, bilkul.
Adding on to Aziz Saab's talk, you forgot dementia. There is a link between the fecal lactic acid concentration with the dementia, and there is 60% decreased risk when those who have a high lactic acid in fecal their content. So that probably may brain and shit link as there as well.
Thank you. Thank you, sir. I'm sorry, in view of time constraints, I'm sorry, we're not going to take any more questions. I'm just going to request our chairpersons for their very valuable comments.
Bismillahirrahmanirrahim. The topics have been really very eye-openers, and tremendous amount of lessons could be learned by all of us, including the state of Pakistan. First of all, about Dr. Basit's lecture. Dr. Basit, the worst thing to approach the government is to ask for money or allocation of money for these type of schemes which they do not understand that what is going to be the impact of these on the life of the nation. You see, there is I put forward to you a suggestion that don't ask for any budget allocation. Ask the government to frame a press and electronic media policy to train the nation on prevention of diseases. It is a no-cost budget, no-cost scheme. No additional budget of any department will be needed. Only thing is that if the Prime Minister or the Health Minister is convinced of this, that a scheme of nation awareness program on hypertension or diabetes or typhoid, hepatitis C or B, this is launched in a concerted manner under a lay-down program for 10 or 15 years. That to give you the example is that our nation should be afraid not to touch any food article without washing the hands. That state of mind, if you can create by simply in electronic media or press media policy, I think you may achieve tremendous amount of results. Actually, this is what are my comments on this time. Only one small part is that Professor Mohsin Aftab told us that hepatitis C, one of his lecture probably in Sialkot he gave, that when the smallpox eradication scheme was launched in Pakistan, you see, and smallpox vaccination was obviously before that even, this is the point where the hepatitis C was introduced from one person to the other. I don't know whether Dr. Jafri Saab will agree with this, but this is how few thousands were infected, then they gave it to the thousands and the thousands. No blood screening was done for hepatitis B and C for a very, very long time, and that is why this disease burden is present at the moment. These are my comments. I request the other chairperson that to comment on these lectures.
Thank you very much. Now what I would like to say about Professor Basit's talk, and which I've listened to it before as well, but he's got some more refining touch to it. And of course, being the part of the university, our own university, they did a tremendous job in in fact, highlighting. Of course, we can argue with the percentage as far as the disease burden is concerned. But one thing is certain, that it made us realize that we should better look into this. So at least with this awareness, I can only quote one thing from one of the ADA conferences, one of the good old days when we used to visit, beyond Pakistan. And with the tears in his eyes, the conference chair was saying that we are very soon going to be, he was talking about American, that 1 in 3, right? And then he said that, what we going to do? And the co-chair said, what can we do? We have got a war between two set of people. And one is trying to prevent the disease, try to cure the disease, and there is one end which has got hugely, a huge weight of money on their own hand in advocating and spending trillions of dollars in the propagation of high-calorie diet. So this was the one thing which we heard from there. As far as Professor Aziz's talk is concerned, it is very enlightening, and of course the awareness and the understanding of microbiota is now these days the talk of the day. And the preventive aspect has been highlighted very beautifully, and I don't think that we would like to go into the nitty-gritty of the titles, right? Of course, I mean, the fact has been put forward eloquently by Professor Azizur Rahman. As far as Professor Wasim Jaffri's talk is concerned, he is, of course, a speaker of global magnitude and a grand one as far as Pakistan is concerned, for we proud of it. And I don't think Professor Jaffri need any presentation, right, to talk about the hepatitis and the disease related to it. I very well remember in one of the Apostle lecture in Tokyo where he highlighted one very important point, and that is about a decade ago, that we should have a treatment of hepatitis C in weeks. Why are we, I mean, the sort of pharma industry, and he highlighted that point that it should be a few weeks treatment, right? And we are very happy that at least it cut down to 12 weeks. Now we have no option other than to find the cases. I repeat, as he said, find the cases as far as hepatitis B and C is concerned. And if we, the preventive aspect of hepatitis B has been explained, and of course, we can, if we get hold of hepatitis B patient, unfortunately who is not vaccinated and of course got a disease is there, then of course we can at least control it. And we know that we cannot eliminate it, but at least we can prevent or prolong the peaceful life of that fellow and delay the agony. As far as hepatitis C is concerned, there is no point, okay, it's not treating it. I thank you very much, and I hand over to our last chair.
Thank you, sir.
Thank you. Excellent presentations by all three speakers. As far as Dr. Basit is concerned, the only thing which I can say about it, that this disease which you, the survey which you have presented here, in this, the diabetes is approximately having prevalence of 26% or a bit more. But the figures which you have quoted along with that, iske saath jo mirch masala baki wala hai, hypertension which is in more than 50%, dyslipidemia which is seen in more than 96%, and obesity which is seen in more than 71%, all these mixed together, what the heck it has created and it may create. So as Professor East Mohammed Saab said, मेरे ख्याल में सबसे जो ज़्यादा ज़रूरत है ना, वो हमें एक बहुत ही मैसिव मीडिया कैंपेन की है. आई एग्री विद हिम. और आपको ना किसी बंदे के पास जाके वो उस फाइल के लिए जिस पे साइन होने थे और उस फाइल को एक दिन पहले हाईजैक कर लिया गया जैसे जिक्र हुआ, तो हमें इस चीज़ की ज़रूरत ही नहीं रहेगी. जितना कि इस वक्त सोशल मीडिया इफ़ेक्टिव है, वी ऑल हैव सीन दैट, फेक जेन्युइन एवरीथिंग इज़ ब्लास्टिंग. तो अगर हम लोग सोशल मीडिया का इस्तेमाल कर लें इसमें और अपने मीडिया को यूज़ कर लें, तो प्रॉबेबली इससे हमें बहुत फ़ायदा हो सकता है. एंड सेम इज़ ट्रू फॉर जैसे वसीम जाफरी साहब ने कहा. और मेरे ख्याल है कि हद तक हम लोग, हम में से बहुत सारे लोग बहुत सारी कोशिश करके, और जैसे फिगर्स हम बात कर रहे थे कि 2030 तक शायद हम कामयाब हो जाएं, इंशाल्लाह विल डू. एज़ फार एज हेप सी इज़ कंसर्न, आई एम प्रीटी पॉजिटिव कि हम लोग 2030 तक इंशाल्लाह इससे जान छुड़ा लेंगे. लेकिन जहाँ तक बी का ताल्लुक़ है, हम सब मिल के दुआ गो हैं कि अल्लाह करे कि जिस तरह हेप सी के लिए अल्लाह ताला ने एक रेमेडी दे दी है, तो इस तरह हेप बी के लिए भी रेमेडी जो है दे दी जाए. एज़ फार एज अजीज़ साहब लेक्चर कंसर्न, अगर मेरे को चेयर इस पे एतराज़ ना करें, आई विल लाइक टू लेबल दिस लेक्चर एज अ स्टेट ऑफ आर्ट लेक्चर, एंड आई थिंक no comments and no questions should be on that lecture.
Thank you, thank you. जी sir, जी.
On a lighter note about Professor Azizur Rahman's lecture, soon there will be a market of fecal medicine, and people will be going to give me these bacteria because I want to be happy. Give me these bacteria because I want to be slim. I want to avoid diabetes mellitus. I think future holds very good for Professor Azizur Rahman to delve into this subject further.
Thank you.
Thank you very much.
I'd like to thank the speakers as well as the worthy chairpersons for this session. I will also extend invitation to the audience for the next session, which is the PSIMRA Research Award Ceremony. But just before we start that, there's a quick tea break, and I will advise everyone and request to just keep it short for about 10-12 minutes. You may enjoy a cup of tea just behind here in the hall. 10 minutes, maximum 10 minutes, Ji. And we will get back here in 10 minutes. Thank you. Dr. Somia? Right. Bismillahir Rahmanir Rahim. As we begin the PSIMRA Research Award ceremony, I'm going to request everyone to please take their seats. Thank you. Assalamu alaikum everyone. This is Dr. Wafa Kaisar, and on behalf of PSIM, I welcome you all to the PSIMRA, Pakistan Society Internal Medicine Research Awards ceremony. Our conference theme, Evidence-Based Medicine Up Now, is the core of medical practice. Evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. It is an interdisciplinary approach which uses techniques from science, engineering, biostatistics, and epidemiology, such as meta-analysis, decision analysis, risk-benefit analysis, and randomized controlled trials to deliver the right care at the right time to the right patient. It aims for the ideal that healthcare professionals should make conscientious, explicit, and judicious use of the current best evidence in everyday practice. PSIM was established in 2019 with the sole purpose of promoting and propagating the quality and effectiveness of healthcare by fostering excellence and professionalism in the effort towards this goal. PSIMRA is Pakistan, which is a joint initiative of PSIM and Pharmevo Research Forum, PRF. It provides a platform to the internist, our young aspiring physicians, to present their research work and compete with their peers at a national level. This competition will foster the development of the research ecosystem in internal medicine. It is supported by an unrestricted research grant from Pharmevo. I welcome our panel for today, starting with our distinguished guest, a phenomenal person whose achievements and efforts cannot be summed up, our president, Professor Javed Akram. He also serves as the Vice Chancellor of University of Health Sciences. Sir, please join us on stage. Thank you. He's also the editor-in-chief for the Journal of PSIM. I will also welcome on stage the jury for today, Professor Aftab Mohsen, a leading gastroenterologist, hepatologist, principal of Rashid Latif Medical College. He is the Senior Vice President, Corporate Affairs, and the Chairperson, Organizing Committee for this conference. I will also invite Mr. Shaukat Ali Javed. He's the Chief Editor of Pakistan Journal of Medical Sciences. He's the founding member of the Pakistan Association of Medical Editors and Eastern Mediterranean Association of Medical Editors. Our third juror and judge was Professor Khalid Mahmood Khan. He's Professor of Medicine and Gastroenterology at Allama Iqbal Medical College, Jinnah Hospital, Lahore. He's also the chapter head Lahore for PSIM. Thank you very much. I will now welcome Dr. Masood Javed for introduction of the Pharmevo Research Forum. Dr. Masood Javed, Director Medical Affairs and Institute of Leadership Excellence, Pharmevo. He's the Associate Editor of Pakistan Journal of Medical Sciences, and he's visiting faculty of many universities. Please take over.
Assalamu alaikum everyone. Can I have my presentation? Thanks a lot. Pakistan Society of Internal Medicine for giving this opportunity and collaboration for the research award which you hold. I take this opportunity to briefly overview what is Pharmevo Research Forum is there and how much we have done in the last 1 year briefly, and about a bit of PSIMRA. Pharmevo is from the day one works in the area of research and academics, not in the many others avenue which the others corporates are working. We think about and working from many awards, registries, health research advisory board. We now go to that level that we do a lot of things, let capitalize and work on some of the areas to do some more meaningful work as we go along. So this Pharmevo Research Forum was established about a year back, and now it's collaborated for transparency, accountability, and independence. It collaborated with Pakistan Journal of Medical Sciences, which is one of the leading impact factor medical journal from Pakistan. The vision of Pharma Research Forum is simple, to develop a research culture. So whatever is here, whatever we can contribute in this area at national, international level, we want to go for the whole thing. If I just search about some international ranking of university based on the research criteria, you find many medical universities not at the top. The first ones come the engineering, others, and then comes the medical, all other. If we go beyond that, many of us even don't know that's clinicaltrial.gov. That is a website. Those clinical research has to be done. The WHO requirement is there. You need to register your clinical trial here, and otherwise not leading journal will not going to publish it. So we just search here, you find out only 231 studies you find out at one point from Pakistan. अगर इसी चीज़ को देखें तो हमारे एक टर्शियरी केयर हॉस्पिटल में जितना पेशेंट लोड है, जितना डिजीज़ पैटर्न है, जितनी हमारे पास रेजिडेंट और हेल्थ केयर लोग मौजूद हैं, तो एक यूनिवर्सिटी से इतनी होनी चाहिए अगर हम पूरे पाकिस्तान से ये चीज़ें आ रही हैं. तो इसको देखते हुए, क्योंकि एक बहुत बड़ा एवेन्यू है, बहुत सी ऑर्गेनाइजेशन इसमें काम कर रही हैं, तो हमने भी अपना काम करने की शुरू की. क्या किया जाए, तो हमने कुछ चीज़ें स्टार्ट की, जिसके अंदर से एक बड़ी इंपॉर्टेंट रिसर्च ग्रांट. जब भी रिसर्च की बात होती है तो इवन जूनियर डॉक्टर जब बात होती है जी, ग्रांट नहीं होती, हमारे पास फैसिलिटीज़ नहीं होती, हमें चीज़ें चाहिए. तो वी स्टार्टेड अ इंडिपेंडेंट एडवाइजरी बोर्ड विद द रिसर्च ग्रांट एज वेल, और जिसके अंदर हमने बस ये रखा था कि मैक्सिमम 300,000 फॉर ईच ग्रांट, और आपके रिसर्च 18 मंथ्स के अंदर कंप्लीट होनी चाहिए विद आवर प्रायोरिटी एरियाज एज वेल. और आपको ये बता के हमने पहला राउंड इसका कंप्लीट कर लिया है. हमने 19 रिसर्च ग्रांट्स अनाउंस कर दी हैं, और नेक्स्ट वीक के अंदर हम इनको चेक्स भी उसके डिलीवर कर रहे होंगे. और इसी तरह जो आप लोगों को अगर इन्फॉर्मेशन नहीं है, तो नेक्स्ट ईयर का जब अनाउंस होगा तो आपकी अपॉर्चुनिटी मौजूद होगी कि आप सब भी इसके अंदर अप्लाई करें. ये सारी इंफॉर्मेशन prf.pharmo.biz पे मौजूद हैं, और वहाँ पे रियल टाइम में अपडेट होती हैं. सारा प्रोसेस ऑनलाइन है, उसके अंदर कोई मैनुअल वर्क भी नहीं है. आपको वहीं पे अपनी ग्रांट के लिए अप्लाई करना है थ्रू द प्रोसेस, जिसको शौकत अली जावेद हेड कर रहे होते हैं विद द एडवाइजर्स फ्रॉम ऑल ओवर पाकिस्तान. वो इसको रिव्यू करते हैं. इसके अंदर कोई डायरेक्ट कमर्शियल लिंकेज नहीं आते, ना आपको प्रोडक्ट के ऊपर कोई रिसर्च करनी है. तो 19 रिसर्च हमने जो अनाउंस कर दी है वो हम नेक्स्ट वीक अनाउंस भी कर रहे होंगे. तो हमने ग्रांट स्टार्ट की. दूसरा, वर्कशॉप तो हम कराते रहते हैं पूरे पाकिस्तान में, जिस इंस्टीट्यूशन में ज़रूरत होती है मुख्तलिफ वर्कशॉप्स कराते हैं. और अब जब PGMS के साथ कोलैबोरेशन हुआ तो एडिटिंग की वर्कशॉप भी इसके अंदर ऐड हो गई, वो भी साथ होती हैं. इसके साथ हमने ये चीज़ देखी, एक वर्कशॉप तो एक छोटा सा इवेंट होता है, कुछ चीज़ें सिखा दी जाती हैं, SPSS सिखा दी, चीज़ें सिखा दी. लॉन्ग टर्म सस्टेनेबिलिटी थोड़ी सी आना मुश्किल होती है. जो लोग इंटरेस्टेड हों उनके लिए हमने बोला कि लेट्स स्टार्ट अ सर्टिफिकेट प्रोग्राम. तो यूनिवर्सिटी एफिलिएटेड और इंडोर्स सर्टिफिकेट प्रोग्राम हमने स्टार्ट किए, जो कि सर्टिफिकेट इन क्लिनिकल रिसर्च है. दीज आर ऑनलाइन कोर्सेज जो आप आराम से अपने घर से ले सकते हैं. दे आर 3 मंथ सर्टिफिकेट कोर्स विद अ यूनिवर्सिटी एफिलिएशन. होपफुली हम कोशिश करेंगे इसको UHS से कर लें. अभी तो इट्स एफिलिएटेड विद अनदर यूनिवर्सिटी. हमारा फर्स्ट बैच कंप्लीट कर चुका है, जिसके अंदर 46 वर्स स्पॉन्सर्ड बाय PRF, क्योंकि इसकी पूरी इंडिपेंडेंट फैकल्टी है, वो पढ़ाते हैं. सेकंड बैच इन प्रोसेस है, जो कि स्टार्ट हो चुका है, 2 सेशन हो चुके हैं, उसमें 36 आर स्पॉन्सर्ड. अगेन इसकी डिटेल मौजूद है, आप लोग अप्लाई कर सकते हैं. चीज़ें हो सकती हैं जो लोग इंटरेस्टेड होते हैं इसके अंदर, लेकिन इसका पूरा क्राइटेरिया है. अगर आप असेसमेंट क्लियर नहीं करते, आपकी अटेंडेंस पूरी नहीं होती, यू विल नॉट गोइंग टू गेट अ सर्टिफिकेट. तो इसकी पूरी प्रोसेस है. तो ये एक और चीज़ है. और कुछ ऑर्गेनाइजेशन के साथ हमारे ये भी अंडरस्टैंडिंग है, हम उनके भी कुछ रेजिडेंट को लेके चलते हैं. एक और चीज़ जो एक हमने शुरू की, I work for quite a long time in civil hospital, tertiary care hospital और कुछ private hospitals के अंदर भी. तो हमारे पास research culture institution में कुछ कम है comparatively generalized में देखा जाए. Although यहाँ पे तो सारे academicians बहुत strong बैठे हुए, इनके ward को compare करें generalized in पाकिस्तान तो resources या चीज़ों की limitation रहती है. तो हमने एक longitudinal program start किया, research excellence program. It's a प्रोग्राम जो हम इंस्टीट्यूशन या यूनिट्स के अंदर रिसर्च आउटपुट इंक्रीज करने में जो जो चीज़ें उनको रिक्वायरमेंट हो, जस्ट इन टाइम लर्निंग, जिसमें ट्रेनिंग भी शामिल है, जिसके अंदर स्टैटिस्टिकल सपोर्ट हो गई चीज़ें. और हमने इसका पूरा प्रोसेस बनाया हुआ है, जिसके अंदर हम मंथली मीटिंग करते हैं. अगर आपने कभी डॉक्टर बासित को सुना हो तो वो बोलते हैं हफ्ते में एक मीटिंग होनी चाहिए. अब हमारे लिए हफ्ते में एक मीटिंग करना मुश्किल होती है. हम बोलते हैं डिपार्टमेंट लेवल पर आप हफ्ते में एक मीटिंग करें, लेकिन PRF की टीम के साथ आप मंथ में एक मीटिंग करें कि कहाँ तक पहुँचे और कहाँ पर जाना है. और हमने इस पूरे प्रोसेस को गेमीफाई भी किया हुआ है, और उसके अंदर कुछ अवार्ड्स और कंपटीशन भी रखे हुए हैं, और उनको सपोर्ट भी करते हैं. कोशिश हमारी होती है कि एट द एंड ऑफ द ईयर कुछ रिसर्च पब्लिकेशन एक्सट्रैक्ट हो. तो अभी तक हम 12 इंस्टीट्यूशन या डिपार्टमेंट के साथ कोलैबोरेट कर चुके हैं, और अभी उनके साथ कुछ से स्टार्टिंग हो चुकी है, कुछ से मीटिंग्स चल रही है. तो वहाँ पे हम जाके इन चीज़ों को स्टार्ट कर रहे हैं. आखिरी चीज़ ये थी कि रिसर्च अवार्ड चल रहे होते हैं, बहुत सी सोसाइटीज़ के साथ PRF के अवार्ड चल रहे हैं, आप लोगों ने भी देखे होंगे. तो रिसर्च अवार्ड इज़ इंपॉर्टेंट कि लोगों को मोटिवेट किया जाए, उनकी चीज़ों को एंडोर्स किया जाए. तो सेकंड PSIM PSIMRA रिसर्च अवार्ड इस दफ़ा बड़ा सक्सेस स्टोरी रही, क्योंकि ऑल ओवर द पाकिस्तान इस वक्त हमने कोशिश ये करनी थी कि हम रिसर्च की ट्रेनिंग भी कराएंगे, उन लोगों को मोटिवेट भी करेंगे ऑल ओवर पाकिस्तान, फिर उनके अवार्ड्स आएंगे. बट बिकॉज अब आपको पता होगा कोविड की रिस्ट्रिक्शन आखिर में कम हुई थी, फिर रमज़ान आ गए, कॉन्फ्रेंस की डेट आगे पीछे हुई, इसमें हम वो वाला काम तो नहीं कर सके. बट स्टिल ऑल ओवर द पाकिस्तान वी रिसीव 122 रिसर्च एब्स्ट्रैक्ट्स फॉर दिस कॉम्पिटिशन, और जिसके अंदर ऑल ओवर पाकिस्तान स्मॉल एंड पेरिफेरीज और मेजर हॉस्पिटल शामिल हैं. डॉक्टर सोमिया आपको और डिटेल उसके अंदर बता देंगी. तो उसके अंदर से सेलेक्ट हो के 20 आज जूरी के पास आए थे जो उन्होंने रिव्यू किए इन दोनों कॉम्पिटिशन के अंदर. लेकिन हमारी कोशिश ये होगी कि नेक्स्ट रिसर्च अवार्ड के अंदर हम इस पूरी ट्रेनिंग्स का भी पैन पाकिस्तान इसको एंडोर्स करने की चीज़ें कर दिए. तो ये कुछ चीज़ें थी कि क्या फार्मो रिसर्च फोरम है. इन सब चीज़ों के लिए आपको कोई इंफॉर्मेशन चाहिए हो तो आप हमारे किसी टीम मेंबर से prf.farmo.biz पे काम करें. कोई चीज़ आपको इंटरेस्टिंग लगती होगी तो हमसे कोलैबोरेट करें. वी आर ओपन for any institution, any person to collaborate on those things as well. यहाँ पे मैं एंड करना चाहूँगा. You don't have to be great to start, but you have to start to be great. रिसर्च एक ऐसा एरिया जिसमें जितना काम किया जाए कम है, तो हम सबको जॉइन हैंड करना चाहिए, कोलैबोरेट करना चाहिए, तो हम नेक्स्ट लेवल पे जा सकें. थैंक्स अ लॉट फॉर योर टाइम एंड बेस्ट विशेस फॉर ऑल द पार्टिसिपेंट्स फॉर देयर अवार्ड.
Thank you very much, Dr. Masood. And now I'm going to invite our General Secretary PSIM, Dr. Somia Iqtidar, for introduction of PSIMRA with the PSIM perspective. She's a great source of inspiration for all young women, including myself. She's currently serving as Associate Professor of Medicine at King Edward Medical University, Lahore. She's also the editor for the JPSIM.
Thank you, Wafa. You're always very kind in introducing me. I think ऐसा कुछ भी नहीं है जितना वफा कहती है. अच्छा, thank you, ladies and gentlemen, for joining us today. This is a session which is very close to PSIM because we always say that this is a research-oriented society. So when FABIWO approached us with this idea of Pakistan Society of Internal Medicine Research Award, it was like کہ یہ تو ہمارے دل کی بات انہوں نے جیسے کہہ دی. بیکاز وی آلسو بلیو کہ ریسرچ کے بغیر اف یو پبلش اور یو پیرش جو ہمیشہ کہتے ہیں. سو جب تک ہم اپنا لوکل ڈیٹا اور اپنے اسٹوڈنٹس کو انکریج نہیں کریں گے کہ وہ ریسرچ میں کوئی کام کرے, تو آئی تھنک کہ ہمارا میڈیکل ایجوکیشن انکمپلیٹ ہے تب تک. سو پاکستان سوسائٹی آف انٹرنل میڈیسن ریسرچ ایوارڈ وی لانچڈ لاسٹ ایئر اینڈ اٹ واز اے ہیوج سکسیس. وی ہیڈ اے ٹریمینڈس رسپانس فرام ڈفرینٹ فزیشینس. اور پچھلی دفعہ ہم نے یہ ریئلائز کیا کہ ہم یہ جو صرف جونیئر فیکلٹی کے لیے کر رہے ہیں, تو اس میں سینئر فیکلٹی کے بہت سارے لوگوں نے کہا کہ وی آلسو وانٹ ٹو پارٹیسپیٹ. اینڈ ایٹ دیٹ ٹائم وی تھاٹ کہ اٹ از ناٹ ایزی یا یہ فیئر نہیں ہوگا کہ ہم ایک جونیئر ڈاکٹر کی ریسرچ کو کسی سینئر ڈاکٹر یا سینئر پوزیشن کی ریسرچ کے ساتھ کمپیئر کر کے ان میں سے کسی کو ایوارڈ کر سکے. سو اس دفعہ ہم نے پاکستان سوسائٹی آف انٹرنل میڈیسن ریسرچ ایوارڈس میں 2 کیٹیگریز اناؤنس کی تھیں. One category was for emerging یا budding physicians, which was residents up till the level of senior registrars, and then senior registrar and above جو level تھا اس میں associate professor سے نیچے ان کے لیے ہم نے second category announce کی تھی, تاکہ ایک matched competition ہو between the participants جن لوگوں نے submission کیا. We had a wonderful response this time, 122 submissions from all across Pakistan, which were then shortlisted, اور ان میں سے دونوں categories میں 20 ریسرچ ایبسٹریکٹس کو شارٹ لسٹ کیا گیا, جن کو ایک انڈیپینڈنٹ جیوری نے ایویلیویٹ کیا. کچھ ہمارا انکلوژن کرائٹیریا تھا اس کے اوپر کہ وہ میڈیسن اینڈ الائڈ اسپیشلٹی سے ہوں, ان کا ٹاپک جو ہے وہ اینیمل اسٹڈیز نہ ہو, ہیومن اسٹڈیز ہو. اس کے اوپر ان کو ایوارڈ کیے گئے مارکس. اور اس کے بعد جو ٹاپ 20 لوگ تھے, 10 in each category, they showcased their abstracts in the PSIMRA arena that we had set up right across this hall. You are all welcome to visit that as well. اس کے بعد ایک اور ایویلیویشن تھی which was done by our very 3 respected judges who are into research for many years, and Mr. Shaukat Javed, Professor Aftab Mohsin and Dr. Khalid Mahmood Khan. They not only evaluated them but also interviewed and and to see how much they knew about this research. और ऐसा तो नहीं था कि किसी ने research paper कहीं से भेज दिया और उन्होंने बस छाप दिया. They had to actually know how they did it and what is the methodology, what was the sample size, and what is the novelty of the idea, why did they do it, to know how much they are into that project. और उसके मुताबिक अब research के awards के जो prizes हैं वो भी announce करेंगे. लेकिन before I tell you the names of the winners, there are two things that I am supposed to do. One is an announcement, which is another big thing that we are starting, that from next year, apart from PSIMRA awards, which are encompassing whole of the medical and allied specialities, we are now dedicating one award to the vitamin D research as well. Vitamin D Academy is also one of the brainchilds of Pakistan Society of Internal Medicine, which was also in collaboration with Pharmevo. So now next time we've decided to give vitamin D research awards, and this is that we shall be inviting the proposals and synopsis from young researchers across national medical institutes, and the selected participants, they will be given the opportunity to present their proposals in the 4th Pakistan Society of Internal Medicine conference, and top 3 selected will then be given the cash prizes, and also they will be given the research grants to complete that project. So the synopsis competition and then support in the form of completion of that project, and then they can submit their full articles and papers. So this is one step ahead, that we are holding their hands not only for giving them an opportunity to do research, but holding their hand in financially supporting them in completing their project. So I think this deserves a good round of applause for our collaborating partners, because this is the 3rd award that they are announcing in 3 years. So thank you very much for this. And in the end, I would like brief comments from the 3 judges about the quality of the research papers before I announce the winners. Mike, please.
Assalamu alaikum. We reviewed about 20 presentations, and among these 20, 17 presenters were there, 3 were absent, and one of them have sent his representative there. Jitne bhi paper the, all were excellent. However, among these, we have selected first 3, 1, 2, 3 position, and luckily, हम तीनों ने अपना अपना अलहदा रिजल्ट बनाया, and at the end, result was same. तीनों का unanimous result था. So I would like further comment from Shaukat Saab.
Dr. Aftab Mohsin for his comments, please.
The research work presented was excellent. The enthusiasm was also very high, and it was a treat to evaluate these 20 selected research papers, posters, and independently we educated. It was a criteria based on 100 marks consisting of 8 different items that we scored. And when we met 15 to 20 minutes later, the surprising thing was that the judges has reached the same conclusion for the same candidate, all 3 of them, and it was, I think, excellent, transparent method of judgment. And we had representation from all the regions, and provinces of Pakistan, and though it was difficult, 2 papers we did not give 10 score because their presenters were absent. So presentation with Mr. Shaukat Ali Javed was we nominated him to announce the result. So I'll hand over the mic to him to announce the result. Sir, please announce the result.
Okay, I would request Professor Irshad Khoso to please join us on stage to award the checks to our winners. I would also request Dr. Masood Javed, Mr. Mohsin and Mr. Atiq from FARMEVO to join us. And our very beloved President, Pakistan Society of Internal Medicine, Dr. Javed Akram.
First of all, I would like to thank Pakistan Society of Internal Medicine, its president, the whole executive, for tolerating me, despite what I do to them. I keep on monitoring them every time and pointing out certain things, but they are very nice, very kind to me. They keep on tolerating me. I don't know how long they are going to tolerate me, but thank you very much.
We are reaching that threshold.
So, there was an, as pointed out, see, I don't want to repeat things what the other evaluators have said, Aftab Mohsin Sahab and Khalid Mahmood Sahab. See, what we did also, some education of these presenters. Some of the deficiencies which I noted, when they present the paper and then they publish it, they make these mistakes. They were pointed out, please don't look after these deficiencies when you next time do it. So, वो भी उनकी education भी ठीक था. So, to start with, there was an excellent presentation. And we all were so delighted to select her, and I would like to announce the name. Dr. Ramsha Habibullah Mangro from JPMC Karachi. Then for the prize for the budding physicians, the third prize goes to Dr. Hifza, is resident from Internal Medicine, Khan University Hospital, Karachi.
बिलाल लिशारी साहब इधर आ जाइए, आपने ही देना ये. सर प्लीज कम ओवर. लिशारी साहब, सॉरी नवाब, नवाज लिशारी साहब.
Dr. Huzaifa, resident Internal Medicine, Khan University Hospital, Karachi. Third prize. Second prize goes to Dr. Durkho Atif, resident Internal Medicine, Khyber Teaching Hospital, Peshawar.
Bikaram sahab will hand over.
Professor Bikaram.
Bikaram sahab Devgaran Jani. नहीं सिर्फ जानी काफी है. देर वो लेकिन वो कहते हैं. माशाल्लाह देने के लिए आए. उनको आने देने के लिए आए.
जी खैबर टीचिंग हॉस्पिटल में.
The second prize for budding physician. The third prize was worth 50,000 rupees. Second prize was worth 1 lakh rupees. The first prize for the budding physician, 1,50,000 rupees, and the winner is Dr. Saima Kazmi, resident Internal Medicine, Indus Hospital, Karachi. Professor Feroz Mehman, I will request him. Professor Feroz Mehman is Professor of Cardiology
माशाल्लाह, वेल डन, वेल डन. आपको सिक्योरिटी गार्ड की भी ज़रूरत पड़नी है, वो भी खास. आ रहे हैं बारिश का बात, वो भी देंगे कुछ ना कुछ.
Now for the emerging physician category, the third prize goes to Dr. Iram Amir, Assistant Professor Psychiatry, King Edward Medical University, Lahore. कौन? अच्छा, कौन के किंग एडवर्ड?
नहीं तो वो देंगे ना.
प्रोफेसर इकबाल आफरीदी, उनको बुलाएं जी. यस,
हाँ जी,
साइकाइट्रिस्ट बैठे हैं.
उनसे हैंड ओवर. Yes, I am from King Edward. I am a proud Cambodian.
वो कहाँ गई थी?
चलो ले लो, लेकिन दे देना आगे.
This prize is for Dr. Iram Amir, Assistant Professor Psychiatry, King Edward Medical University. उनके बिहाफ पे सोमिया इक़दार वसूल कर रही हैं. 50,000 rupees. The second prize goes to Dr. Anan Arshad, Assistant Professor Internal Medicine, Aga Khan University. Can we request Professor Abdul Basit, please do us this honor.
साथ वादा ले लो सारे शरोजा भाई चिल्ला रहे हैं सरोजा में सरोजा जाना है भाई.
सर ये आपने अच्छा नहीं किया, फर्स्ट का डिसाइड ही नहीं किया.
तो फर्स्ट वो अपने आप को देना चाहते हैं. Thank you so much.
And the first prize for this emerging physician goes to Dr. Saima Askari, Assistant Professor Endocrinology, Bakai Institute of Diabetes and Endocrinology. Dr. Saima Askari.
Professor Shahzad, Vice Chancellor.
Professor Shahzad, please do us this honor. Professor Shahzad Ali Khan, Vice Chancellor, Health Services Academy.
MashaAllah. Public Health Guru.
This prize is worth 1,50,000 rupees.
Oh, MashaAllah. Party.
Thank you very much. Thank you very much all. Thank you very much. God bless you.
Thank you very much. I'm now going to request Mr. Mohsen Shiraz, Deputy Director Marketing Farmevo, to please present the vote of thanks.
Bismillahirrahmanirrahim. On the behalf of Farmevo, I would like to thank PSIM officials and Executive Committee, and also thanks for providing an opportunity to initiate this program with the PSIM. I would like also thanks to the participants who actually participate in this PSIMRA award. And in the end, inshallah, we'll continue this effort and we'll bring more projects like this. Thank you very much. Bismillah.
Okay, so we will be shortly starting our fellowship award ceremony. The fellows are requested to move to hall, just adjacent to this hall, for the robing ceremony. And all the respected guests are kindly asked, please be seated over here, but we need to evacuate this second row for the fellows. So if you could kindly move to a row behind the second row. First row is for the dignitaries and second row we were evacuating for them. Okay. So the second row for the fellows, please. All the people who are being awarded fellowship this time, they are requested to move to the hall for the robing ceremony. Thank you very much.